We welcome you to our first regional kidney cancer symposium, the Judy Nicholson Kidney Cancer Foundation. My name is Linda Ostoski. I'm president of the foundation. And today we have many great presenters and speakers from all around the country. And today we are here for you. We are here to celebrate you and your caregivers. I know you've all been through a journey, and many of you, it was a journey to even come here. And we really thank you for that. We are going to try to stay on schedule. We had a few changes, like Joel Stern. He was supposed to introduce the speakers this morning. He was unable to attend. He was not feeling well, but thank goodness he's feeling a lot better right now. And Dr. Masouel, his wife just had a baby, so he will not be here, but he'll be here digitally. And Dr. Pili will not be here, but he will be here also digitally. So I really thank you for coming and enjoy yourself. And you know, we are here to give, care, and share, and give hope. And that's our inspiration for today. There's always hope. So let's begin. So we have first is Dr. Jaime from the University of Miami. He will be speaking about my kidney cancer diagnosis. He has to leave a little bit early today, so there will be a few questions and answers after his presentation. And then each other speaker will speak, but we'll have a session for panel discussion with the doctors when you'll be able to ask them questions and they can answer anything. Okay, so let's begin.
Good morning, everybody. First, I would like to thank the Judy Nicholson Kidney Cancer Foundation for this nice invitation. I love to participate in the Judy Nicholson events. We have done this in several parts of the country. We have been doing this in Miami every year, both in person and digitally, and it is a very enriching experience. So today I'm going to talk to you about what I call Kidney Cancer 101, right, for patients. And we will be talking about the diagnosis of kidney cancer, what is kidney cancer, and what do the doctors do to understand your kidney cancer better, okay, in order to design the best treatments that are the most appropriate for each patient. I'm Dr. Jaime Merchan, and I am a medical oncologist at the University of Miami and the Sylvester Comprehensive Cancer Center in Miami, Florida, and my specialty is renal cell carcinoma. So before we talk about kidney cancer, let's talk a little bit about the kidneys. What are the kidneys, right? They are very, very important organs. We have two of them, the size of a fist, which are located in the abdominal wall, in the back part or in the posterior part of the abdominal wall called the retroperitoneum. And they are located in each side of the spine, okay? And the function of the kidneys is to filter blood, to remove impurities, to remove excess salt, minerals, and also to balance water levels. And they are essential for life. Without kidneys, we would only live if we have dialysis. The kidneys also produce hormones that are very important for our lives. For example, hormones that control red blood cell production. Okay, this hormone is called erythropoietin, and also hormones that help control the blood pressure. They are highly vascularized, meaning that there's a lot of blood vessels, and basically what we see here is there's the renal artery that brings the blood in, and the renal vein, which basically brings the blood out of the kidney. And it is possible in some cases, in most of the cases, to live normally with only one kidney. Like if a patient is born only with one kidney or a patient has kidney surgery, they can live a normal life as long as they don't have other medical conditions that affect the remaining kidney. Okay? And just as a kind of like some facts about the kidneys, the kidneys filter all the blood in our bodies about 60 times every day, right? And these is about 50 gallons of liquid that are filtered through the kidneys. And they produce, depending obviously on the amount of water we take, up to 1 gallon of urine. What is kidney cancer? Kidney cancer is a malignant growth that starts in the kidneys. Okay? And there are several different types of cancers of the kidney. The most common type is one that we call renal cell carcinoma, or RCC. Just to get an idea of the magnitude of kidney cancer, in the US in 2022, it is expected that about 79 new cases of cancers of the kidney will be diagnosed, and about 14,000 Americans will die from this disease. Symptoms, most of the patients do not have symptoms, and the tumors are discovered incidentally by an ultrasound that are done to rule out gallstones, for example, or abdominal pain, and they find a tumor in the kidney. But for those patients who have symptoms, some of the common symptoms include blood in the urine, back pain, low appetite, as well as weight loss. Unfortunately, there are no effective screening methods to detect kidney cancer. Okay? And also, as a fact, up to 1/3 of patients who have kidney cancer that is localized and undergo surgery, okay, there's a high risk of the cancer coming back. So it is a serious disease. Now, many patients ask me, like, doctor, how did I develop kidney cancer? How did the cancer form? And this is an interesting and complicated story, okay? The cause of kidney cancer in most of the cases is unknown. However, kidney cancer begins with alterations in the genes or in the DNA of the normal kidney cells, okay? We call these gene alterations, we call mutations. And then the mutations accumulate, and the normal kidney cell becomes a cancer cell. A cancer cell is called cancer cell because they have the ability to reproduce without control, they resist to die, and then they also have the capacity to expand and to invade. So due to the mutations in the DNA of the normal kidney cells, or mutations in different genes, the normal cell goes the wrong way, and it becomes a cancer cell that starts growing and proliferating. So from normal tissues, okay, there are a few cancer cells that form, and then they multiply, they form a small tumor, and the small tumor keeps growing, okay? Now, the process of a normal kidney cell to form or to develop into a cancer cell does not occur overnight, or even in months. It may take years for this process of what we call oncogenesis, for the process of malignant development. It can take years. And then once the transformation occurs from normal to kidney cancer cells, the process of the tumors growing and metastasizing sometimes can be faster, and it depends on the behavior, on the biology of the tumor. So once the tumor grows to a large enough size, it can invade different parts of the kidney, and also it can start spreading by going to the circulation. So some of the kidney cancer cells escape, go to the blood vessels, remember the renal vein, and then they can spread to different sites. Another important aspect in kidney cancer, okay, is that kidney cancers need blood vessels in order to grow, in order to survive. And this is one of the important findings in science, where it has been discovered that kidney cancer depends a lot on blood vessels. And also, we know that kidney cancer is an immunogenic disease, meaning that the immune system and the tumor microenvironment are very important. And the discovery of these properties of kidney cancer has allowed scientists and investigators to develop treatments against kidney cancer that are targeting the tumor blood vessels and the tumor immune responses. So all this process of a normal kidney cell transforming into a kidney cancer cell, growing, expanding, invading, and then spreading can lead to metastatic kidney cancer. And the kidney cancer can go anywhere in the body. It is one of the tumors that has no boundaries. It can go everywhere from head to toe. The most common sites of metastasis include the lungs, liver, bones, as well as other organs like brain or pancreas. Now, as I said, most of the cases of kidney cancer, we cannot explain a specific cause. There are some exceptions. For example, there are cases where we see patients with hereditary forms of kidney cancer. And there are several well-established hereditary conditions that are associated with kidney cancer. For example, VHL syndrome or von Hippel-Lindau syndrome, and other hereditary kidney cancer syndromes like Brit-Hogg-Dubé syndrome, tuberous sclerosis, Cowden syndrome, etc. These are very rare. However, I think most of the doctors who have seen kidney cancer patients have had several cases of those. Okay? There are also external factors, not hereditary factors, but external or environmental factors that are associated with kidney cancer that may be responsible for some of these gene mutations that lead to kidney cancer development. One of the most important ones is smoking. Okay, and other factors can include obesity, high blood pressure. We talk about family history, and also exposure to chemicals and toxins, as well as gender and race in some cases. Another important thing to understand is that not all kidney cancers are the same. Okay? There are multiple and different subtypes of kidney cancer. The topic of this discussion, as I said, is renal cell carcinoma, or RCC, which starts in the kidney tissue, like in the cortex and the medulla of the kidney. And there are many, many types of renal cell carcinoma, but the most common include clear cell kidney cancer, which occurs in about 3/4 of the cases. Then papillary kidney cancer, which there are two types, and all of them are about 15%, and less common forms like chromophobe kidney cancer or oncocytoma. But there are many other forms that are less common, probably 1% or less. For example, there's one form of kidney cancer called translocation renal cell carcinoma, medullary renal cell carcinoma, which occurs in a specific group of patients with a sickle cell trait. There are renal cell carcinomas that are associated with a specific deficiency in some metabolic genes, unclassified, and the more you read, and in 2022, there may be more than 20 or 30 different subtypes of renal cell carcinoma. But there are other types of cancers that occur in the kidney. Okay? The other big portion of the kidney, in addition to the kidney tissue, is the pelvis of the kidney, which is this yellow cone which collects the urine before it brings it to the ureter and then to the bladder. Cancer of the pelvis of the kidney is one type of cancer that is more similar to bladder cancer. We call it urothelial carcinoma. Okay? And it should not be confused with renal cell carcinoma because the biology and the treatments are very different. And there are other less common forms of cancer of the kidney, including lymphomas or sarcomas, very rare, also neuroendocrine tumors. Now, once we or a physician discovers a mass in the kidney, okay, that is suspicious of kidney cancer, what is the next step? What do we do next? So patients come to the doctors, okay? Patients are obviously very anxious, and the doctor's job is to try to calm the patients down, explain very objectively, okay? And in order to explain very objectively, we all need to understand the magnitude of the cancer, okay? And this is basically why we use the term called staging, which is figuring out how advanced the cancer is, okay? And why is staging important? Staging is important because it will help doctors and the medical team decide on what would be the best treatment, and also to give some information about the prognosis of the kidney cancer that one patient has, okay? And in order to do staging, we use a system with 3 letters called T and M, okay? And T stands for the tumor, the primary tumor, which basically describes the size and the extension of the tumor inside the kidney. N stands for lymph nodes, presence or absence of lymph nodes. And finally, the M stands for metastasis, which is whether the tumor has spread outside of the kidney or not, okay? And then when we have information of all these 3 letters, T, N, and M, we do different combinations based on specific cases, right? Combinations of T, N, and M. And from these 3-letter combinations, we can bring to a stage, right? And the stages are the result of this analysis of the T, N, and M combinations. And there are 4 stages in kidney cancer: stage 1, 2, 3, and 4. How do we stage? Okay, what procedures do doctors do in order to stage the patients, okay? And the staging can be done both using non-invasive methods, okay? I will talk a little bit later about the importance of having a pathological diagnosis, but it can be done via non-invasive methods like scans, for example. And when we do that, for example, if we have a patient who had a kidney surgery with kidney cancer 4 years ago, and now the patient presents with multiple sites of metastasis, and a biopsy was done to confirm, then we do, for example, scans in order to see whether the tumors are in the lung, in the livers, and then that will help us stage the patient. And also staging is done pathologically, especially in patients who have localized kidney tumors, and they are removed by the urologist, okay? And then we get a very, very detailed pathological information on the type of kidney cancer, the extent of kidney cancer, okay? Whether lymph nodes or not were removed or not, so we will have a good information that will help us fill the blanks in the T, N, and M, okay? So the imaging studies that we use, or the radiological studies that we use to do the staging, can include a CT scan or an MRI scan, okay, as well as bone scans. PET scans can be useful sometimes. I personally do not use PET CT scans a lot in renal cell carcinoma because sometimes we can get false negative results, okay? If a doctor suspects stage 4 disease, the diagnosis, and if patient has no diagnosis, the doctor may recommend to do a biopsy of one of the metastatic lesions. For example, if there's a lesion in the liver, or in the lung, or in the lymph node, the doctor will refer the patient to a radiologist to do a special needle biopsy in order to make a diagnosis, okay? And if the doctors think that the tumor is localized to the kidney, all right, in most of the cases, the doctor will recommend removal of the tumor by surgery. So this is a slide where we talk about the stages, okay? Stage 1, 2, and 3 are tumors that are localized to the kidney or the kidney region, meaning they have not spread. The difference between stage 1 and stage 2, which are tumors that are confined to the kidney, is the size, more or less than 7 centimeters. Okay? Stage 3 here is basically tumors that have any size that have spread a little bit beyond the kidney capsule, either to the fat surrounding the kidney or to the vessels, especially to the renal vein. And finally, stage 4 is when it goes beyond the fat to a capsule called Gerardus fascia, and also if it goes to multiple distant lymph nodes, or if it travels outside of the kidney region. This is an example in a CT scan of a tumor that is localized in the upper pole of the kidney, so this could be stage, I don't have the measurement, it could be stage 1, 2, or 3, depending on what the pathology shows. And this CT scan, we have here the long window of a CT scan that we can see several nodules, okay, that are metastatic nodules in a patient with stage 4 kidney cancer. Now, in patients who have metastatic kidney cancer or stage 4 kidney cancer, the medical oncologist will also determine other factors that are based on the clinical exam and also laboratory tests, okay? And these factors are very important, very, very important, because they will guide the doctor, they will guide the oncologist as to what the best treatment he or she can recommend to the patient, okay? It also will give important information about the prognosis of a particular case of stage 4 kidney cancer. And these factors are summarized in this slide. We call them the IMDC criteria, okay? International Metastatic Renal Cell Carcinoma Database Consortium. And these are basically 6 factors. Some of them are clinical or by history. For example, if there's the time from the initial diagnosis to the need of treatment, more or less than 1 year, the performance status, okay, which is how well the patients are doing functionally, and then laboratory tests, like whether the patient has anemia or not, the calcium level in the blood, platelet levels, and the neutrophils, which are a subset of white blood cells. So we, in patients with stage 4 kidney cancer, oncologists always check that. And then we get the results, and then we can, depending on how many points the patients have, okay, we can categorize each of the cases of stage 4 kidney cancer into 3 groups, okay? One group is called favorable risk, when they have none of these points, intermediate risk with 1 or 2 of these points, or poor risk if they have 3 or more, okay? And again, this determination occurs for patients with metastatic renal cell carcinoma, and it is very, very important for the doctors to understand the nature, the biology of the tumor, to determine prognosis and to guide on the best treatment. Okay? So the diagnosis and the staging and the management of kidney cancer is a team effort, okay? And that is one important take-home message that I would like to share with you. It is not only one doctor who is the hero in this story, okay? There are multiple different doctors and team members who are critical in the care of patients with kidney cancer. And they include the urologist, who is the doctor who the patients are referred initially to with a kidney mass, and they perform surgery if necessary. Then we have the pathologist who makes the diagnosis as to see what the subtype of kidney cancer there is. Radiologist who analyzes the scans, and sometimes they put a needle to do a biopsy of a lesion. Okay? The medical oncologist who determines whether a patient needs systemic therapy or not. Pharmacist, okay, who helps prepare the treatments prescribed by the oncologist. Nurses who are critical, okay, are incredible, and they really take the patient by the hand through their journey of kidney cancer, okay? And many other doctors, for example, radiation oncologists who give radiation if needed, pain specialists, palliative care doctors, social workers, PCPs, psychology, psychiatrists, nutritionists, physical therapists, etc. So it is a big team effort in order to provide the best care for patients with kidney cancer. So the stage of the disease guides the treatment, and that's why it's so important to determine the stage by all the procedures that we discussed in the prior slides. In patients with stage 1, 2, and 3 kidney cancers, okay, if patients don't have any significant medical conditions that may prohibit surgery, in most of the cases they are recommended surgery, okay? And some patients who are determined to have high risk after removing the tumor may be recommended what we call adjuvant therapy, which is some form of treatments, especially immunotherapies that are some of them are approved now, okay? Now, in patients with stage 4 disease, the first thing we do is we determine whether they are a favorable risk, intermediate risk, or poor risk, okay? And then depending on that, we decide on the best treatment. And finally, this is just like a preface of the next talks that you will hear. This is kind of like a historical roadmap of the treatment for kidney cancer, okay? And I'm not gonna go into details of this, but I want you guys just to look at the progress that has been made over the years since the early 1990s, especially after 2015, where a large number of treatment options have come and have become available to patients and physicians. And all of this is only possible due to research, to cancer research, right? I think I am proud to say that a lot of people who do kidney cancer research, we know each other in most of the cases, and we work together with each other. And that's why and how it has allowed us to really make progress and help patients. So, and just to finish my talk today, there is hope, and there will be hope. This is the topic of today's event. And if you can see here, all the treatments, and then there are probably many, many more treatments that are upcoming and probably will become a reality in order to hopefully find cures for kidney cancer. I would like to thank you very much, and I hope you enjoyed the rest of the presentation. Thanks.
Good afternoon from Houston. My name is Pavlos Masouel. I'm an assistant professor at the departments of genitourinary medical oncology and translational molecular pathology at MD Anderson. Apologies I could not be there with you all in person, but I would like to sincerely thank the organizing committee for inviting me to talk on rare kidney cancers. These are my disclosures. Pertinent to this presentation is that I have served on advisory board committees with BMS and Exelixis and have done non-branded educational programs for Exelixis and Pfizer, whose products will be among those discussed today. Now, as shown in this slide, when we say kidney cancer, we refer to multiple diverse diseases. Clear cell renal cell carcinoma is the most common histology found in approximately 75% of all cases. However, the remaining 25% is comprised of a diverse range of subtypes under the umbrella term non-clear cell kidney cancer. Each of these subtypes has different prognosis, different molecular features, and different responses to different treatments. Now, these are some key rare kidney cancer subtypes shown here. However, we should be mindful of the simple fact that each individual patient we see in the clinic has the most rare disease in the world. Only he or she has it. And thus, the frameworks we develop to help patients with so-called rare kidney cancers can actually help all patients with cancer. Every patient can be helped. Shown here is the tremendous progress achieved in the past 15 years with multiple powerful new therapies approved by the FDA for clear cell kidney cancer, the most common type of kidney cancer. Now, this includes targeted therapies, immunotherapies, and their various combinations. Of note, however, all these approvals were based predominantly, or in many cases exclusively, on data from trials done in clear cell kidney cancer and not the other histologies. Now, to understand a little bit how to tackle and how to think about rare kidney diseases, we can think about what we call the relevance-robustness trade-off. And we can say that bias, when we think of the term bias, is the opposite of patient relevance. And we can either use the term bias or patient relevance. They measure the same thing, but in opposite direction. And the relevance is what measures the truth about our patients that we see in clinic. It answers the question, is my inference true for my patient? And as shown here, the longer the distance between what we're estimating when we do a study or when we're thinking about a patient and the truth, the higher the bias and thus the lower the patient relevance. And then there's another term called variance that we use in medicine, and that is the opposite of what we call robustness at the population level in our estimates. They again measure the same thing, but in opposite directions. Robustness is what measures the degree of what we call random error in our estimates, and it thus answers the question, how close to each other are our data from a group of patients? Now, what we call traditional confidence intervals are a measure of this robustness, and the higher the robustness, the more narrow our confidence intervals. And the key thing here is that there will always be a trade-off between patient relevance and robustness in our inferences. Always. Less flexible statistical models will have lower patient relevance but high robustness, whereas more flexible models will have high patient relevance but lower robustness. And the key task is always to find the sweet spots that best balance patient relevance with robustness. And Kelly Liu and Zhao Meng published in 2016 a brilliant article that starts from first principles and naturally builds up all the schools of data analysis inference while trying to answer the question, how should we treat a specific patient we see in clinic? Perfect robustness would be to just randomize everything. And if we do that, then we don't need to think about potential confounders or other aspects of, the underlying causal network. However, despite what some people think, randomizing certainly does not balance our patients. It is another process known as conditioning, shown here, that actually balances our patients. And this is why we cannot randomize our clinical decisions. We don't just flip a coin when we make decisions for a specific patient we see in clinic, whether they have a common kidney cancer or a rare one. Randomization inference is a very powerful tool that was originally developed in the early 20th century to optimize agricultural crops, and it has a lot of value in medicine. But we have to always remember that our patients in clinic are not plants. And so, on the other hand, perfect patient relevance would be achieved if we knew every single thing about our patient in clinic, their biology, their environment, their goals and values, even the Krebs cycle. But this is unattainable in practice, which is why there will always be a trade-off between relevance and robustness. And so before we start thinking about rare kidney cancers, or common ones as well, we need to understand the first law of data analysis. So here is a question that I ask our hematology-oncology trainees to answer during my course on data analysis at MD Anderson. There's no trick to this question. It applies to all kinds of studies, experimental, observational, randomized clinical trials, anything. And the question is, as the number of patients enrolled in a clinical trial increases, the probability that the confidence intervals of the trial results will include the truth? What is that probability? Does it increase? Does it decrease? Does it remain the same? Or I have no idea. I'll give you guys a few seconds to think about it. This applies to everything. This is the first law of data analysis. We increase the number of patients we enroll in a study. What happens to our chances that we will include the truth in our estimate? So when I ask this question of people, about 70% typically answer that the larger the sample size, the higher the probability that our uncertainty estimates, like the confidence intervals, will include the truth. Only 5% typically answer that the probability increases. 18% are more savvy and answer that it remains the same, whereas a few do not feel that they know the answer. But the correct answer is that paradoxically, and very counterintuitively, clearly, as the size of a study increases, the probability that its confidence intervals will include the truth decreases. That's crazy, isn't it? So the reason why this happens is the relevance robustness trade-off. Let's say that we want to find the truth that is shown here. But this truth is always beyond our senses, which is why we have to create models of the truth. But these models will inevitably always contain bias represented here as the distance from the model to the truth. And when we do studies with small sample sizes, then we obtain wide confidence intervals that are likely to include the truth as shown here. But the more we increase our sample size, the more our confidence intervals will narrow and thus be less likely to include the truth we're interested in. Thus, studies with large sample size can yield misleadingly narrow confidence intervals around heavily biased results. This applies to any cancer, whether common or rare, and whether it's kidney cancer or anything else. And it is not just physicians that get this wrong. Because large quantities of data are now available to researchers, this phenomenon has been labeled the big data paradox. And it is actually a major reason behind the unreliable predictions made from the 2016 United States general election polling datasets. And Nature, one of the most prominent academic journals, published just a few months ago another instance of the big data paradox, whereby Delphi Facebook, the largest public health survey ever conducted in the United States to date, completely mispredicted the COVID-19 vaccine uptake in the US. And because the big data paradox is fundamental to the way we interact with reality, it was also recently shown to occur even in data sets from particle physics experiments, such as the Large Hadron Collider. Now, to address the big data paradox, we utilize three different non-mutually exclusive remedies. As shown here, when the sample size of a randomized control trial or any other experiment or observation is small, then the corresponding wide confidence intervals may include the true value of interest. However, as the sample size increases, the quality of the gathered data may decrease, and this can be addressed by maintaining high data quality throughout the study. And towards this goal, our department has adapted MD Anderson's Prometheus informatics system to focus exactly on data quality by providing more details on the origins of the data used in the analysis, including the steps involved in data selection, pre-processing, curation, and provenance. The second mechanism occurs because as the sample size increases, the heterogeneity of the patients may also increase, resulting in both increased bias and what we call increased irreducible error, even if the quality of the data remains consistently high throughout the study. And this can be addressed by both anticipating and modeling patient heterogeneity before and during data collection. This is exactly why we introduced the field of structural causal modeling to oncology, and why we carefully collect correlative blood and tissue samples from our patients to be used for fundamental, basic, and translational research. The last mechanism occurs because as the sample size increases, the standard error shrinks, and the total error of the parameter that we're interested in is mainly due to what we call irreducible error and bias. This occurs even if the enrolled patient cohort is highly homogeneous, and even if data quality remains consistently high throughout the study. And our informatics teams are addressing this via the use of error intervals that represent the reducible error due to both bias and standard error. But at the same time, we also maintain epistemic humility, because there will always exist some degree of irreducible error that cannot be accurately represented by any data analysis. And these frameworks were actually developed to tackle renal medullary carcinoma, abbreviated as RMC, which predominantly afflicts young individuals of African descent. We have used these solutions to the big data paradox to generate scientifically relevant and robust knowledge. And now you understand what that is, which in turn has spurred academic interest and funding. The same thing can be done for other rare and common kidney cancers, And in addition, we're also utilizing patient advocacy and support groups, social media, as well as state and federal activism to raise awareness of and support patients with RMC. And our uniting goal is to eradicate this horrible disease, and similar patient advocacy efforts can be developed across different kidney cancer subtypes. That's the main message that I wanted to convey today. Now, let's now dive deeper into our current knowledge of rare kidney cancers. Broadly speaking, there are 4 types of what we call systemic therapies used for the treatment of kidney cancers. The first is cytokine therapies, to which the rare kidney cancers do not typically respond well. The second is what we call targeted agents. The third is the immune checkpoint immunotherapies that harness the body's immune system to recognize and kill cancer cells, as well as the last one being classic old school chemotherapy. Now, how to choose between the last 3 treatment options will depend on the exact type of kidney cancer each patient has. This is why it is so important to properly diagnose the kidney cancer subtype of each patient. Now, many kidney cancers listed here are resistant to standard chemotherapy, but are potentially sensitive to the targeted therapies used for the treatment of the more common clear cell kidney cancer. On the other hand, some kidney cancers listed here are actually sensitive to chemotherapy, but are resistant to most or all of the targeted therapies used for clear cell kidney cancer. And in addition, renal cell carcinomas with sarcomatoid differentiation may sometimes respond to chemotherapy in combination with targeted agents. Now, targeted therapies, which usually come in the form of pills, are reasonable options for many rare kidney cancers. Of those agents, cabozantinib is preferable for papillary kidney cancer. Temsirolimus can be considered for poor-risk kidney cancer in the absence of other options. And furthermore, bevacizumab plus everolimus is another reasonable targeted therapy option, particularly for tumors with papillary features. And by studying their immune microenvironment, we can discern the following scenarios for different kidney cancers. For clear cell kidney cancer, the most common one, the immune cells are already infiltrating the tumor, but the immune cells need to be activated, for example, by immunotherapy. For papillary kidney cancers, we need to both bring more and activate the anti-tumor immune cells, whereas chromophobe kidney cancers have very few immune cells, and thus the first task will be to bring the immune cells in these tumors. Renal medullary carcinoma and collecting duct carcinoma contain a lot of cells, but that can inhibit immunity. It is therefore prudent to try and remove these cells before activating the anti-tumor immune cells. Now, because chromophobe kidney cancers are so much more immunologically cold tumors than papillary kidney cancers, the clinical responses of chromophobe kidney cancers to immunotherapy is very attenuated, as shown here. And moving on to specific therapies that we can use for distinct subtypes outside of clinical trials, here are a few recommended strategies for papillary kidney cancer. Cabozantinib is the preferred first standard of care therapy for papillary kidney cancer. And as shown on the previous slide, we can also use immunotherapy because it can produce responses, although less frequently than clear cell kidney cancer. And there are other targeted therapy options that can be used as second or third line regimens. And molecular testing may reveal targetable alterations to drugs such as alectinib or crizotinib. For chromophobe kidney cancer, we often favor surgery or surgical resection of the metastatic disease, even if it is in the liver, because chromophobe kidney cancer is more likely than other kidney cancers to spread to the liver early. Because chromophobe kidney cancers are generally resistant to immunotherapy and to targeted agents, we really push for surgery and or radiation whenever possible. Otherwise, we can use targeted agents, and immunotherapy may also be considered if no other options are available. Now, translocation kidney cancer is the most common kidney cancer in children and young adults in the US, but it may be tough to recognize because it often mimics the appearance of other kidney cancer subtypes. And so think of translocation kidney cancer whenever you encounter a tumor that seems more like a mix of clear cell and papillary subtypes in young patients, especially women who have a history of chemotherapy during childhood for malignancies, autoimmune disorders, or bone marrow transplant. And there are multiple subtypes of this disease. The most common is TFE3 translocation, whereas TFE-B translocation is less common, but often has better prognosis. And we're now finding out that some kidney cancers, particularly in older adults, may be due to TFE-B amplification and not translocation. Now, the management of translocation kidney cancer is challenging because these tumors are often resistant to all therapies, but we often start with immunotherapies, which produce responses in about 20% of cases, or we can try targeted agents such as sunitinib or cabozantinib. And because translocation kidney cancers can often be driven by the TFE3 mTOR pathway, mTOR inhibitors are a reasonable option here, and this can include the combination of lenvatinib with everolimus. Now, kidney cancers with fumarate hydratase deficiency can be due to either germline mutations or less commonly due to sporadic mutations in the fumarate hydratase F8 gene. And it is the most aggressive variant of papillary type 2 kidney cancer and is characterized by metabolic deregulation and a shift to a dependence on glucose for its energy needs. And the distinct metabolic profile of these F8 deficient kidney cancers makes them particularly vulnerable to the combination of bevacizumab with erlotinib, which impairs glucose metabolism. And this combination is thus an excellent first-line therapy for this disease, but also targeted agents such as cabozantinib can also produce good responses in these tumors. There is less experience with immunotherapies. In our institutional experience at MD Anderson, while F8 deficient kidney cancers can sometimes respond to immune checkpoint therapies, they're less likely to do so than other malignancies. And I thus recommend at least trying bevacizumab plus erlotinib or even cabozantinib before considering immune checkpoint therapies, particularly in patients with aggressive disease that needs to be quickly cooled down. Renal medullary carcinoma, abbreviated as RMC, predominantly affects young African Americans with sickle cell trait or other sickle hemoglobinopathies. It is more common in men and 3 times more likely to arise from the right kidney compared with the left. And all cases are characterized by loss of the SMARCB1 tumor suppressor, also known as INI1. In rare cases, it may be found in people who don't have sickle hemoglobinopathies, and high-intensity exercise, but not moderate intensity exercise, may be associated with the development of RMC among individuals with sickle cell trait. And RMC does not generally respond to the targeted agents or immunotherapies commonly used against clear cell kidney cancer. And because of how aggressive RMC is, we almost never do surgery first to remove the kidney, even if we don't see any metastatic disease. We start first with chemotherapy to cool down the disease, and then only remove the kidney after 4 to 6 cycles, at least, chemotherapy. And the preferred first chemotherapy is platinum-based chemotherapy, particularly carboplatin plus paclitaxel, and recently published data support the use of gemcitabine plus doxorubicin as a second-line therapy for RMC. And now we know that EGFR inhibition with erlotinib can be used as a third-line option because it can produce responses even in heavily pretreated patients. Never use anti-VEGF TKIs or conventional immune checkpoint inhibitors. They do not generally work against RMC. Collecting duct carcinoma is another highly aggressive high-grade adenocarcinoma arising from the renal medulla, but it is usually found in older patients than RMC. And we're now realizing that collecting duct carcinoma is a diagnosis of exclusion. It is actually much less common than other types of kidney cancer, such as RMC. And so many cases diagnosed as collecting duct carcinoma are actually RMC or other cancers, such as those shown here. Now, collecting duct carcinoma shares some similarities with RMC, but it may be responsive to cabozantinib, whereas RMC is not. Collecting duct carcinoma can respond to platinum-based chemotherapy regimens, and the addition of bevacizumab may further improve outcomes. The role of immunotherapy remains to be defined, and in heavily pretreated patients, there are case reports of response to HER2-targeted agents, as almost half of collecting duct carcinoma tumors demonstrate HER2 amplification. The last one is unclassified kidney cancers that are, as expected, very heterogeneous clinically and molecularly. The aggressive types often have mutations in genes such as NF2, SETD2, and other pathways. The number one goal here is to try and classify these tumors as much as we can, by sending pathology slides for review at a tertiary academic center, by looking for clues from the patient's history, family history, or any other clues from the labs and physical exam. And here we may try regimens such as immune checkpoint therapies or targeted agents based on context. In summary, although most non-clear cell kidney cancers are resistant to standard chemotherapy, it is the preferred therapy for certain rare subtypes, such as RMC. Similarly, some subtypes are resistant to targeted therapies and to immune checkpoint therapies, and therefore, knowing which kidney cancer subtype we're treating is key. And we urgently need novel biology-driven, target-specific clinical trials for rare renal cell carcinoma subtypes. Do not be discouraged by their rarity. As I explained, due to the big data paradox, research and patient-centered inferences are quite feasible for rare kidney cancers. And the lessons learned from rare kidney cancers such as RMC can help patients who have both rare and common diseases. Thank you very much for your attention. My contact information is shown on this slide, and I will be happy to answer electronically any questions you may have.
All right, thank you very much. So I always enjoy Dr. Masouel's talks. I always find they're very chock full of very pressing information, but it does take me a bit of time to absorb them. But they are, he's just on another level. He's an extremely bright individual, but I always enjoy his talks. So I'm going to sort of take a little bit of that mental strain off my own head and yours a bit. I'm a surgeon, so we're not quite as bright. So that'll be good for us. I'm going to talk a bit about current advances, and I kind of limited it to surgical management. A lot of our speakers are going to talk about sort of more advanced disease, and a lot of that comes down to systemic therapy and other adjuncts, bone health, palliative care. Dr. Mashan laid a nice foundation for, I think, many of the talks talking about the different stages. So I'm going to talk more about the earlier stage disease and a bit what we've done from a surgical point of view in those patients, which I think has been a bit of an unheralded success story as far as how we do with kidney cancer. So I'm going to talk a bit about that. I don't have any sort of pharmaceutical or industry-related disclosures. I am on the board of directors for the Judy Nicholson Foundation. I will state that there are some pictures and videos later in the talk that if some of you are a bit squeamish, you may want to sort of avert your eyes for that. I think medicine used to be very patriarchal. It's less so now, and with that comes more information. And I think some patients have more inquisition as to what goes on with surgery or treatment. So I'm going to provide you a little bit of insight in that, but with that comes some of the nitty-gritty with it. So we're going to talk a little bit about the surgical management of these localized kidney cancers, a little bit about the technical aspects. There are a lot of different ways we can do the surgery for these treatments. And I'm going to talk a little bit about how we're getting better. Small, nuanced ways we approach the same operation that's been around for decades now, and how we're trying to fine-tune it to get better outcomes for patients. I'm going to talk primarily about localized disease. One of our other speakers, Dr. Masters, is going to talk about sort of more advanced disease where the surgical complexities are greater. And one of the interesting things about that, I think, that he'll highlight is, it really is a team approach. And I think Dr. Mashan also alluded to that earlier. I think that's one of the nice things about working as these bases. It is a team-based approach. So you can see, these are very common cancers, as many of you are probably here know. And it's increasing over time. When we look at the survival of these patients, I think in patients who have localized disease, we've been, say, fortuitous in the sense that our treatments are very effective. Metastatic disease, those numbers are 12 years old as far as metastatic disease. That has improved significantly, and it continues to improve, and it's probably where most of our research and most of our efforts go to improve patient care, because these are the patients who have the worst disease and so need the most treatment, and we have the most ability to impact more patients significantly in that area. But I'm going to focus a little bit more on the localized disease for this talk. This is data from the So there we go, localized. This is data from the UK, but it's very similar in many industrialized nations. The rates of small renal masses and localized kidney cancer continue to increase, and I'd say rapidly so. Part of this came with, we're imaging people a lot more, but there is an increase that is not accounted for by that. And so as much as we sort of improve our treatments, this is going to become a bigger pressing issue in healthcare overall. So small renal masses, Dr. Hajiha is going to talk after me a bit about this and why you may choose one option over the others, and some of our other speakers are going to talk about some of these other treatments as well. Treatment options for small renal masses ranges from surveillance, where you're watching these, ablative techniques such as freezing, which is like a freeze gun here, the old standby, which is surgery, which is modified significantly from when I started my training, which I'd like to think is not that long ago, and even newer technologies such as radiation, which we never used in kidney cancer before because we said, oh well, radiation doesn't work. Well, we're finding out if you do radiation the right way, it can actually work, and we have a speaker talking about that later on today. At the end of the day, surgery is still, for these localized tumors, the most definitive and the most efficacious. So from a purely cancer killing point of view, it works the best. That said, all these things come with a cost. And so the cost with surgery is that it is the most invasive and it has the highest risk of complications. Those complications can be, things like bleeding. They can be, you go in to take out part of a kidney, you have to take out the whole kidney. You can have a leak of the urine. So there are a number of different complications you can get with surgery, and those are more common with surgery than other treatments. But overall, in the grand scheme of things, those rates are still very low. So it's still a very effective treatment, but it also has more recovery time with surgery than other treatments such as ablation or radiation may have. So how good is surgery for these lesions? When they're small, it's extremely effective, right? 98.9% of patients, that's the only treatment they're going to need for these small localized lesions. They're unlikely to ever need any other treatment. So it's I think, very satisfying for patients, but also very satisfying for physicians because, we do this one intervention, and if it goes well, these patients do extremely well long term. And so I think, that it's very satisfying. That's why a lot of us got into medicine, was to be able to help people, and this is one area where we feel like we really can. That said, this is the treatment that's most likely to impact your renal function, either you having the whole kidney removed versus a partial. When we do these surgeries, oftentimes we clamp the flow of blood into the kidney, and your kidney doesn't like that. It's used to getting lots of arterial oxygenated blood, so it can impact that. Ablative techniques, which Dr. Paz-Fumagalli is going to talk about later on, less impactful actually on your renal function. Maybe not quite as effective, but it starts to become split in hairs potentially too. So what is kidney surgery? I think it's fairly nebulous. If you ask most patients, there are a slew of what their impressions of this may be, and that's because we do this in a lot of different ways. So traditionally we did these open, but you can do them laparoscopically and robotically, and those are more common now. You can do partials versus radical, where we take out part of a kidney or the whole kidney. You can do these basically through the abdomen from in front of the kidney, or you can do what's called retroperitoneal, which is sort of from behind the kidney. So, if you add up all these different options, there's sort of 12 different ways you can attack a tumor in a kidney. Some surgeons do all of these, some surgeons do one or two of these, and there are different pros and cons to each of these. And so we'll talk a little bit about that. I will say, by and large, most small localized lesions, most patients in the US are going to have a robotic transperitoneal partial, where we go from the front with a robot, we take out part of the kidney, and we leave the rest of that kidney intact. That's probably, by and large, the most common technique that's used in this day and age in the US for small renal masses. Larger masses, traditionally, and I'd say still to this day, are most often done open, and with a open incision where we're taking out the whole kidney. And you'll see some of these, Dr. Masters will talk about this later on. There are some cases where we're using laparoscopic and robotics more commonly in these situations, but it certainly hasn't replaced open as the mainstay. So, these are different ways to approach, and those have significant impacts for patients and the recovery. And you can see that just sort of, this is what you see as a patient, right? You see the incisions, and you feel the incisions. We as surgeons see the incisions and say, oh, those look nice, but we're not the one who has to get out of bed with that incision. We're not the one who has to go about, not working or our day-to-day tasks. My wife, we had our first child about 2.5 years ago. She had a C-section. That's usually a pretty easy surgery to recover from incision-wise, but, it gives you a new appreciation when you have someone, you see the day-to-day struggles of, what those incisions can mean. So, at the top, it's rare that we have patients who have incisions this size anymore. On the top right there, you'll see that's pretty common worldwide now. You'll see these sort of open partials. We still do that to some degree, but much less common. You see the patients in the lower panels, those are patients who have had laparoscopic robotic surgery. You can imagine their recovery time is probably quicker and easier. And so if you can choose between one of these approaches and it's appropriate for your lesion, you'd probably choose the lower ones because it'd probably be a quicker recovery and be easier on you. So that's one of the things about why we choose certain approaches. So, you can do open laparoscopic or robotic. Open is for bigger masses oftentimes. This is a kind of a cute picture of the kitty cat trying to come through this cardboard box. If you've got a big, large renal mass, that's not going to come through a small incision. So, your disease, the size of the tumor can dictate what type of treatment you may get, whether it's open laparoscopic or robotic. There are patient factors, so some patients have had multiple abdominal surgeries, and so doing laparoscopic or robotic may be higher risk in those patients. Some surgeons may say you shouldn't have it done. Some surgeons will say, well, we can try it and see. That varies to some degree, and it just shows you that surgeons can also impact what treatment modalities you may be offered. We all do our training in different places, and there are some colloquialisms as to what type of treatments and the style we offer. And then cost, that's usually not one that sort of is as impactful in the United States, but certainly elsewhere in the world, particularly in areas where socialized medicine costs and cost effectiveness comes into it. So, there are people I see who have large renal masses, and, most of those, if they can be done with a minimally invasive, we'll do laparoscopic because we don't need a robot for that. And I think as a cost of the system is lower, we need to probably start thinking about that because all these costs do drive up healthcare for those of us with or without insurance. So open surgery, and these days, it tends to be reserved in the partial setting for more complex cases. Oftentimes for patients, we've heard a couple of the speakers talk about patients who have some of these syndromes. These patients often have more lesions. They'll often have surgery more than once for these lesions. And so sometimes doing it open can give us a better way of controlling that safely. There are ways you can classify how complex lesions are. So some surgeons will use what's called a nephrometry score. I would say personally I don't use that, but many surgeons do. There are different ways we can control the blood flow into the kidney, and so many surgeons feel if they do it open, they can control this time that the kidney is on clamp, or they can cool the kidney and therefore maybe decrease the risk to the remainder of that healthy kidney. And as I mentioned, multiple prior surgeries can impact, what we do. This is an instance, you can see that same incision at the top where they've packed it with ice. The idea is that if you cool the kidney, that time the metabolism of the kidney slows down, it's less susceptible to that. I'll talk a little bit more about that. So here we're going to have some pictures which are a little more vivid, so if any of you get squeamish, now's the time to avert your eyes. This is a small renal mass in the kidney, and this is basically a surgeon cutting it out. That's the defect that's left, and then this is the sort of what the kidney looked like afterwards. Most times it looks a little nicer than that at the end, but that's basically what an open partial entails. Robotic, this is by and large how we do most things currently for small renal masses, and this is sort of, it's minimally invasive, but unlike laparoscopic surgery, which I sort of use the analogy, it's like operating with your chopsticks. This is operating with your hands. There's the wristed instruments on robots. You can see the surgeon sits sort of at a console that's at the bedside, but they're not directly at the patient bedside. And it allows you this view on the bottom where you get a nice view and you can see these instruments in here. This is probably your standard partial approach in this day and age. It's a quicker recovery, and there are some benefits for surgeons as far as doing these surgeries. It decreases blood loss and things like that as well for us. So this is probably what we see most times for small renal masses in the United States. So radical versus partial, it's kind of like two heads are better than one. So this is the idea of nephron sparing. So, if you can have two kidneys, that's better than having one kidney. And by and large, that's true. That said, sometimes we overplay the benefit of partials, and we sort of sometimes throw common sense out the window. The best evidence was actually a European study that looked at, radical versus partial in patients with normal renal function. And if you look in those patients, whether you took out the whole kidney or part of it, in the long term, the risk for, end-stage renal disease or needing, say, dialysis was actually no different. So many patients, may not need a partial, but that said, many can have it with only a minimal increased risk of complications versus a radical. So, in some patients they'll have a smaller renal mass and we can do a partial, but the risk for complications may be higher. And if they're 75 or 80, maybe we're better off having a lower risk of complication and removing that kidney, particularly if they've got normal renal disease. So, these are different techniques we use, and not one technique fits all patients, and we sort of tailor that to the patient based on a number of factors. I will say, a partial is, when feasible, is generally the standard. When you start to get larger tumors, it's a little less clear, and this is where patient and disease factors start to play more into it. More advanced lesions, there's not great evidence on open versus lap versus robotic. There is plenty of publications out there, but most of these are retrospective in nature, so they weren't designed to look at this question of which one's better. People did them open and they switched and did some lap and did some robotics and looked afterwards and said, well, how do these patients do? And so there are some potentials for bias in those data. I think in certain cases, some approaches are better than others, but I think that's very tailored in these advanced settings, which one's which. So what are some of the ways we can do surgery better? One was doing laparoscopic or robotic, right? It shortens the recovery time for patients. One was doing partial nephrectomies. It sort of protects your renal function long term, particularly in patients who may have like hypertension that's not well controlled or diabetes. You probably are helping them out. Cold ischemia, this was the idea that, cooling the kidney down after you clamped it, decreased the metabolic rate. There was actually a randomized controlled trial done, or prospective trial done on this by Rodney Bro, who was a urologist in Ottawa. In patients with normal renal function, if you cool the kidney down, it actually doesn't make any difference. So you don't need to do that. We don't know if that's true in patients who have some impaired renal function going in, though. So even if, it may not seem like it's the best thing, in some cases it may be beneficial. We started using sort of computer mapping and modeling more. So you can see this here is a complex sort of tumor on the top right, and they've got a mathematical model. Most of us base our surgeries based on CT scans, which are 2D planar images, and then we kind of mentally reconstruct it. But there are different companies now that actually provide 3D modeling software to create these sort of 3D models that you can rotate around, and you can see where the blood vessels go. And so for complex cases, these can be extremely handy. Along with that, they allow for this sort of intricate map of the blood vessels going into the kidney. And we know that most people have one artery, one vein in their kidney, but those arteries split into smaller arteries that go to the different areas. And so if you dissect down on those, you can find out, the one or two arteries that go to your area of interest, and you can clamp those instead of clamping everything. And that allows for the rest of the kidney to still continuously have blood flow and not really have that impact of having a clamp on. Analogous to this is also this idea of early unclamping. So generally speaking, most surgeons, when they did these surgeries, did sort of two layers. They did a bottom layer and then a top layer. Many surgeons now either have done away with the second layer, or if they do two layers, they do their first layer and then they unclamp early. And the idea is that your ischemic time then is shorter. We can also use techniques like Firefly. So that's in the bottom right. You can see this was the picture I showed you earlier when I showed you robotics. Here they're showing that the blood flow into the mass itself is no longer there. You can still see that some of that area around the tumor does have some blood flow. So they may sort of adjust their clamps, or they may say, okay, I'll tolerate that. So these are different techniques we sort of started using to try and decrease the sort of consequences of surgery as far as the recovery time and as far as the effects on the kidney itself, to do better surgery. So I'm going to show you a video here. This is a new type of robot. It's called a single port. It's got some benefits in select cases, but it's a video we recorded on a patient of mine doing a single port for a small renal mass. And this will show you basically kind of what we see when we do these cases a bit and understand a bit about this. It's a short video, so I'm just going to play this here. You can ignore the guy talking in the background.
Okay, so in this surgery, it's a little bit different than a traditional surgery for kidneys.
All right, so this is a surgery we did. This is using a new robot. You can see the sort of view there of the patient. They're on their side, and so this is sort of one where we come from behind the kidney. It'd be nice if it played, which it did earlier. There we go. And so you're going to see there's me sitting at the side, right? So the surgeon sits at the bed at the side. This is sort of from behind the kidney. And this is sort of the sac or the durotus that Dr. Mashan talked about earlier that surrounds the kidney. So we're going to open that up and we're going to expose where the blood vessels go into the kidney and then the mass. And you're going to see basically how we do these surgeries where we take out part of the kidney. This is this single port robot. That's why we did this video. Most robotic surgeries is done with what's called a multi-port robot, where you have several incisions, but they're all very small. This one, you make a slightly bigger incision, but it's just the one incision. They tend to be about 2.5 to 4 centimeters in size, the incision. This one here would come from behind the kidney. There are some advantages and disadvantages to doing this. You're going to see here, this is sort of that's your IVC, which is the biggest vein sort of in your body, and this is the renal artery that runs behind it. When you come from behind the kidney, the first thing you come across usually in the vascular hilum is the kidney. So we're able to get that artery exposed, and now we've got that exposed, we're ready to go look at where the mass is on the kidney. And so you can see here, this is a small little nugget on this kidney. Oftentimes what we'll do is we'll use ultrasound intraoperatively, and then we can mark out the exact borders of this. That way we sort of make sure we remove the tumor, but at the same time maximize preservation of the normal surrounding kidney tissue. So here we're going to go put a clamp on this artery. This is a small mass, so we know our time that we're going to be on clamp is going to be very short. So we don't sort of worry about trying to selectively get out small little bits and pieces of the artery. We can clamp the main one. We use a combination of sort of heat and just cold steel to basically cut these out. So you can see here you've got some normal kidney overlying that mass. So we're sure we're getting everything out there. And then we've got this divot in the kidney, which will sew up and close and sort of put the kidney back together. Most times we do this with sutures. So you'll see here. One of the nice things with the robotic surgery is that, visualization-wise for us as surgeons, it's a tenfold magnification, so you get really, really nice detail. That can be very helpful in tricky cases as well. So sometimes, we say more complex cases we like to sometimes do open. Sometimes it's better doing them robotically. It really depends on the patient and their lesions. And then there's a sort of second layer, and this is a bioabsorbable tissue, this bolster that we use. And many surgeons no longer use this. This is sort of a more traditional approach where we use the bolster. But that's basically how we cut that tumor out of the kidney, put the kidney back together, and then we take at the end let the flow back into the kidney. And you can see sort of we bag the specimen in a bag. That way no cells are spilled. And you can see that kidney, the surrounding area is nice and pink, and it's not bleeding. That's an example of what we do when we do surgery. And thousands of these are done across the U.S. on a daily basis. This is just a particular one with this. So in conclusion, I'd say, surgery works very well for localized disease. It has excellent oncological outcomes and excellent functional outcomes. That doesn't mean there isn't room for improvement, and that's why we have other alternatives like ablative techniques. The choice of technique is often multifactorial. Not every case requires a hammer, right? Different tools for different situations. Good alternatives to surgery do exist, and we utilize those more now than we ever used to for patients' benefit. And robotics isn't always better, right? In certain cases it can be, but sometimes open is better or laparoscopic may be better. It depends on the situation. So I'll finish there. Thank you again to the Judy Nicholson Foundation for having me speak. And then these are just my colleagues, one of which Dr. Chatskill is one of our medical oncologists. He'll be talking later on about bone health. But again, I think as Dr. Mashan points out, it's a team effort. And so these are the people who are part of the team I'm on. Thank Thank you. Anyone have any questions? Yeah, sure. Yeah.
I have a question. Thanks for a great presentation, and I feel like we're more bored on this.
Yeah.
It's related to actually your field and actually your presentation, and this was a question that I had 12 years ago when I was diagnosed, and I think it's still a relevant question for newly diagnosed people. I had my surgery, I had open nephrectomy with a neurological surgeon, it was great, but then you sort of get to, when I was stage 3, who do I go for my continuing care? Do I stick with my surgeon? Do I switch over to a medical oncologist? And I think that's, I made my decision and I'm really happy with that decision, but it felt like a fork in the road and I didn't really have a lot of guidance. I was just going based on personality, which wasn't necessarily the best thing to do, but not a bad thing. But I think it's a question.
Yeah, so I think, you said personality. I think rapport with your physician is crucial, right? If you can't ask them the questions you want to ask, right? If you can't engage with them, and people who say, well, you don't have to get along with your surgeon, but you should be able to. You should be able to ask the questions you want to ask. So that rapport, I think, is probably paramount to making sure you're going to have a good functional relationship going forward. In some situations, patients come in, they have a partial nephrectomy, and they're good. Some guidelines would say, follow them for 5 years. In some situations, you need to follow them longer, right? And the question is, who does that? I usually tell patients, the initial follow-up, where I've done surgery on someone, the first year or so, I kind of want to make sure I see them because I want to make sure things are going smoothly. After that, it kind of depends on their disease, right? So if they're very localized and they have a local urologist and it saves them a 2-hour drive, I'm okay with that because that person is able to follow them appropriately. At the same time, if they want to come back and see me in drive 2 hours, I'm fine with that too. More advanced disease patients gets a little trickier because you don't want too many sort of people trying to quarterback it, right? And so the more advanced disease you have, oftentimes your medical oncologist is going to be your more sort of key quarterback person. We have a number of patients on clinical trials for advanced kidney cancer. And so, Dr. Chasko and myself, we'll have patients and sometimes we'll alternate visits between the two of us. And in some centers you can do that because, him and I, for instance, we talk probably 2 or 3 times a week anyways. So we're in constant communication about patients all the time and he can call me, I can call him. So it works well for patients, but not all systems are set up that. So it can be a little hard because you as a patient, you don't know what their system is set up like. I think in that sense, if you've had a good sort of experience with that person, then I would say, provided you think they provide you good quality care, I would continue to follow with them, right? If they sort of say you should go see this person instead, if you feel comfortable with that person, I think that's okay. But that can be a little bit difficult to navigate. Yeah, I can understand that, especially when you're kind of in that middle group. You're not, metastatic, but you're not a small chip shot. You're kind of, you have a risk for recurrence, and it's not insignificant. I think the main, the most paramount thing is to make sure you have follow-up, right? So, but I can understand from a patient perspective that's not always clear-cut, and it varies from place to place. Yeah.
Good morning, everybody. So my talk is really going to focus on small renal mass. As a patient, this is the most common type of presentation of kidney cancer, and I'm hoping that after the end of this talk, we can answer some of the questions about what happens to the patient that is diagnosed with a small renal mass? What are the process? What are their options for treatment? And we'll also touch on follow-up as well at the end of the talk. So I'm an assistant professor of urology at Emory University, chief of urology at Atlanta VA, and in my practice, I manage kidney cancer robotically, open laparoscopically. I have no disclosures. So objectives, as I mentioned, we'll briefly talk about kidney cancer. Previous speakers went to details of what is kidney cancer, so I won't go into as much details. We'll discuss what is a small renal mass and what are the treatment options, and also we'll go over the follow-up for small renal mass. So in general, cancer is the #2 cause of mortality in the US. So cardiovascular disease is still #1 cause, so it's important to keep that in mind. And interestingly, having good cardiovascular health can be actually protective to prevent kidney cancer. And high blood pressure is one of the risk factors for kidney cancer. When it comes to urology cancers, kidney cancer is a #3 common cancer in urology. However, it can be quite serious. 30% of kidney cancers, unfortunately, present at late stages. Historically, before the increase of imaging that are so prevalent now, a lot of kidney cancers presented in late stage to the point that, there was a term triad of presentation where it was blood in the urine, having, significant pain, and other morbidities. However, we see much less of that, fortunately, due to advance of imaging. Still is common. It's more common in men than women. And typical age is between 50 to 70 years old, although, as you saw in other speakers, we have rare cancers that can present in very young age, or those with familial syndromes and hereditary type of cancers can present a lot earlier. But the median age is around 64 years old. And as I mentioned, majority are in a lower stage, but however, we do get a significant number that are in advanced stage. That's why it's important to talk about those. And Dr. Master, my colleague at Emory, is going to go into details. He's a world expert in management of advanced kidney cancer. So I look forward to his talk today. What is a small renal mass? Just before we dive in, as a patient, you might hear that I have a spot on my kidney. That doesn't mean it's a mass. And it also doesn't mean it's a cancer. A spot on a kidney could be what we call a cystic lesion or a fluid sac that is quite common. 50% of patients over age of 50 might have a cyst in their kidney. So that's not small renal mass. And by definition, it is a lesion, a solid lesion that is smaller than 4 centimeters. And the reason that number comes, as you saw in an earlier talk, which was very helpful about staging of kidney cancer, size of the tumor is very important in staging of the cancer. And I'll show you later in the TNM staging, we'll go over that. And it should be not an invasive tumor. So that's sort of a definition of a small renal mass. As I mentioned, they're mostly diagnosed incidentally. Nowadays, there is a very high use of CT scans and ultrasounds in our emergency departments. This has increased by 4 times in the last 20 years. So a lot of patients that walk into the ER with vague abdominal pain or back pain get a CAT scan, and you see incidental findings of many things, from kidney stones to kidney cancers. And they're usually non-specific. Majority of localized or small renal mass do not cause any pain or blood in the urine or anything like that. And the good news is that 20% of these masses that are smaller than 4 centimeters are not cancer. They're benign lesions. And the risk of cancer spread at that size is quite low. So these are all good news about small renal mass. What are the benign renal masses? I won't go into too much details, but one of the most common types is oncocytoma. You might hear that term, but there's a long list of types of masses that could be benign or non-cancerous in a small renal mass. This is sort of the complex TNM staging. I won't go into too much details. You already saw that in earlier talks. However, as you can see here, the size is what really defines the earliest stages of the kidney cancer. Any cancer under 7 centimeters is a stage 1, which we divide between 1A and 1B. 1A is really what we focus on a small renal mass, which is less than 4 centimeters. 1B is from 4 to 7 centimeters, and then anything between 7 to 10 centimeters is stage 2. So that size has become important in the staging, and then later you can see other things like invasion into the blood vessels, which Dr. Master talk will focus on, or if there's extension to the nodes or other parts of the body can affect the staging system of the kidney cancer. So as a patient, when you're diagnosed with a spot on your kidney, usually the next step is to get a more accurate imaging, a cross-sectional imaging with and without contrast. That usually can be done by your primary provider before they refer you, or by a urologist when you get referred for the spot on your kidney. The next thing that comes to mind, once you have that imaging and it sort of shows that this is likely a cancer, is, do I need to biopsy this mass? In many areas of oncology and cancer care, not just urology, taking a tissue sample is a natural first step before we offer treatment. However, in kidney cancer, there's a lot of controversies about need of biopsy. And there's still debates going on among urologists, so this is a very controversial area. Just to talk about biopsy, historically, it was presented as this very invasive procedure that has, risk of tumor seeding or spread to the rest of your body. We showed that that's not true. The risk of tumor seeding or spread is extremely rare. It's case report, really, if it happens. And the biopsy is quite minimally invasive. It's done usually by radiologists, although some places urologists are now moving to doing in-office biopsy. It's a same-day procedure, small needle, go to the through your back usually or side using ultrasound or CT guidance, take a sample from your kidney. The risk of morbidity is less than 1% to 2%, and the main thing is bleeding, which is almost always manageable without any intervention. The issue with biopsy is that it's not always accurate. 5% of the time, it might tell you there's no cancer when there is cancer, which is a concern. And also 10 to 15% of the time, it could be just non-diagnostic. So you go through this whole process, you come back to your doctor, and you're told that we don't know if there's cancer or not. We didn't get enough tissue, or the tissue wasn't adequate sampling. And then you have to decide what to do next. So in general, we reserve biopsy for cases that we're pretty certain is going to change what we offer the patient. So examples of that is if we worried that the mass is a spread from another source of cancer, or is a metastasis from another cancer to the kidney. Or if on imaging, it's not really clear if it's a kidney cancer. It might be worrisome for other diagnoses such as infection, bleeding, and at that point, biopsy might change what we offer to the patient. What are the patients that are not really a good candidate for biopsy, for instance? Elderly patient who have many morbidities, and patient already had a shared decision making with you that, doc, even if this is cancer, it's a small renal mass, I understand the risk of a spread or progression is quite low. My risk of dying from this cancer in the next 5 years is less than 2%, but my life expectancy is 2 years. I don't want anything done about this. We're just going to watch this. Well, biopsy is not going to change what you do, so that's not a patient you want to biopsy. Or a very young patient on the other end of the spectrum, that 45 years old, young female that has a kidney mass that is very concerning for kidney cancer. And the other tools we can use, if it's even a questionable mass, that if it's cancer or not, such as like System-EB kidney scans, which is like a nuclear scan that can tell you if it's a cancer or not based on just imaging, is helpful. And the patient is like, doc, I want this mass dealt with. I'm too young. I don't want to have many years of imaging. I understand that there's 20% chance it might not be cancer. I don't want to take the risk of biopsy, and we'll just take that mass, out or do ablation or other treatment options. So in terms of treatment options, Dr. O'Malley went over this. I'm going to focus more on active surveillance and thermal ablation, and there's also options of radiation treatment, which are coming along. They're more like studies now. They haven't really become part of the guidelines yet, but I think there's a lot of promise for radiation as a minimally invasive treatment for kidney cancer as well, which is coming down the pipeline. And I'll let our colleagues talk about this later today. But generally, active surveillance, ablation, partial nephrectomy, and radical nephrectomy are options for small renal mass. Active surveillance is more of a new area in kidney cancer. In prostate cancer, we already crossed that bridge many years ago. Historically, we used to remove every prostate or radiate it, but we realized in the last 2 decades that we can watch a lot of prostate cancer. Well, we're realizing a lot of this now with kidney cancer. There are multiple groups. One of them actually, where me and Dr. O'Malley did our training in the University of Toronto, they have a very large series of data showing that you can watch kidney masses quite safely for a long time. Here I'm showing you the 2 major cancer bodies, AUA and NCCN, and their guidelines summarized in a table. What are the candidates for active surveillance? Based on AUA, elderly who are not really good candidates for surgery or ablation. Also patients who have poor kidney function, so they're at the risk of ending up on dialysis if you do something invasive to their remaining kidney, or if they have less than 5 years of life expectancy. NCCN is sort of a more broad approach. Any small renal mass could be watched, especially if they're less than 2 centimeter. And also if there are cystic mass, which I won't go into too much detail since we're talking about a small renal mass, but any kidney mass that is cystic, so it has like fluid with a small area of mass, is actually quite less concerning than a solid kidney mass, and it can be even more easily watched. Now, it's important that we stick to the criteria to watch this. So that's why it's called active surveillance. So this is not just saying that, okay, well, we'll see how it does. We're actively following the mass. And we have criteria such as, if the mass grows more than 5 millimeter per year, or if it reaches a certain size, with triggers for intervention. And this involves having, 6 to 12 month imaging of cross-sectional imaging or ultrasound of abdomen, along with chest imaging to ensure that there's no progression of the disease. The next option is thermal ablation. Just a point on active surveillance, unfortunately, it's very underutilized. So it's important that you discuss this, with your physician. Right now in the US, we're quite behind in adopting active surveillance. Only 20%, based on a recent study, 20% of patients who could be qualified for active surveillance are being offered active surveillance. And as urologists, we need to be more proactive about, discussing that with our patients. As Dr. O'Malley said, not every nail needs a hammer. So thermal ablation is the next option. It's generally ideal for, again, small renal mass, so smaller than 4 centimeter. Many of the earlier studies used cutoff of 3 centimeter for small renal mass, but we are having more data coming out that showing that it could be effective even for larger than 3 centimeter mass. It's definitely the least invasive option compared to partial or radical nephrectomy. But at the same time, because it's less invasive, it's also, you're not removing the tumor. It's not as effective, at least with the data we have so far. And again, the data is not that long-term yet compared to partial or radical, but the effectiveness is probably 10 to 15% lower in cancer cure long-term. However, that doesn't mean it leads to mortality. A lot of those recurrences can be caught in close follow-ups and be dealt with repeat ablation or more complex surgeries, but still can be curative. The modalities we use can be either heating or cooling or freezing the tumor. So you can see radiofrequency or microwaves is the way that we heat and kill the cancer cells, and cryoablation is how we freeze and kill the cancer cells. All this done with putting needles in the back or side into the kidney, kind of like acupuncture. So there's no skin cuts or incisions. That can be same day or overnight in the hospital observation procedure. Recovery is quite fast, less than 1 to 2 weeks, usually less than 1 week before you get back to your normal activities. And however, there's caveats. So when you have a small renal mass, not all of them could be a candidate for thermal ablation. If the mass is quite central, close to the hilum or the vascular supply of the kidney, or too close to the collecting system, for instance, or really close to adjacent organs, bowel, other organs, it can be challenging for ablation. Or if there is a need to go through a lot of kidney to get to the mass. So those are concerns. So it's a technical decision, and usually it's in collaboration between urologists and radiologists who are the expert in doing ablations and image-guided access to the kidney. And like everything else, before we actually do the ablation, we have to take biopsy. This is mandatory. This is the one time the biopsy is mandatory. Usually, it's done at the same time of ablation to save the patient a trip to the hospital, but it can be done beforehand to be really sure what you're ablating is kidney cancer. I'm not going to go into much detail. Dr. O'Malley had a great talk and video about partial nephrectomy, but just to summarize, it is an option for small renal mass or even masses under 7 to 10 centimeter. The field has really changed from 10 to 15 years ago, where a lot of kidney cancers bigger than 4 centimeter would end up with a radical or complete removal of the kidney. The pendulum may be swung a little too far to the side of preserving kidney, and we are now realizing that maybe there is a role for radical nephrectomy in certain patients that we pushed for partial because of the higher complications of partial nephrectomy, and also because of multiple studies showing that the kidney preservation is not as important in some patients that are older, they have less than 5 to 10 years of life expectancy, and they have normal kidney function with a normal kidney on the other side. However, still a strong role for partial nephrectomy. Any mass less than 4 centimeter definitely should be considered for partial nephrectomy if this is decided to be treated. Also, if the patient has kidney failure, already has kidney disease, you really want to push for nephron sparing surgery. And if they have one kidney or if they have familial syndrome. And just to give you an example, a few months ago, I did a partial nephrectomy in a young female with a 12-centimeter mass, which had VHL syndrome. So that patient is going to have more kidney cancer in the future. So again, one size doesn't fit all. It's case-by-case patient selection, but generally it's reserved for small renal mass. And it can be done many ways: open, laparoscopic, robotic, which is the most common approach these days. And the goals are really two things. One is to cure the patient from cancer, so you need to reach what we call negative margin, so you cut deep enough that all the cancer is removed. We can confirm that with sending a biopsy, if we call it a frozen section. So at the time of the surgery, when the mass is removed, we visually can see the cancer is removed, but we also can send a little sample to confirm there's no cancer left behind. There are other techniques like using ICG, which Dr. O'Malley showed, the green light that you can see in the tissue. That also can be helpful to distinguish cancer from normal kidney at the time of your surgery to help your margin. And the other goal is to save as much kidney as possible. So just as a little imaging illustration, you already saw a great video of it, so I won't go into too much detail, but the mass is removed, and then we use different techniques to put the kidney, close the kidney back together. This is just the slide to show that not every small renal mass is the same. So you can see these are what we call cheap shots. You can do this, with any modality. Usually we've done this robotically. These are very easy. They're away from the collecting system or the hilum, the vessels that come here. These are more difficult because these are more central. They're going deeper, closer to collecting system, and they might be, closer to renal vessels when they're in the middle like this, not on the ends of the kidney. And different masses can have different complication rates. So in a patient that is elderly and has a higher risk of surgery with a mass like this, we might offer nephrectomy, removing the whole kidney. But in a younger patient, we might offer a partial nephrectomy. So that's sort of another angle of looking at it, why every patient is different and every mass is different. Radical nephrectomy is an option for a small renal mass. However, we generally reserve it for mass larger than 4 centimeter. Some of the examples that small renal mass, which is a smaller than 4 centimeter, is a candidate for radical nephrectomy is if the tumor is really central, it's really close to the renal vessels, or if there's concern for its invading the renal vessels. Then we don't usually recommend removing just the mass. Also, if the patient is, has other many morbidities for a complex surgery like partial nephrectomy, or they have advanced age, and they have normal kidney function with the kidney normal on the other side. Sometimes also we offer it in patients that have non-functional kidneys. So that's if we suspect that the kidney is atrophic or doesn't have much function, there's no point of saving the kidney for small renal mass, and we just remove the whole kidney. It's definitely safer than partial nephrectomy, but it has the increased risk of kidney failure and loss of kidney function long term. So therefore, we try to not use it if we can for small renal mass. And it can, again, same to partial nephrectomy, can be done in different approaches, open, robotic, or laparoscopic. And due to cost saving, a lot of centers are still doing laparoscopic removal of the whole kidney. It's equally as effective as robotic. The incisions are very similar. They're all small incisions, and it depends on surgeon's skills. Some surgeons might still actually be more efficient with doing it laparoscopically, but some surgeons coming out of training are more efficient robotically. So really, they're all very similar. There are different approaches to it. So this is just a picture showing you what it means to remove the whole kidney. Essentially, you have to cut off the main blood supply, which is the hilum of the kidney, and the ureter, and that's sort of all the attachments of the kidney. Now, to just answer your question, I'm glad you had that question about follow-up, and we're doing a better job in being organized. What is the follow-up of, kidney cancer after treatment? And many guidelines are making this more clear, but as urologists and as oncologists and radiation oncologists, we should do a better job in sticking to the guidelines and making sure the patient know the big picture ahead of them. So it's important to explain to the patients that what is the plan for follow-up after surgery, because that's sort of what's on your mind once you had your first, or after ablation, once you had your first step of your journey of treatment of the kidney cancer. Generally, it depends on the risk of cancer. So small renal mass, they mostly fall into the low or intermediate risk cancer, and they usually need imaging every 6 to 12 months. And then after that, in year 2 and year 3, it can be a yearly imaging, which involves abdominal imaging, which could be ultrasound or CAT scan or MRI, along with the chest imaging, like a chest X-ray, and labs. And obviously, history and physical exam, coming to the office. And then usually after 5 years, the risk of recurrence for especially small renal mass drops significantly. And that's a point that you can discuss with your surgeon or your provider. If I need to continue my follow-up with you, or I can maybe follow up in my local provider or my family doctor. But with more higher risk patients or patients with familial syndromes, we tend to want to be involved with their follow-ups sort of longer term. But there are guidelines in regard to follow-up, so you can ask about that for your doctor next time you see them, and they can go over that with you. So take-home point, like everything else in medicine, kidney, small renal mass is a shared decision-making. And it's actually the area that is more required to decide together. When you have a big 20-centimeter mass in your kidney with tumor thrombosis going into your vein, the options of cure are limited. However, when you have a small renal mass, you have many options, which are all really good. So it's really important to talk to your surgeon, to talk to your doctors, and make a decision that you're comfortable with. And make sure that you go to a place that gives you all those options, because we could be biased as surgeons, that especially if we do only one thing or two things, might be biased. So make sure you search and get information about all the options available. And every patient is unique, and every kidney mass is unique, so not one size fits all. Thank you. I'll take any questions at this point. Go ahead.
I had a question. You had mentioned CT scans, or X-rays as chest X-rays as surveillance, but is that standard of care? Because the only reason I ask is I got a chest X-ray 2 weeks later, and there was nothing. 2 weeks later, I got my second opinion, got a CT, and I had dozens of spots in my lungs.
Very good questions, and that comes down to the risk of cancer as well. So for somebody who is very low risk and small renal mass, chest X-ray is sort of a standard of care. But for a patient with a higher risk cancer, definitely you want to do chest CT or cross-sectional imaging. So it depends on patient. Just to keep in mind, every CAT scan with contrast can have 1 to 2 in 1,000 risk of causing cancer. So a CT urogram, that's actually one of the areas of my research interest, is radiation causing cancer. And a CAT scan with contrast, a urogram, which has close to 30 millisieverts of radiation, has 2 in 1,000 risk of causing new cancer. So we need to be guardians of our patients and not just use contrast imaging or high radiation imaging. That's why we are trying to implement more of chest X-ray and more of ultrasound in our guidelines. But definitely a patient with a higher risk disease needs a higher quality imaging. It's a very good point. Go ahead.
Would the thermal ablation be appropriate for the resection of a small tumor that is part of a recurrence in the renal cavity? I have a radial nephrectomy now, I have a small mass in the renal cavity.
That's a very good question, and that really falls into the areas that are not really studied in large numbers. Generally, we tend to do a full systemic imaging, make sure there's no other areas of recurrence, and if that's the only spot, general approach is to go and remove it. Ablation can be more difficult in trying to target that one area without really no other surrounding landmarks to help you with that. But certainly it could be option depending on where it is. Like if it's not close to other organs, if it's not a higher risk ablation, it could be option. Just have to keep in mind, if you ablate it, it causes a lot of tissue changes and scarring. And if it doesn't work successfully, it could make the surgical removal more difficult. But before making any decision, it's very important that this is a complex situation that needs to be discussed in multidisciplinary approach. With radiation oncologists, medical oncologists, have a proper staging, radiology available to see if it's even feasible to, and this is something I would definitely biopsy beforehand as well, to really be sure this is actually cancer and not scar tissue. No problem. Okay.
Great, thank you so much. Good morning, everyone. So I'm a medical oncologist. I have 2 left hands, okay? I don't do surgery on anyone. Well, first of all, let me actually thank the Judy Nicholson Foundation for having me. Groups like this, patients, advocates, caregivers are very close to my heart. And so I think this is a very, very important meeting from many different perspectives. So my job was to talk about some new strategies. It was about research, etc. But I thought, let's talk about, from a medical oncology perspective, where might be some new opportunities for patients. So speaking really in the sense of hope, and that's what I would like to convey with this presentation today. These are my disclosures. So we haven't heard so much actually about the systemic therapies in kidney cancer. And so let me just remind you that, for cancer to be successful, a lot of different things have to happen. And I would say the emphasis or how good at cancers are to do certain things to persist and thrive can be quite variable. But one thing is clear that, kidney cancer is really good at avoiding immune destruction. Despite being actually reasonably immunogenic. So that's clearly one area that has been quite fruitful in the management of kidney cancer. The other thing is, the tendency, especially for clear cell kidney cancer, and that's what we are talking about most of the time when we talk about metastatic or stage 4 kidney cancer, is really, I would say the fairly unique addiction to making a lot of blood vessels. These are very friable, easily bleeding tumors. And essentially, clear cell kidney cancer is really defined by the loss of the ability to sense oxygen. And these cells think there is no oxygen, and they start a program that will help alleviate that. So these cells are uniquely focused in a very particular way to support themselves with blood vessels, blood vessels, blood vessels. And that's where, the unique vulnerability comes in to target these tumors with blood vessel inhibitors, the pills that patients take, the targeted therapy, which is unique. There are not many cancers that are that sensitive to this particular class of drug. And especially in a cancer that's typically resistant to cytotoxic chemotherapy, that was really the first class of drug that made a big difference. So we'll talk about that a little bit. There's not too much going on there, except that we have already a large plethora of drugs in that space. I would say the other one that's about to change a lot, I think, or at least really becoming a palpable treatment option for a lot of patients, are some unique features arising from this inability to sense oxygen, and with it some reprogramming, if you will, the way clear cell kidney cancer thinks and is deregulated with regards to some of its metabolism. We'll talk about that, and then and then some other approaches that might be revisited that go in the range of radiation, of trying to kill these cells, maybe in different means than what Dr. Hannan would do. So so angiogenesis, that really has been the bread and butter since 2006, really, since when Sutent, the initial very potent VEGF inhibitor, was FDA approved, and we commonly use a lot of these agents in patients. These days, you probably see less patients who started on drugs like sunitinib or pazopanib, more commonly on Inlyta in combination, for example, with immunotherapy, lenvatinib and cabozantinib, Lenvima and Cabometyx in combination with immunotherapy. Tivozanib is a more recent addition in pretreated patients. And a lot of these efficacy and side effects, they're fairly similar. What we don't understand is, for example, why some patients who progressed on one set of pills might actually still do really well on another set of pills. So, it's not that you develop resistance against the class, you develop resistance against one of these pills, and some of these drugs may still work reasonably well, albeit typically with diminishing returns. So is also the side effects. Some patients, for example, hate carbomatics and other patients do really well on it. Some patients hate Lenvima and others do really well on it. And you can go through the list of these pills. It's very difficult for us to predict how a particular patient will do with some of these. But I would say, liver toxicity with some of these agents, and then because of that, some issues with combinability with immunotherapy, for example, is one of these issues. And you may have seen some news on a triple therapy that was just reported on in Europe, combining cabozantinib, carbomatics, with Opdivo and Yervoy, and that, didn't go so well because of a lot of toxicity. And so there is some effort in potentially improving that, and I would say one agent to probably watch in their clinical trials with that is XL092, and the reason why I'm mentioning that is it's driven by the maker of carbomatics that probably will put these agent into multiple combination, or there are trials with multiple combinations to see if that might be an easier combinable, if you will, next generation cabozantinib with a shorter half-life, easier to manage. So half-life is the amount that the drug stays in your body, so easier to get the drug out of your body if you get side effects, and combinability. So that's certainly one of these agents to watch, but I don't think there are any other huge breakthroughs in that space per se. Talking about the addiction and deregulation, I think this is one of the biggest breakthroughs, I think, in clear cell kidney cancer, and these are the HIF2 inhibitors, and they're really on the verge of becoming available, hopefully, over the next year or two from patients with metastatic sporadic kidney cancer, so the one that shows up spontaneously. This drug is, in form of belzutifan, is already approved for patients with von Hippel-Lindau disease. What's really unique about this drug is, despite being a pill, is, I would say, the unique tolerability. I mean, it's one of the few drugs where patients have to think about what their side effects are. And if they have side effects, it's typically driven by the low red blood cell count, by the anemia that is really an on-target effect. So it's really quite striking. So belzutifan, the brand name is Velireg, that has been approved for von Hippel-Lindau syndrome, and that was mentioned several times before. That is a genetic syndrome that affects families and individuals, typically with multiple bilateral kidney tumors. And for most patients who don't have genetic syndrome, we're waiting really for phase 3 results, alone or in combination with some agents, to try to get this approved. But there are also other clinical trials. So if you're looking for clinical trials, there are agents in development, different kinds of pills or also injectables that may be a small molecule that targets the particular transcription factor, or potential injections that will decrease the amount of RNA, so the production itself of the protein, and may be interesting for some resistance that might occur. Thinking about immunotherapy, I didn't do any drawing per se, but as you know, immune checkpoint inhibition has changed dramatically the way we treat kidney cancer. And the way these drugs work is by really taking down brakes of the immune system. So the cancer has little keys. The cancer, or the microenvironment, quite frankly, has little keys that can engage receptors on the surface, typically of immune cells, and can just turn them off. And that was one of the critical insights that was really rewarded with the Nobel Prize of Medicine in 2018 for the discovery of the PD-1 and also the CTLA-4 pathway. And you have some of these approved agents in that space up there. so the way they act is they protect the immune cells from being turned off. And if you're lucky, your immune cells may now direct its force against something that they can see, and hopefully they can see cancer and can potentially eradicate cancer. So it's clearly a therapy with, I think, I feel more comfortable now saying, really with curative potential. Some patients will do really well for a long period of time. The major side effect, obviously, is that if you have some cells that always looked at your liver, colon, or other organ, they may now go after that particular organ. And so it's really autoimmune disease and the management of some of these side effects. These drugs are not innocent. They can cause irreversible end organ damage, in particular of hormone-producing organs such as type 1 diabetes, adrenal insufficiency, thyroid dysfunction. And they can also cause a long list of potentially quite threatening and impressive syndromes. But overall, for most patients, these are really well-tolerated therapy and can be reasonably well managed. So the question is, are there other checkpoints that we can target? And I would say, the lowest hanging fruits has been, I think, already achieved with the PD-1 inhibitors. But there's another agent that's coming along. There was a phase 3 trial that was positive in melanoma. It's not FDA approved. It's a LAG-3 inhibitor, one of these other molecules on the surface of these immune cells. And there was a positive study. This agent has been around for a little while. It's been also been studied in kidney cancer, so we'll see how much role it's going to play in some of the ongoing upcoming studies. Probably it will be something more incremental, but it's certainly something to watch. And this is not the only agent in this space. If you talk to other investigators, they will have their favorite, other immune checkpoint inhibitor, but it's certainly something that's being developed. I think one of the surprises is now also in the CTLA-4 inhibitor space. CTLA-4 is a target that's really not that well understood. It's much more broadly expressed on immune cells, and not every antibody that's being made against CTLA-4 is a good antibody with regards to its effect of cancer. But they spent now some considerable amount of time in trying to make the CTLA-4 inhibitors better by maybe changing the way the tail of the antibody looks and how it interacts with some of the immune system. And a drug called botensilimab with the company's own PD-1 actually showed a really strong signal in a disease that typically sees 0% response rate, and that is colorectal cancer that is not high in mutations. So if you look at the colorectal cancers, they are somewhere with a certain genetic defect, often in the germline, and these tumors are highly, highly responsive to PD-1. There was one of the news that was up in ASCO where they selected carefully patients with rectal cancer with this particular genetic syndrome. But if you don't have that syndrome, colon cancer is one of the coldest tumors you can imagine, and the response rate to PD-1 inhibition alone or CTLA-4 is typically extremely low. Here they saw a 24% response rate, and so it's a really strong signal that maybe some of these next generation antibodies, even against targets that we are used to, might actually be something to watch and look for. Let's look at cytokines. If you remember maybe the timeline that was shown, right, 1992. By the way, that was approved with a lot of advocacy in the background for those of us who remember that. That was a therapy that's been around for a long time. In fact, we still use it occasionally, even in 2022. But it's a quite draconic therapy in the intensive care unit. But we cure patients with it. I've cured patients with it when I was at Hopkins, etc. So it's still something there, and there have been efforts to maybe change the molecule, the way it interacts with the immune system, that you don't need as such high doses, and maybe bring that into the outpatient setting. And unfortunately, one of those attempts has spectacularly failed, not only in kidney cancer, but also melanoma, and probably was one of the biggest busts, if you will, that's Bempeg aldesleukin. That was designed to kind of like maybe more selectively make the T cells grow that are good, but not so much affect the T cells like the T regulatory cells that actually suppress the immune system. And that, unfortunately, didn't work so well. There are newer variants of interleukin-2 molecules in clinical development, and they are actually more encouraging. They actually show, in comparison to bempegaldesleukin, single-agent activity in renal cell carcinoma. One of these examples is nemvaleukin alpha, for example. So I think there might be a renaissance, hopefully, of some of these agents coming, and we will see how that development goes. But that's a little bit of my little hopes that we can try to open this box in a way that's more useful than what we've done. Not every cytokine is helpful. There are some cytokines that are immune suppressive. So this is the example, for example, of interleukin-27. That is really more like a virulence factor for cancer and is quite immune suppressive. In tumors, this is a molecule from the Surface company. It's extremely well tolerated. I would say it's modest activity in renal cell carcinoma, but also some activity in lung cancer. I had some patients on that with actually some very nice stable disease for quite some time, patients who had progressed clearly before that. And we have to see how some of those agents may find their way into the clinic and how that might work for some of our kidney cancer patients. Another approach is to look at some what we call, metabolites or immune suppressive metabolites. So adenosine is actually a breakdown product. It's a building block of DNA. It's also important for essentially energy currency in the cell. And these molecules, when they get to the outside in the tumor microenvironment, they may break down and take a form that they can interact with receptors on immune cells. In fact, they can be quite immune suppressive. And one of these receptors is an adenosine receptor antagonist. There's a small molecule developed. There's some antibodies also in that particular space. They tend to be well tolerated, seem to have moderate activity. But I think there is room for some of those molecules to be developed on top of an immunotherapy backbone. So, for example, Katie Beckerman from Vanderbilt will have a triplet study open combining ciforadenant with nivolumab and ipilimumab in previously untreated patients. That's run through the Kidney Cancer Research Consortium, and where we have several sites in the United States. Another one that is often discussed with patients where I think there's a lot of hope, but I think it's still something that is not easy to achieve, and I think is particularly challenging to be successful in solid tumors, are the CAR T cells. So there was one of these very early spectacular achievements, primarily in leukemia, where you could literally, target B cells, and many of hematological malignancies, many of these bone marrow malignancies, leukemias, are B cell derived. So the rationale here was, okay, let me reprogram these cells. I take random T cells, I put in an antibody-like molecule that targets surface receptors for B cells, and that allows these cells to be super aggressive if they engage with their target. And you could just ablate, you could just destroy all the B cells in the body of the patient, and with it you would get an anti-leukemia effect. It's not that simple. In solid tumors, we don't have typically as easy targets where you can just eradicate whole tissues because often they're not distinct enough. And so if there is, you may have to fine-tune some of these receptors. They may engage when they see a certain density of targets, for example, on the cancer cells might be higher than normal tissues. They're thinking about maybe like programming them that you may need to have two targets at the same time. So it's much more finesse that's important. And also these cells, or these solid tumors, are much more immune suppressive. So it might be easier for these CAR T cells to engage with free-floating cells and to go and get into a highly immune suppressive solid tumor microenvironment. Nonetheless, companies are going to that space, and that's fantastic. So as an example, ALLO-316 is a CD70 targeted CAR T cells, and they're also fine-tuning some of their products for kidney cancer. Last but not least, I wanted to mention, radiation therapy. Dr. Hannan is literally a world expert in delivering very highly focused radiation and spot welds my patients all the time. Thank you, Raquibul. But the question is also, can we maybe deliver radiation more systemically? And so there are approaches of taking highly radioactive metals or elements, if you will, that will decay and send out very locally radiation and attach them to carriers, if you will, to antibodies that may see, in this case, for example, CA9 on the yellow cancer cells, or, for example, PSMA, prostate-specific membrane antigen, which is often, actually very often, highly expressed in the vasculature of clear cell kidney cancer, and can be have these molecules attached there and then just start radiating right in those spots without Dr. Hannan needing to use his death rays. And so, so these are things that are being explored. The amount of radiation may not be as high as what you would achieve maybe with stereotactic radiation, but it might be an addition of hitting the tumor bulk. Maybe there's some stimulation of the immune response. Some radiation can potentially do that. And so I think you will see some trials in that space also coming up. And so I would say with that, I would just stop and thank you for your attention.
Any questions?
Yes.
Yeah, just a small question. You had mentioned when you were talking about angiogenesis drugs. Class, one pill not working as one pill. Do you feel the same thing about cytokines? You've done original cytokines, and do that, and didn't have a result, then pulled out cytokines?
Yeah, so first of all, there are several different cytokines, and some of them, for example, may be supportive of NK cell growth, and there might be some rationale for that. Not sure, let's say, how much better IL-2 variant would work after high-dose IL-2, for example. These are unclear things. But I think, hopefully at some point we will come to understanding what component of the immune response is defect, or how can we overcome that. What I didn't mention, for example, other approaches, for example, is tumor-infiltrating lymphocytes. That goes a little bit into the direction of IL-2, where you kind of like take out a piece of tumor and digest it, and then take out the T cells and just grow them and play the numbers game. And then you inject a large bag of those cells back into patients. And there's some nice data, melanoma, for example, and people are now looking at that potentially in kidney cancer. So I think people are coming from all kinds of different angles. But yeah, I think your point is well taken, which is, I think we need to have more effort to understand where patients are in the journey of if therapies fail them, right? And what is the molecular and biological underpinning, and how can we potentially best manipulate it? Great. Any other questions? Yeah.
When are we finally going to start seeing the use of biomarkers that might help guide patients and their doctors in therapies versus TKIs, or are they coming there?
Yeah, so for disclosure, I'm a little bit a pessimist when it comes to biomarkers, okay? So, and let me give you a good reason, try to give you a good reason why. So for example, first of all, I think we're grateful for the industry of spending money on some of the large cohorts from phase 3 trials to look at the tissues and getting some data back to us. But it turns out that some of these signatures and other things that we find in one combination may not necessarily apply to other combinations. So I think it's really important to prospectively be very careful with that. The other one is, for example, these signatures are probably in the range of a PD-L1 staining of what they can potentially achieve, right? But let's say for Opdivo and Yervoy, we don't use PD-L1 staining to choose a therapy. If you are PD-L1 positive, I may squeeze your arm a little bit more to consider it. But if you're negative, it's not a reason not to do it, because we know those patients still live longer. Response rate of those patients still 37%. In fact, 7% of patients still get a complete response, even if you're PD-L1 negative. So, I would say at this stage, many of these biomarkers are not yet at the stage of a biomarker. I think there are interesting scientific insights that we need to explore further, but they're not yet good to go to choose therapy. So I'm a little bit more pessimistic when it comes to it. And then the other thing is, the field is moving so rapidly, right? We are almost just, I would say, lucky, but the triple therapy was almost here, so to say. I think carbo-nivo-AP is an issue. We will not know what's going to happen with this. But the truth is, you add another one. Let's say instead of 2 drugs, you have a third drug, and then all of these signatures that you did before, what does that mean, right? So the field is moving very fast. And let's say the triple therapy that Katie Beckerman is doing, we don't know how that correlates with other signatures. So we're always going to be quite behind. The other thing is also personally is, let's say you could, what I'm afraid of is that we are just looking at the short-term gain. So let's say if I identify that your tumor is much more angiogenic than immunogenic. So does it mean, okay, let's not even try immunotherapy, I'm just going to start you on palliative therapy, meaning that's what it is, because angiogenesis inhibitors don't cure anyone. They keep your cancer under control, but they don't get rid of your cancer. Instead of coming from the opposite end, which is, okay, your tumor is cold. So instead of just giving you palliative VEGF TKI, why not do we double down on your tumor and try to figure out how we get really hot? Maybe we need to actually intensify immunotherapy in you. So that's the other point of view, because the only thing that I can do as a medical oncologist to cure patients, I cannot cut like my colleagues or use death rays like Dr. Hannan. I can only try to use immunotherapy typically to get long-term benefit. And so, but I tell you, there are lots of discussions in the community around it. We certainly want to see more investments in biomarkers. I think one thing that we should really do more frequently, and I think it actually belongs into guidelines, is that we start really next generation sequencing all of our patients. Now, admittedly, the clinical utility, meaning the benefit from it, is still low, but there might be something we might learn down the road. I think we should just do it, put it into guidelines, and start with that and go from there. Thank you very much.
Good morning. Those of us who dedicate our lives to doing procedures feel so inadequate in the presence of researcher medical oncologists. So the first thing that you'll notice is that we're going to drop a little bit the intellectual level of things. I can't handle that. I admire it. I wish I could have that power, but I don't. I'm a much simpler person. So today we're going to talk about something that was announced as new surgical techniques, but in reality, there's really nothing new about it. We've been doing ablation procedures for about 20 or more years now. I'm old enough that I was lucky to ride that wave. I saw it from its very beginnings to now that these are very mature and well-accepted techniques. So it's a pleasure to talk about something that actually has succeeded quite a bit and is in daily practice. So the first thing I need to do, though, is to clarify what I am and what my community offers to you as the public in general and patients in particular. To this date, neither my mother nor my mother-in-law know what I do for a living. What do you do? I'm an interventional radiologist. And what is that? What kind of doctor are you? It's like, well, I don't know, Mom. Forget it. So what is an interventional radiologist? Well, what we do is use pictures, any way we want to obtain them, to guide procedures that are typically done with a combination of plastic tubes and needles. And the design of those elements changes, but that's the bottom line of it. And it crosses all organ systems. And that's one of the reasons why it's very difficult for us to have an identity, because we're not organ specific, right? You say, well, I'm the prostate urologist. Great, I know what you are. I'm an interventional radiologist, and you get a stare look. It's just, blank look, I don't know what you are. So let's now provide to you what it is an interventional radiologist can do. All right, so first of all, our techniques are really convenient because they have numerous features that are positive. It tends to be less expensive, less risky, less painful. 80% of patients don't even need to stay in the hospital. They go home the same day. In certain situations, it can be more effective than surgery. In most instances, surgery is the preferred mode of therapy, but sometimes it's not. And there are patients that we can do without general anesthesia, although general anesthesia is the usual. It can be done without. With intravenous sedation, it's manageable. So in order to treat kidney cancers, heat and freezing are the ablation methods of choice. There is a third option that's called IRE, and we won't talk about that today because of time constraints, but basically anything that you do where you insert a probe that delivers some kind of energy or modifies the environment in such a way that it kills is called a percutaneous ablation. Now, for us, the morphology of the tumor, that is its shape, its overall physical characteristics, is really important. So the looks matter, and the cancers that matter to us as interventionalists are those that correspond to T1A, which is less than 4 centimeters. We consider those small. Anything above 4 centimeters we consider big for us in our community. And this is generally what a kidney cancer looks like. You've seen it many times. And this is what the corresponding image would look like on a CT scan. On the left side, you can see that the tumor is kind of bubbly, kind of ugly looking, and comes very close to the central portion of the kidney where the blood vessels enter and the urine comes out. This is something that wouldn't be ideal for us. It's a little biggish, and being close to delicate structures that we can hurt, we would be very cautious. Now, if you look at the right side, there's a little pimple sticking out of that. Well, guess what? That's another cancer that happens to have a different morphology, so looks matter. This one is very easy for us to treat, super safe. It's never going to come back if we treat it. This one is probably best handled surgically, and if not surgically, then we would have to accept a lesser effective treatment if we have to do it percutaneously, which is possible but not ideal. So why does this sort of alternative surgery make sense? As we've already heard, surgery can be big, can be small. Radical nephrectomy is by far the best option for large tumors, as was indicated to you. But partial nephrectomies have the benefit of preserving kidney tissue. That is what we call conservation of nephrons or nephron-sparing procedures. That is really important because, let's not kid ourselves. If you lose too much kidney tissue, you will go into kidney failure. And some patients are very low risk for that, others are at a high risk for that, and we cannot really ignore that really important part of the whole patient management. Now, the rationale behind using heat and freezing is that this is what most closely resembles a partial nephrectomy. That's really what we're trying to do. We're trying to reproduce what our urology colleagues do with partial nephrectomies, but without those specific techniques. Now, what is the rationale for not taking the whole kidney out? This has been already discussed, but very briefly, and looking at it from a slightly different perspective. Our colleagues at our Mayo Clinic campus in Minnesota, for a period of about 33 years, they gathered a bunch of data, then they analyzed it, and then they grabbed all these radical nephrectomies and partial nephrectomies they had done at that time. They compared those two groups and came up with two that were very similar. So that for a fair comparison, they paired them and came up with a way to make a comparison that was as valid as they could make it without it being a prospective trial. And what they found, without getting into numbers, is that limited surgery was just as good for cancer control as the big surgery. So partial nephrectomy is extremely effective. And the other one that they found was that the incidence of problems with kidney failure were lesser in the partial nephrectomy group. Now, Dr. O'Malley mentioned European data that is scientifically acquired that may not entirely match this, but let's not forget that those are population studies, not individuals. If you have someone who's hypertensive diabetic with a creatinine of 2.0, who has maybe 35% of kidney function left, you do a radical nephrectomy, and that person is going to require dialysis. So this is a real issue. Now, talking about minimally invasive treatments, specifically percutaneous ablations, we've already emphasized that it mimics partial nephrectomy, and it's very simple. All we do is place the probes, do something that kills. We do not remove the tumor. We leave it there for dead, and we have to take with it a surrounding layer of normal tissue. Why? Because cancer is sneaky. It can have little microscopic spread, and if you don't get enough beyond the visible margin, you can have a higher recurrence rate. So we have to make the kill zone just a little bit bigger than the tumor itself. We most commonly use radiofrequency ablation, microwave, and cryo, which is freezing. In our practice, we rarely use RFA anymore. We pretty much have migrated exclusively to microwave and using heat, but both are perfectly viable. Now, this is a beef liver, and what you see there that looks like a little palm tree is one of the many designs of radiofrequency ablation probes. If you stick it into the liver and start applying the energy, you will actually see the bubbling of the steam coming out of those tissues from the intense heat, kind of dripping all over that cut section of the beef liver. And when you cut through it, you see cooked liver. Right? So the temperature that this can reach is considerable. It certainly boils off the water, and that's why the tumor dies. It is impossible for the tumor to survive. In fact, all you need is 50 degrees Celsius for about 5 minutes, and the tissue dies. So when you reach these very, very high temperatures, it's a bit of overkill, but the overkill is not meant to be for the central portion. It's meant to be for the periphery, because that's where our weak spot is. The middle of it is easy to kill. The edge is what we need to try to sterilize. This is a microwave probe. The physics behind it is different, but basically what we're doing is shaking at the molecular level. And as these methods, both radiofrequency and the microwave, make things shake at the molecular level, that friction causes heat to build up. And it's amazing how when you can reach extremely high frequencies, for example, for microwave, the frequency is 15 million times faster than what we get out of an electrical outlet. So it's extremely fast, and that's what makes that temperature from frictional effect rise gradually. Now, let's look at this case, this individual with a 2.8 centimeter tumor. What does it look like on the CT scan? Well, as you saw in the previous example, it's sticking out there. It comes close to the central portion, but not so bad that we can't handle it. 5 months after the treatment, it has the death zone, which really is now a round scar, has shrunk down to about 2.3 centimeters, and it is lifeless. You can see how it was a lighter shade of gray on the left. Now it's dark. That means the blood cannot get into it. The whiteness is given by the X-ray dye that's injected, and the fact that it can't get into it pretty much tells you there's no blood vessels. Therefore, this thing is assumed to be dead. And then 9 months later, it has continued to decrease in size, and you will never be left with something that is spotless. It will never vanish. It will always leave a little scar. With freezing, what we do is we exploit the fact that when gases expand, the temperature drops. When my kids were teenagers and they would go with their Axe deodorant everywhere. It feels so good. It's cold. Why? Because as the aerosol expands out of the nozzle, it cools. That is exploited when we do cryotherapy, and the probe is designed so that the argon gas that passes quickly expands in a small expansion chamber that's at the tip of the needle, and that causes a deep temperature drop. And if you give it enough time, that little ice ball will grow to the maximum size that it is physically able to. So it's just tricks that engineers have provided us with to treat patients. Now, one of the advantages of the cryo is that it allows us to sculpt ice balls that are a little bit bigger than what you can do with an individual probe. So if you put several probes together, they start kind of welding themselves together and forming a more uniform ice ball. And this is illustrated here. That's my hand holding 3 probes after I dunked them in a container with water. And these things look like hot dogs, but if you let them sit there long enough, they will turn into egg-shaped. And if you have them together, those will come together and will give us a bigger ice ball. So it enables us to treat tumors that are a little bit bigger than we think if we use an array that's large enough. Now, this is something we don't do on a regular basis. I got it from one of my colleagues up in our Minnesota campus. And this was in the early days of cryo, when we were trying to understand how it went. So this person was exposed to more radiation than really was necessary. We wouldn't do this nowadays. But it shows how, before the treatment, you have here the probes defining the zone where the freezing will occur. After 2 minutes of freezing, you start getting this dark spot, which is the ice ball growing, 6 minutes, and after 10 minutes, you get the maximum range of effect of that ice ball. So time is allowed to do its thing, the ice ball grows, and then after they give some X-ray dye and repeat the scan, you can see how even this early, this tissue is incapable of soaking up the X-ray dye from the bloodstream the way it is capable before you do this. So it works. And as you can see, the tumor is, the tumor is treated and there is a layer of tissue that needs to go with it to sweep up whatever microscopic spread there might be. So who qualifies for this? We already stated very clearly, pretty much everybody agrees, 4 centimeters is kind of like a magic number in many respects, and that's what we prefer to do, less than 4 centimeters. The smaller the better. Those who are not really great surgical candidates typically come to see us in clinic. For whatever reason. It could be their heart, it could be their age, it could be previous surgeries. We are, in my opinion, quite competitive with partial nephrectomy when it comes to multiple tumors. The person that I have treated the most was a lady that had 8 ablations for 8 different kidney cancers. You can imagine that that person is at very great risk for dialysis, yet she's not on dialysis. She still has enough function left despite having treated 8 tumors. There are some people who just refuse surgery. And there might be someone in this room who refused surgery and had an ablation instead. And people who have the tendency for multiple tumors are best managed with nephron-sparing procedures, whether it's a partial nephrectomy or a percutaneous ablation. As a patient, you come to us. What do you think is going to happen? What does it feel like? What's your experience? Generally speaking, the experience is pretty good. It's not something you would want. You wouldn't choose to have it done, but it is not that bad in general. During the ablation, you're under a general anesthetic typically. You won't know what's happening. You wake up and you feel like someone kicked you in the back. It does, because heat hurts, frostbite hurts. It is reasonable to expect some pain. Nausea, lack of appetite, those kinds of things are quite common. The nausea, in my opinion, is typically related to the anesthesia more so than the procedure itself, but it comes as a package. Then during the first week, the back pain gets better, sometimes overnight. Most patients the next day feel a heck of a lot better. I have had patients who've gone back to work the next day. Others have prolonged pain. In fact, a patient of mine who is funny because I finally stopped seeing her after many years, but she complained to me that her golf swing was never the same after I was done with her. You will always find people with reasons not to be entirely happy, but yeah, there can be some consequences to what you do, but generally speaking, it's minor. After the first week, honestly, most people feel pretty good, unless I mess up their golf swing. So what are the results of the treatment? In other words, what can you expect for the future? As has been already clearly outlined, because we're dealing with small tumors, that is a very early stage, the results are very good. And when we talk about results, we talk about outcome measures. And those outcome measures are all this lingo that we use for epidemiological reasons, and the most important of which is overall survival, but then there's all sorts of variations on the theme. It doesn't really matter. The point is that whether you use heat or freezing, those outcome measures are well into the 90s and very often to the 100% favorable to the patient. So what can you expect from the treatment? You can expect something that is highly effective, just like partial nephrectomy is highly effective. What do we do for follow-up? Well, we need to make sure that we didn't mess up the kidney function. It can happen, especially in those people who are already teetering. We want to make sure that the tumor was treated in its entirety. That's done with pictures, either MRI or CT scan tells us, okay, yeah, it looks like we got it all. Why do we have to check? Well, because there's human error. You know, sometimes there's a little edge that grew in a funny direction and it wasn't noticed, and then it becomes more obvious. So you want to make sure you got it all. Tumor recurrence, of course, is the most important thing long term. It's very rare for anything to happen soon. It's usually down the line years where you start seeing something that might come back. But generally speaking, this is extremely effective. It's pretty much curative in 97, 98% of patients. Tests, the only test that is important to us in regards to this is the creatinine. You want to make sure the kidney function is good. There are no things such as CEA or PSA or all those tumor markers that other types of cancers have. We don't have one for this. Therefore, we cannot use those to follow. We use pictures, MRI or CT scan. I usually see patients within the first 3 months just to make sure everything is good, no complications, and that we got good coverage. But then we will see them once a year, and then the 5-year mark, if everything is good, we just switch to every 2 years. And from that point on, we just continue inviting to come, mainly because you do not know who's the one who's going to get another cancer. The risk of cancer coming back in a different spot of the same kidney or the other kidney is about 1 in 5. And we do not know who that individual will be. So we're kind of forced to follow everybody, even if 80% could be left alone and never invited back. So if you have any questions or concerns, anything you'd like to talk about, please feel free.
Great talk. Thank you so much for expanding on renal ablation. Question, I see myself in practice, how we interpret follow-up images. You know, not every radiologist, I think, is trained to read post-ablation. How do you manage that challenge in your practice, and what advice you have for us following patients?
Yes, there's 2 extremes. There's the world where I work. We've been doing this for over 2 decades. It's so much a part of our DNA that everybody pretty much gets it. And then there is my initial experience, 20-some years ago, when I was angrily called on the phone by a family member accusing me of having lied because I said I would remove the tumor and all I did was make it bigger. Because someone interpreted a CT scan as the tumor grew considerably over the last 6 months. So that is a very important concern. Nowadays, really, the tricky part is distinguishing new tumor growth from an inflammatory reaction to the burn or the freeze. There's something that pathologists report as inflammatory pseudotumor that we see every so often, and it looks ugly. It can look like it's a cancer coming back, but most of the time, the looks of it are distinctive enough that you can sort of tell, that's going to be just an inflammatory reaction that's just growing very slowly over time and not cancer coming back. Whenever there's doubt, of course, we'll have to biopsy it. We do that every so often, primarily to calm people down when we figure this is just an inflammatory reaction. Remember, we're not removing it. We're killing it in a place, and the body will react to it. It knows something went wrong. There's something alien, something dead in the body, and it'll attack it, it'll try to wall it off, it'll scar it down, and then the non-specific appearance of inflammation on a CT scan might mimic a cancer growth. So yeah, it's experience talking to your imaging colleagues and keeping in mind that that inflammatory pseudotumor trips people up all the time.
I'm just curious which real-time imaging modalities you're using for these procedures, and is that operator dependent? Does it vary by institution in your experience?
I love to draw from my professional life because it's like a microcosmos of what goes on at a community level. When I first started doing this, I figured, easy. I can just use ultrasound, room doesn't matter, little sedation, no problem. Well, not so. If you use ultrasound, the problem is that the bowel is very sneaky. All it takes for us to have a little bit of peristalsis and bowel that wasn't even close, now suddenly is there. Maybe the patient that morning happens to be a little gassy, and the gas expands the bowel in a funny way. So I learned a long time ago to just use cross-sectional imaging of the CT scan type primarily. You can use MRI, but CT scan is so practical, and we have the setup for general anesthesia and everything already there, so it makes it so much easier. Another reason why we have migrated to CT scan to a large extent is because cryotherapy is very commonly used. And as you saw in those pictures, the ice ball is less capable of stopping X-ray than regular water. That's why ice floats. Ice floats because it's less dense. So that change in density makes the appearance on X-ray change. So we can exploit that, and then we can actually sculpt. We use that for liver as well quite a bit, and we will use that as a way to sort of know where to go. Ooh, this edge needs to be enhanced, or here we can stop, or we can back off because of the visibility. So we typically will use CT scan for guidance, general anesthetic, and we will use both heat and freezing depending on the circumstances. Yes, sir.
Yes, thanks for a great talk. Focus mostly on using these techniques for kidney tumors, but can you do a minute or two on using these techniques for metastatic tumors?
Yes. If you were to ask one of our medical oncologists in the conference center, they will come up with the term oligometastatic. Okay. Oligometastatic disease just means that you have metastases, but they're few. We have known for quite some time that if you decrease the burden of the cancer in the body, you can improve outcomes. If you have someone who has few metastases, starting out with a burden that it's well controlled, and you control the visible disease, rendering the patient without visible active disease, and then you draw statistics to large groups, you will see that those who have control of their few metastases tend to do better. That's the justification for using both surgery and ablation methodology for metastases. Right? So we don't use it, you wouldn't go crazy with someone who's got a bunch. And in those instances, we have used it in many situations. We've used it in lesions in bone, in lung, in liver. When safe, we can use it in lymph nodes. Even within the same organ that originated the tumor, let's say it's the kidney itself that has maybe a couple of spots where there's a recurrence. After an ablation, perhaps, or after a partial nephrectomy, which we see periodically, we see cases that have local recurrences. We can go back and reablate those. So these techniques are applicable to a very broad range of circumstances, but the kidney cancer that we're talking about here, the typical RCC stage 1 T1A sort. Those are extremely well suited for local therapies, and we can do a lot of good with very little risk. But yes, you're right, we can use it for metastases.
You may have answered this in a different way, but how do you determine whether you use heat or cryo for a particular?
That's a very common question, and the standard answer that I give patients is that once you're on the table under anesthesia and we got you positioned the way you gotta go, we'll know for sure. Because heat and freezing have a lot of things in common, but have some differences that we can either exploit or might be a cause for concern. Heat is very fast, which is very attractive, and the other thing that heat is very good for is cauterizing. So I am of the opinion that if you use heat, you have a lesser likelihood of a bleeding problem. Freezing is less destructive to normal tissues and tends to cause a little bit less pain. So if I think that I'm close to a nerve that might wrap around the abdominal wall or maybe go towards the groin area or the thigh, and I'm afraid that, this person's gonna hurt because it's very close to the abdominal wall and the musculature, I might choose to use freezing instead, because I know that even though they will hurt some, it's not gonna be as bad as we would be with heat. Cryo, that is the freezing, has a lot less effect on the structural collagenous portions of organs. So let's say that we're very close to the renal pelvis where the urine collects. Heat for sure will burn a hole, for sure. Whereas cryo is much more gentle and will allow for better healing. So if we're close to things that we might think are in danger, we might prefer to use the freezing. So there's a variety of circumstances that will help us pick one or the other. But there's a big chunk of patients that could go either one. It really doesn't make any difference. And so we will tend to default to cryo for kidney. But if it's a small little one like the one on that right kidney that I showed you that I described as a little pimple, that would be perfect for heat. Super fast, super safe. It's not going to hurt much at all, and it's not going to bleed. So we will pick depending on the circumstances. Thank you.
Thank you, Peggy, and wonderful to be here, and thank you so much for inviting me to speak on a topic that is really near and dear to my heart. Most of my research has been in the earlier stage of kidney cancer and what we could do to improve outcomes. Here are my disclosures, and I mainly list these also because I've been involved in the development of a lot of the adjuvant renal cancer trials, as well as the PROSPER trial, which will be one of the topics. So what is perioperative therapy? And the reason I titled this perioperative rather than adjuvant is that I'm going to be talking about some clinical studies that also offer some treatment kind of around surgery, not just after surgery. But adjuvant therapy is generally therapy that is given after you've had surgery and you don't have any disease that we can see on a scan after the fact. So I do want to emphasize that surveillance is a very important part of your follow-up. It's probably the most important part of follow-up, and other speakers have gone over this already, but there is some variability as to how often we follow people. I'm not a big proponent of PET scans for following patients because I think they can sometimes be a little misleading. They are great when they do show something. I do have one patient that I follow with PET scans because the contrast is very hard on her system, but she's also, she's got sarcomatoid renal cancer, which seems to light up pretty well with this. And I don't always use IV contrast also when I'm following patients for surveillance. Many of the drugs that are used in treating metastatic kidney cancer have been tested in the adjuvant or perioperative setting. And this slide really shows a lot of the different groups. These are what we call the VEGF inhibitors that target blood vessels. This is an IV antibody that you might know as Avastin. And these drugs as well work in the, also work to some degree in the blood vessel pathway. Hypoxia is lack of oxygen, and that's also this newer drug, belzutifan, is used in this setting. And then the PD-1 and PD-L1 inhibitors are also, that work on the immune system. So especially the VEGF inhibitors have been tested in the adjuvant setting, and there have been actually 6 trials looking at VEGF inhibitors. I've only listed the ones here that have been used for just cancer localized to the kidney, but there was another trial that looked at patients who had metastases removed and the role of pazopanib or Votrient in that setting. And really only one of these trials was what we call a positive trial and showed that there was some efficacy, and that was the S-TRACT trial, where patients with very high risk clear cell kidney cancer either took sunitinib for a year or they took placebo for a year, and that led to FDA approval of the drug. What it didn't show was an improvement in overall survival, and I think by themselves, when we've given these drugs just by themselves, what we've noticed is that it's very hard to tolerate these drugs, more so in the adjuvant setting than it is in the metastatic setting. And I don't know whether, there's a lot of reasons that could be. One of them could be that we just, because there aren't actual cancer cells that are big enough that you can see on scan, that maybe there isn't enough blood vessel to target. And so the side effects might be more directed towards your normal body instead of the cancer cells. It could also be that when you've had your kidney removed and you don't have disease elsewhere, that you generally have a lower tolerance for, side effects. But I think that the other thing about these drugs is that when you're on them for a long time, we're usually on a clinical study capturing severe side effects, but lower side effects are also, over a long period of time, can be quite intolerable. People get sick of those side effects. And these drugs by themselves don't tend to kill tumors. They don't directly act on the cancer. They act on the blood vessels. So we think of them as controlling disease, although I will tell you that I have a few patients with metastatic disease where the tumors have disappeared, and we followed them for very long periods of time off of therapy. So this is a trial that was a clinical study that was presented earlier this year, the Everest trial. This was a trial that's been going on for a very long time, and it used the pathway of being an mTOR inhibitor, and that's why I listed it separately. It was everolimus, or the patient population knows it as Afinitor. And this used the same very broad selection of patients that we used in some of the earlier TKI trials, like the ASSURE trial. So it did include some lower stage patients, and these patients took everolimus for a year, or they took a placebo that looked like a everolimus for a year. And it very nearly missed its endpoint. You can see that the people on the Everest trial did do a little bit better than the ones that were on the control arm, but it wasn't enough to kind of meet the bar that they had defined. So it's not very likely that this drug is going to move to this indication, through the Food and Drug Administration. I'm going to focus mostly on the immune checkpoint inhibitors and the CTLA-4 inhibitors that you've heard a little bit about by Dr. Hammers. And the main emphasis here is what these drugs also don't, in general, work directly on your tumor. What they do is they get your immune system to work on your cancer. So they make your immune system more hypervigilant. It makes it recognize things that are foreign in the body, and it kind of revs up the immune system. So it doesn't immunosuppress you, it actually revs up the immune system. And the first trial is the Keynote 564 trial, which was these results now have been around for around a year and a half. And this was a study that focused on patients who had cancers that were at least 7 centimeters and had kind of angry-looking nuclei under the microscope, or they had some spindly cells, which we know can make people more high risk, or they had a larger tumor that was greater than 7 centimeters and had invasion of the fat or the blood vessels, or even more invasive than that. Or a very small number of patients had some metastases that were removed within a year of having their original kidney mass, and so they were considered very high risk as well. And this trial was really restricted, again, to clear cell kidney cancer, and they were looking to see whether giving this drug for a year, which was an IV infusion every 3 weeks, would decrease the risk of developing metastatic disease. And you can see here that it did achieve that. This is when the study was first presented about a year ago, and this was a little bit longer. You can see that patients continue to do well. You can see overall that everybody, though, seems to do pretty well. I want to point that out. There's a lot of patients who have not relapsed even on the control arm, but you can see that the patients that got pembrolizumab are continuing to do better. And we don't have survival data that is mature yet in this population. We're following it. We have not seen a difference in survival yet. I'm going to, before I talk about side effects, talk about 3 other trials, studies that have been recently presented at a European meeting in September called the European Society of Medical Oncology, or ESMO. And these were 3 other studies using immune agents that I think we were a little bit surprised about the outcome. The first is Emotion 101, which used a different drug. The drug is atezolizumab, and this drug is also known as Tecentriq, and it is what we call a PD-L1 inhibitor. So that one, PD-L1 is expressed on the tumor cells. So it works on the immune system, but it also targets the tumor cells. And patients got this for a year, every 3 weeks, or they got, again, an IV infusion that looked like atezo. And it was a fairly similar group of patients as was enrolled on the Merck trial and on the pembrolizumab trial. The endpoints were fairly similar, and unfortunately, as you can see, this is what we call a disease-free Kaplan-Meier curve, and you can see that the curves are really pretty much right on top of each other, which means that we didn't really see much of a difference. There are many reasons that this could be. I would want to remind everybody that these studies were all conducted during COVID-19, and so, the follow-up, how some visits, might have been telemedicine, there might be delays in therapy and stuff. It might have something to do with the drug, it might not have something to do. It's very hard to parse these out, but it was a little disappointing that there wasn't an overall improvement in this. The next trial is Checkmate 914. And this was a trial using, a study using nivolumab or Opdivo with ipilimumab or Yervoy. Those are the commercial names. And this study also looked at this population, and what it showed, there were 3 arms to this trial, and the only 2 arms that we know anything about are this arm, which is the ipi-nivo, and the placebo arm. We do not know the results of just getting Opdivo in the adjuvant setting yet. I do want to point out a couple things. When we treat metastatic disease, we generally give this combination every 3 weeks. And so there was some difference in the schedule. And the reason that was done was it was thought to be a little bit more tolerable. And the second thing is that this was only given for six months rather than a whole year of therapy. So those were some differences from the other clinical studies. And so far what we know in this is that there also was not a big difference in how patients did on this trial. They didn't seem to do much different. And so there's a lot of speculation also about why could that be, because certainly I should mention both atezolizumab and ipi-nivo are very active in the metastatic setting. And so, one of the possibilities, I guess, could be that, maybe you need, because ipilimumab helps with T-cell memory, maybe you need a tumor mass present when you do this. There's a lot of reasons we don't know. There were a lot of side effects with this trial, and a number of patients had immune side effects that they had to stop treatment or they had high-dose steroids. So a lot of this is still being analyzed, and this is also not published yet in a manuscript form. We do know that looking at the subgroups, that there were some, this is what we call a forest plot, there were some subgroups of patients that might have done a little bit better, and I'm sure the company is going to be looking at that. And in all of these, I want to emphasize that really, even in trials that we don't show a benefit, it's so important to be able to look at patients' tissue, because we can often learn a lot about whether there's an immune response in tissue, and even looking at the baseline tissue, whether there are things like what we call pathomics, where there's artificial intelligence being developed to kind of identify signatures and stuff. And so even in a negative trial, it's so important when patients are willing to let us look at your tumor samples and participate in correlatives, because often we can figure out why something isn't working or why it is, and we can also home in on a narrower group of patients that might respond. So the last trial is the PROSPER trial, and this was a trial that was developed with patient advocates. And we were very excited about this idea because in mouse models, it looked like if you treated a mouse model, mice with these kinds of drugs, especially nivolumab, that we saw a better priming of the immune system. So this trial was designed in such a way that if you enrolled on the study, you either got a dose or a couple of doses of nivolumab before your surgery, and then you went to surgery, and then you got nivolumab for about 9 months after your surgery, or you just had regular old surgery. And importantly, we did not have a placebo arm in this. We had an observation arm because we had a lot of input from patients, and they liked the design of that. And I can think of good things and bad things with that. One good thing is that you're not going and getting an IV in your arm for nothing. On the other hand, sometimes if a patient knows they're on this arm or the physician knows that they're on this arm, sometimes people act a little bit different on a study. So that's another area of debate, I think. But anyway, we were following these patients, and the other important thing about this is enrollment was based on the size of your cancer on a CAT scan or an MRI before you went on study. So if you had a cancer that was at least 7 centimeters, you could go on this trial, or if it looked like it was invasive. But we didn't actually know what the histology was ahead of time. So patients with either clear cell or any other kind of kidney cancer could go on this trial. And they did have to have a biopsy if they were on the trial that was on the side that was getting treated, because you want to make sure you actually have a cancer before you get treated. Unfortunately, we did not see a difference in how patients were doing on this, and we saw that signal relatively early, and so it was really back in March last year. Some of the last patients were even just completing their therapy that we released the data that we did not see a difference, but we're still actively looking at the tissue to see, especially in this where we have samples both before and after surgery, can we learn something about who might have benefited and why other people didn't benefit, and again, it's very important. So the last part of this, I just want to focus on the pros and cons of getting immunotherapy, and I think you'll have some other information later about this as well. But remember, what we're doing is getting your immune system to attack your cancer. But sometimes it goes into overdrive and it can do other things. So it can really attack anything it wants to, and you can get inflammation, and that causes some of the side effects that you can get. The most common is tiredness or a rash, but you can sometimes get some more severe side effects, such as attacking your nervous system or attacking your heart. And those are very, very serious side effects. So the main thing about this is most of these are very responsive to treating with steroids, but the drugs last a lot longer in your system than the pill therapies. The pill therapies usually wash out after a couple of weeks. The immune therapies can last in your body for even 100 days. And once they turn on the immune system, they might even last for several years. And that can be good. We know that if you get some of these side effects, it can be indicative of response. But if you get a really severe side effect, which is generally only about 1% to 2% of patients, but if you're that patient, if you get diabetes, the diabetes isn't going to go away. If it attacks your adrenal gland, it's not going to go away either. So that's really food for thought as far as who should get adjuvant therapy, who shouldn't get adjuvant therapy. And I'm very much a believer that it is a shared decision-making, that not everybody is the right person to get adjuvant therapy, but there are a lot of people that can benefit. There are now 2 drugs that are approved, pembrolizumab and sunitinib. So it's wonderful to have some options, but I would also say that we have a whole lot to learn, and I think that surveillance is a good option for some patients, but we also need to get a much better idea of who we are over-treating and who we are under-treating. There are certainly patients in this category that are never going to relapse, and why is that? And there are other patients that have something that you think is very low risk, and they are going to relapse. And the only way that we can really learn from that is to continue to do smarter trials with looking at your tissue, looking at your blood sample, doing that biomarker development that hopefully we can get to where we can assign people to a trial based not just on what it looks like under the microscope, but on biomarkers. And I will stop there and thank you. Happy to take questions, or maybe you want us to wait until the end.
Gentlemen. Hi, thank you. I did have a question about the process. I'm curious about the biopsy, since you said you don't want to treat patients without being sure they're kidney cancer yet. You will operate on patients based on the clinician thinking that it's cancer. Can you explain a little bit more about that statement?
Well, I think that people are doing more and more biopsies these days, especially if the kidney cancer has spread to other organs. Anytime that you're going to offer a drug before you take a kidney mass out, you really do have to prove it. But we are getting better. I mean, it is quite easy to tell on imaging generally what is a kidney cancer and what isn't. I think the main thing is you can have a urothelial cancer that you might not want to treat the same way. A lot of times oncocytomas, chromophobe, and papillary are quite easy to tell just by looking, and we are getting some really cool radiomic and pathomic high-level things to hopefully do better with that. Did that answer your question?
More or less.
Okay.
Yeah.
Oh, yes, in the back.
Thank you so much for that excellent talk. I think, it's been a challenge about how to, counsel patients on these adjuvant options, given that we've had kind of more and more of these, unfortunately, negative trials. I think a lot of us think that there may be some differences between pembrolizumab, nivolumab, atezolizumab, but maybe not a tremendous difference. And so does there potentially come a point where we say maybe the Keynote study, that is the adjuvant pembrolizumab study, maybe that was a false positive? I mean, are we looking for overall survival results? I mean, how do you personally counsel patients on this difficult question?
I think it's very important. I think that you're not going to see a lot of clinical studies that have overall survival as their first endpoint, because those studies take way longer. They can take 10 years to get that answer. So it's usually a secondary endpoint, but it's a very important endpoint. And again, I don't think everybody should get adjuvant therapy. I think it is really a individualized conversation, and often people come in with a kind of a gut feeling of what they want to do too. I mean, I think the risk is if your cancer recurs, then the fear is that it's not going to be curable. But I think we also have examples that when people recur, sometimes it's very indolent, and sometimes they get a real home run with immunotherapy that it does completely disappear. But it really is a balance between side effect and risk. Thank you.
Thank you to Judy Nicholson Foundation for inviting me to give this talk. It's really an honor and pleasure to talk to patients and caregivers in this setting where I get to explain what goes on behind the scene. So with that, I have no financial disclosures other than me being a radiation oncologist, and these are some of my funding sources. So did you know that there is no such thing that a tumor cannot be eradicated with radiation? I love the nomenclature that my colleague Dr. Haas used, the death rays. So with high enough dose of radiation, all essential cellular processes can be disrupted and we can cure any cancer. So why don't we kill every cancer? And the reason is collateral damage. So collateral damage has plagued radiation therapy for over 100 years. Normal tissues suffer the similar fate, and the dose of radiation that kills the tumor also can not be tolerated by the normal surrounding tissue. So radiation travels only on straight path. It does not bend. So how do we target a tumor deep within the body, surrounded by normal tissues, without hurting the organs? The answer is magic. Any sufficiently advanced technology is indistinguishable from magic. And today, what I am planning to do is take you behind the scene and show you exactly how we do that magic. And I'm going to demystify all these terms that you have heard about: 3D, conformal radiation, IMRT, all these terms gets thrown around. But today we'll learn exactly what they are and how they work. So the most advanced form of radiation that we now apply to kidney cancer is the stereotactic radiation. You will hear SABR, you will hear SBRT, you will hear gamma knife or cyber knife. All of them are using the same stereotactic technology, so those will be used synonymously. So for the purpose of this talk, I'll call them SABR. The important thing to understand is SABR is not a standalone new invention. It is actually built up on previous technology. So to really understand SABR, you need to start from the 3D conformal radiation and then work your way up, and it's a culmination of all those technologies. So with that, let's get started. 3D conformal radiation, something that has been discovered way back in the 70s, 80s, and was the mainstream of radiation. How does that work? So let me explain you a few things first on the colors. So when we try to portray radiation and how much radiation we have delivered, we use colors and a color spectrum. So where blue is cold, meaning less amounts of radiation, orange is intermediate, red is hot, meaning that has received the highest dose of radiation. And this is really very helpful to understand and analyze radiation plans and things like that. So in a conformal 3D radiation, you bring the radiation from different directions and they march on the target. So here you're seeing the prostate, and because you brought the beam from 4 different directions, you have a square where it is hot because the radiation converged there, but a lot of surrounding tissues like the rectum and others are cooler. Okay, so now you can imagine that a more advanced form of this, we can bring the radiation from 5 different directions, and now you have a pentagon. So now you have a more sparing of the rectum because you have a pentagon. Similarly, you can bring the radiation from 10, 15, 20 different directions, and you start carving out a circle, and that is more focused and more conformal. So this was the first development of technology. We call this 3D conformal radiation. The next technology is IMRT, which is intensity modulated radiation therapy. So what is intensity modulated radiation therapy? The hallmark is this multi-leaf collimator. So these are thick lead leaflets. You can see that they are almost 6 inches in thickness, and they can move and take the shape of the tumor. So now instead of having an open beam, you have a beam that has taken the shape of the tumor from that direction when we are bringing the radiation. And to point out the difference in the dosimetry, let's go back to the previous slide. And you see that inside the beam, the dose is even. It's the same color. So there is no intensity modulation there. But now, when you bring those same beams, inside the beams, it is not even color. It is taking the shape of the tumor from this direction. So now it is intensity modulated radiation. And then by bringing it around with 5 different beams, again, conformal radiation technique of bringing radiation from different directions. Now, not only that you have a circle, but you're starting to carve out. You see the curvature. You're getting the concavity. So now you really can spare the rectum in much better ability. So that's intensity modulated radiation therapy. And I have a video to show you how it works, and hopefully it works. Let's see. Okay. So there's the radiation machine. This is the gantry that's delivering the radiation. Built into the gantry is these multi-leaf collimators that are moving as we deliver the radiation, taking the shape of the tumor. So it does that on one side, and then it moves to the other side. And then you have the prostate and the rectum. Goes to another side and gives the radiation. Again, the collimators move. And at the end, you have radiation that has carved out the rectum and only delivered to the prostate. And this is just taking prostate as an example, but it could be any organ essentially in the body. So the next advancement is a more advanced form of radiation, advanced form of IMRT called arc IMRT. So what is arc IMRT? You can imagine that instead of beam going in one place, stopping, giving radiation, one, it is taking a long time, And 2, it is limited because you can only do maybe 10, 15, 20, 30 beams. But ideal would be if it goes continuously in an arc, and at the same time it is going, the collimators are changing to take the shape of the tumor from that direction. And at the end, what you have is an infinite number of beams that are delivering the radiation, so you get the maximum conformality or sparing of the normal structures. And we have a video to show how that works. So here you have a tumor that is actually, next to the critical organs like kidney in the parietic region, and the gantry is going in a continuous motion, delivering the radiation and painting the radiation dose right onto the tumor. And at the end, you have some blues nearby getting lower dose of radiation, but the tumor is really getting hot and getting the ablative dose of radiation, despite having all these critical structures nearby that are getting spared. So that's the newer form of IMRT, which is the arc IMRT. So then next thing is, you're giving all this radiation, but how do you really know it's going and it's hitting this spot while you're giving the radiation? And that's what is image-guided radiation. We call it IGRT. And what is image-guided radiation? You have the normal radiation apparatus, which is the gantry and the linear accelerator delivering the radiation. Onto that, we add an X-ray source and an X-ray detector. This is the source and the detector. So while the patient is laying on the table, the X-ray source can do the X-ray, but also it can go around and do a CT scan at the same time. So while you're delivering the radiation, now you can see the tumor and you can make sure you are hitting the target. The next problem is tumor motion. And you will see the problem right here. You have the tumor in the lung, but it's not in the one place. It's continuously moving. So what do you do with a moving target? How do you do focused ablative radiation on a target that is moving? And here is a kidney. Didn't work. Let's see if this one moves. Okay, this movie is not working, so you may have to take my word for it. That the kidney also moves quite a bit with breathing motion. So not only just the lung tumor, anything around the diaphragm is actually going to move quite a bit. So the question is, how do you target that? One of the ways is to develop the technology where we can image this motion. So the fact that this is you're able to see this motion is the fact that we have this new technology called 4D CT, 4-dimensional CT, that takes into account breathing motion, and we can generate the location of the tumor with your breathing cycle. And now we know where to target the radiation at that moment in the breathing cycle. So that's one of the techniques of accounting for tumor motion. There is another technique, and there's a number of other techniques actually. One of them is the gating, which will be shown by this video if it works. So here the tumor is moving with breathing, and at the same time X-rays are detecting the motion of the tumor, and that information gets fed into the machine, and the radiation beam moves with the tumor, and this is called tumor tracking. So with the development of all of these technologies, now you're ready to target tumor that can move even, and with the precision and conformality to do stereotactic radiation. So combine all of this technology and another technology that we developed, which is the body frame. So one of the things that body frame does, it has a coordinate system in its own. So it brings a GPS system to focus the radiation further. So you can imagine that a GPS that is telling you where the car is going may be accurate to only 100 feet. But bringing the GPS system closer, now we can have millimeter precision. So what the result of that is, now you have a tumor that is deeply seated into the thorax, where you're right next to the esophagus and heart and the trachea and other critical normal structures. But you're still able to give maximal dose of ablative dose to the tumor with minimizing collateral damage and toxicity. Very convenient 1 to 5 fractions, where a patient is driving in, getting radiation on their lunch break, going back to work on the same day. And it is completely non-invasive, convenient, and cost-effective. So that's what stereotactic radiation is. So with that, we have the technology, and a lot of technology that we have developed is really important that allows us to do this. And we have done a lot of research and funding that was given to us to develop and some of these technologies and apply them. So what can we do now that we have stereotactic radiation? We can apply it to kidney cancer. So what are the effects? So we completed a phase 2 clinical trial recently that is currently under review, where we enrolled 16 patients with the kidney cancer. We treated them with SABR of 3 to 5 fractions, and we confirmed with post-treatment biopsy on the tumor control. We showed that there is no high-grade side effects, and the cure rate was 94% with no grade 2 or higher toxicity. So this is one radiation effect. So I'm going to briefly go through some of the other potential applications of SABR now that we have this ability that we did not have before. How do we integrate that into the management of not only primary but also metastatic kidney cancers? So in the metastatic setting, we looked at treating patients with all metastatic sites just to see, what the local control is. And in a retrospective study that we published of 175 patients treated, 175 metastatic kidney cancers treated with SABR, and we saw a local control rate of 90% with no reported high-grade toxicity. So for selected patients in the oligometastatic setting, I know oligometastasis was brought up before, we did a phase 2 trial where we showed that in 1 year, we can control the cancer in more than 90% of the patients. Again, patients had very good quality of life because these are not systemic therapies that are generally slowing down the patients and giving systemic side effects. No greater than grade 2 side effects. And on an average, we control on median time to control the disease for these patients for close to 2 years. So this was impressive, and to emphasize, these are very selected patients, so this is not applied to all metastatic patients. Selected oligometastatic patients can do really well with this strategy. So based on the results and promising results of this strategy, we are actually now designing a large randomized phase 3 trial, and some of them with help from patients like you, where we will compare head-to-head to see if we can change the standard of care. We'll compare systemic therapy versus stereotactic radiation to see, one, if it can maintain the same level of overall survival that the patient is having with systemic therapy, and at the same time preserve or improve quality of life for our patients. Another setting could be using SABR to improve the efficacy of ongoing systemic therapy. So this is what we are calling oligoprogression. So these patients are on systemic therapy, but 1 or 2 sites have stopped responding to the systemic therapy. So the patient could be tolerating the therapy well otherwise, and we know there aren't too many effective systemic therapies available down the line, so it makes sense to maximize the duration of the systemic therapy use. So 1 or 2 tumors could become resistant, and we could take them out with stereotactic radiation, and that's what we have done with this trial. So you can see the systemic therapies in some instances were started a long time ago. They received the radiation, and after the radiation, on an average of almost a year, we could extend the duration of that systemic therapy, again with minimal toxicity. So this could potentially be another application of SABR. So now, SABR side effects, but what about benefits? Did you know that focused radiation can have significant immune stimulating properties as well? So there is this thing that was reported a long time ago, which is called an abscopal effect, and this is how the abscopal effect works. If a patient has 3 sites of metastasis, A, B, and C, sometimes we give radiation to A, and we see that A responds, but not just A responds, B and C also responds. And this is what we call an abscopal effect, or a systemic effect of radiation. And a lot of studies have shown that this is actually mediated by an immune response. So what we think is that and we have seen this in our patients in an IVC tumor thrombus trial, where we treated the thrombus in the primary kidney away from a lung metastasis. And after the treatment, we saw that initially the tumor got a little bit bigger, and then it completely disappeared. This metastatic site did not receive any radiation, and this patient did not receive any immunotherapy either. We biopsied this tumor, and we saw that the biopsy showed intense infiltration of immune cells that are sort of eating up the tumor. So we think this is happening because when we radiate tumors, it not only just kills the tumor cells, but it also induces an immunogenic cell death. It brings in the T cells and dendritic cells from the immune system to educate the T cells, which can then go out into the circulation and fight the tumors and remove the tumors in some instances. And with that, we started a strategy where we combine immunotherapy with stereotactic radiation. We are calling this the I-SABR strategy to see if we can enhance the outcomes of immunotherapy. As you know very well from our previous talks, immunotherapy has been a great success. For kidney cancer, the response rate has been 40%. Similarly, for lung cancer, bladder cancer, head and neck cancers, there has been improvement in outcomes shown with immunotherapy. But by no means we know that it is not a home run. Partial responses are between 20 to 40%. Only some patients are cured, even though majority are living longer, but they're not cured. And there is toxicity that has been pointed out as a significant problem. So what we need to do is we really need to understand the mechanisms of immune modulation better. Therapies must avoid the toxicity and particularly an overreactive immune system. And the triggering of the immune response must be more comprehensive and tumor specific. So what immunotherapy really needs is a potent local trigger, and SABR doing pinpoint radiation to the tumor, avoiding the normal structures, can be that trigger where it kills the tumor cells but also starts educating, exposes the tumor's DNA for sensing by the immune system, and the result could be the T cells activated, ready to fight the cancer, and brings the non-specificity, brings the specificity to the non-specific immunotherapies that are available. So we did a trial in the mice where we took a mice tumor and we randomized the mice to 5 groups, one receiving cancer vaccine, one receiving cancer vaccine plus radiation, radiation alone, no treatment, and non-cancer vaccine. And what we saw is that the tumor sizes with, of course, control treatment grew bigger. With cancer vaccine itself, it was a little bit smaller. And then with radiation, it was yet a little bit smaller. But when we combined them together, we really saw complete disappearance of the 60% of the mice, tumors in the mice, and 40% there was small tumor that did not grow much. And you can see that I carefully removed the identity of the mice to not do any HIPAA violation. You really never know where the HIPAA police are nowadays. To go on with I-SABR, we were one of the first to register I-SABR plus IL-2 clinical trial, and Dr. Hammers here has reported positive outcomes of the RAD-VAX trial, combining Ipi/Nivo with SABR increasing the response rate of Ipi/Nivo. And now we're designing another trial that we're calling the SPARK trial, where we are combining SABR with STING agonist and nivolumab for kidney cancer patients. So with the continuing to develop the technology, we hope to reach the future of kidney cancer treatment by doing more focused and pinpoint radiation, by bringing the proper trigger to the immune system and enhance the non-specific immunotherapies that are out there, by also at the same time reducing side effects. And with continued clinical translational research and support from you, we hope to reach the routine outcome of abscopal effect for patients and not just the sporadic ones. With that, thank you very much for your attention, and I would be happy to take questions. Yeah, there are a lot of trials going on investigating abscopal effect, not just in kidney cancer, but also other cancers where we combine radiation with immunotherapy. it's going to take some time to figure out exactly how this works, and trial and tissue and translational research is really the key. The IL-2 trial I mentioned, we actually published the results that I did not bring in, and it actually did not improve the response rate of IL-2 by itself. But we have done careful translational studies to figure out exactly why, and now we are working with different regimens of this stereotactic radiation, giving it in a cancer vaccine schedule. We think that is one thing that could potentially improve this. So a lot more research needs to go on, but I am optimistic that we will be able to figure this out down the line.
Is there anything coming out about like where there's certain spots that are radiated or make more of a difference than others in the body?
Absolutely. So there could be tropisms of tissue and organ that are more immune responsive because of their blood flow, because of the histology or architecture. We have actually seen that. I know one of the retrospective studies and also the IL-2 study, we noticed that when we do lung radiation compared to non-lung radiation, the response is more immunogenic. Similarly, the bone radiation was not as immunogenic as non-bone. So yes, that's a very good question, and this is a more place where we need to understand more.
Yeah, another thing that can be done, so for example, to the Radvax trial, we have a follow-up called Radvax 2. And the difference there is that we will actually do PD-L1 PET imaging of the patient's tumors. Because we didn't know what should we actually radiate, right? You may radiate an already hot tumor, so it may not really add anything. So that will allow us to actually select the cold tumors, and then we can see what happens to the cold tumors. So I do think, we've not done well in humans how to study the abscopal effect comprehensively. And so there are a lot of critics, including myself, so to say, where we say, okay, we need to be really much more stringent in how we evaluate that and how we go about it to demonstrate that this is particular effect. We do it reasonably well in mice, but human and mice are not always comparable, especially when it comes to human.
Human systems are a lot more complex, and for that reason, we do need to do a lot more clinical trials and translational studies to understand it better.
The whole concept of the abscopal effect is incredibly attractive, because you figure, wow, if we can do something here and it has a global effect, then we want to exploit. And efforts so far that we have been involved with have been very hit or miss. Most of the time you don't see that, but when you see it, it's just a wonderful spectacle. What's important to know is that the key is the exposure of the innards of the cancer to the body's immunity. And you can achieve that with any of various mechanisms. One of them is radiation therapy, but we have done it with something called IRE, irreversible electroporation, and we've also done it with cryotherapy, especially targeting the liver. And you do see this sort of effect. The biggest frustration is that you have no clue who's going to have that effect, and it's a minority. But I think that there's a lot of ways that this can be achieved, and it's when you see it, you're in disbelief, because it really is a fantastic effect.
And if you don't look for it, you will actually not see it. So it's to be able to know that there is something like that goes on. I mean, what you say makes me again remember IL-2 experience, where there is very small number of patients that are getting these amazing responses. Same thing even with Ipi-Nivo, there is a small percentage that gets these amazing responses. So there's multiple things at play that we understand. It's not just immune response, it's also immune suppression. And then, so it is complex, and that's the reason we need to do more research to understand exactly which patients can have abscopal effects, why they have it, and how we can enhance it or use it to make more patients get that experience.
Dr. Hannan, the experiment that you did with that was done with mice, we talked about the origin of the cancer vaccine. Can you just expand on what that actually is?
Yeah, sure. That actually was a PSA vaccine. So these mice were growing prostate tumors that was expressing PSA. And we used PSA vaccine as a proof of strategy. And, I provided the citations and the results were amazing. This is one of the things that actually I did early in my postdoctoral years that really got me into this field of immune modulation and radiation.
But was it, did you use it as a proxy for immuno-oncology drugs?
So that PSA vaccine now, I believe, completed phase 2 trial, and it's being investigated further. Right. Thank you very much.
All right. Good morning, everyone, or almost afternoon. First, thanks to the foundation, obviously, for letting me come up here and talk to you guys today. So a little bit of a change of pace. We talked about some of the rare tumor types, and that sort of gets to some of this here. But when, I think it's important to make a difference. We talk a lot about molecular profiling, next generation sequencing, right? And that's all to study the tumor, right? How does the tumor change from normal cells to tumor cells? And those are very important. What I'm going to be talking to you is a little bit is what we call hereditary, or earlier we talked about one of the presenters used familial, a little bit interchangeable. But these make up about 5% of all patients with kidney cancer. And I think it's not too much of a stretch to know that we're sort of probably only at the tip of the iceberg. There's probably more that we don't know about. And so there's a lot of people studying this as well. But hereditary is treated differently both at the beginning and in surveillance and in every consideration of when you manage these patients. So the last presenter stole the line I was going to say, if you don't know about it or you don't go looking for it, you're not going to find it. And I think that's very important in these patients. And a lot of what I do is educating providers because a lot of times these patients, they don't come across them very often. And if you make a ill-advised decision early on in their treatment, it a lot of times has long-term consequences. So I think a little bit today, just talk about the epidemiology, like I mentioned, who this affects, how common it is, and then hit some of the sort of major hereditary syndromes we talk about typically. A little bit about the pathology, and a little bit about the molecular pathophysiology, and then again, sort of getting to the management of these patients, because they're each sort of unique and as a group are treated very much different than sporadic patients, which is majority of the patients we see. So this is a slide that's been shown several times before, right? Clear cell is what we talk about most, and that's the most common one, but it's also associated with probably the most famous of all these hereditary syndromes, which is VHL, von Hippel-Lindau. There's excellent groups in support for this because it is the most common hereditary tumor we see, and so it sort of has the most data behind it, pretty much at the clinical level, scientific level, and it's probably the one that sort of is the flagship for hereditary renal cell cancer, but there's obviously other types. I think it gets more and more complicated as we know more about these tumors, we start to learn more about their mechanisms. In fact, some of these tumors are known to be hereditary, like FH deficient in some of those, and those are now specifically their own tumor types, right? They used to get lumped in with the papillaries and some of the other ones, but now we recognize how important it is to know about these specific tumors up front, that the pathologists have really done an excellent job in carving out these ones, other ones like tuberous sclerosis and stuff like that. So this is sort of a broad, overall picture when you look at some of the hereditary syndromes. The clear cell type, again, like I mentioned with VHL, is the most common type. There's other types, like BAP1 is a syndrome more recently described that's associated with this tumor type. The papillary or MET is a relatively rare hereditary finding, but something we know in sporadic. Folliculin, which is associated with hereditary or with Birt-Hogg-Dubé, sort of usually encompasses the chromophobe or these hybrid types, oncocytomas, and that can create some diagnostic and treatment dilemmas potentially. Mentioned the FH deficient ones, which again, classically we lumped in with the papillary type 2, but we recognize that these are very distinct tumors and again, treated very differently. So it's critical to make this assertion. Along with the SDHB or the other types in the tuberous sclerosis. So sort of go through these ones real quick. So von Hippel-Lindau, sort of every hereditary talk starts with this one, and for good reason, because it is the most common. It's something that's been well described out of the NIH for several decades. And we manage these patients differently, but we think that, most of these patients, they come with a family history. The problem, not just within urology or medical oncology, is we don't always have enough time to ask these critical questions to our patients. And again, if you don't ask, you're never going to know. But a lot of times when I see patients, especially in the community, if you take the time to ask about their grandfather or their kids or something like that, some of these things come up, and those should be red flags because many patients will present. It's estimated about 70% of patients with this alteration will go on to develop RCC, so that is one of the biggest manifestations, but it's not the only one. And again, this is a critical juncture where we can sort of get stuck in our lane and think kidney cancer, but these patients, many of them, including VHL, can be affected by a myriad of other diseases and cancers, and that's why it's so important to identify them. The typical age of presentation is obviously much younger, right? Most of the sporadic patients we see are usually diagnosed around mid-60s. These patients typically present in their 40s, even 50s and stuff. Now, that's just the average. You can certainly see patients younger, and we do, and you can also see patients older. So you can't use age as the one objective way to sort of screen for patients, unfortunately. So again, this sort of gets into some of the different manifestations, and these are critical. Obviously, we talked about kidney cancer as being one of the more prevalent ones and certainly one we focus on, but these patients are also at risk of adrenal, pheochromocytomas, paragangliomas. Those are very important because those can be functional, right? Those can have a dramatic impact on whether patients, if they recognize them or don't recognize them, they can produce lots of symptoms, and absolutely critical that you know about it before those patients go on to surgery or some kind of intervention because they can have catastrophic effects if they're not recognized and treated appropriately. They also can develop retinal angiomas, which can obviously deal with patients' visions, and you want to catch those as early as possible too, because that certainly affects quality of life. Other things we see is a lot of times these patients will have pancreatic features, cystadenomas. Again, some of those have malignant potential, and they certainly need to be followed. They can develop into neuroendocrine tumors and stuff like that. One of the other big ones is meningioblastomas, and those can occur anywhere sort of in the central nervous system. Again, those are catastrophic events. If they go unrecognized, you're talking about paralysis, stroke, you're talking about bad things. So it's really important that patients, know about this risk. Again, that's one of the, I think, the difficult thing for anyone who treats a lot of kidney cancer patients is having this conversation. Not only are they coming and saying, hey, guess what? You have a tumor, you have kidney cancer. That stinks, right? You know what stinks more is you are at risk of developing all these other cancers. You're only 40, and we need to hook you up with. That's a very overwhelming conversation and one of the more difficult ones I have with patients. But our job as physicians, I think, is to be transparent and to have those conversations as unpleasant as they can be. But a lot of times once patients get over that initial shock and you see these patients lifelong, because these aren't, all those surveillance things, those don't apply to these patients, right? These patients for the rest of their life need to be under the care. But a lot of times those patients are very grateful later on that somebody took the time. So in managing these patients, specifically when it comes to kidney cancer, we use this classic 3 centimeter rule. It came out of the NIH studies, but a lot of times for patients with kidney tumors, we wait until they reach 3 centimeters before we do any kind of intervention. The rationale behind that is that studies, again, pretty well characterized studies at the NIH show that the metastatic potential, meaning the risk of these tumors spreading, seeding around the rest of the body, are very low until they reach that size. In fact, many of the VHL patients, the biggest risk to their life typically has been not the tumors themselves, but us going after the tumors, meaning that patients who get renal failure dialysis, right, these are younger patients, that ends up being one of the biggest risks to their mortality. And so we got to balance, treating tumors with obviously over-treating and worsening their renal function. So that's an important thing. So this 3 centimeter rule is sort of employed. And we do use it in some other syndromes. It's not has been justified, but again, because of this one being out there for so long and well characterized, we do use it. One of the important things, again, is if you recognize or have a high suspicion that these patients are hereditary or VHL, and this pretty much applies for any of them, partial nephrectomy should be employed whenever possible. One of the, again, things that we try to avoid is you have a young patient who had a radical nephrectomy on the outside who comes to see you as a second, and now you're already sort of behind the 8 ball, right? They only got 1 kidney, and they're going to get other tumors, right? So, low threshold, if you're not comfortable as a provider doing these, refer them to somebody who is, because these patients need every chance they can to hold on to nephrons. One of the sort of nice new drugs, and it's been mentioned a couple times here, is belzutifan, right? This is now an option for patients with von Hippel-Lindau disease as a way to non-surgically manage their kidney tumors. There's still a little bit of debate, and again, because it's only been out for about a year now, we'll have to see where it falls and who gets it and who doesn't. I think there's probably more value for this drug in actually treating some of the tumors outside of the kidney than the kidney themselves, namely the meningioblastomas, but it is an option for some patients, and some patients who have had 5-6 surgeries, it's certainly something to consider. So again, for these patients, they need surveillance for the rest of their life. We do it a little bit different than we do it for the sporadic patients, because again, we have to think long-term here. One of the things, these are the recommendations sort of through the NCCN, and the VHL Alliance is an excellent group that has all this data too, and for those patients who, I strongly advocate going to their website and learning for them too. But patients here need an MRI of the abdomen yearly, and this is again to assess not only their kidneys, but the pancreas and the adrenals. Again, looking for paragangliomas, which are sort of nerve sheath tumors, which can again have a lot of effects as far as hormone and epinephrine production. Again, they need to have yearly testing for plasma metanephrine. So some urologists do that, some don't. Endocrinologists do. So getting them employed with endocrine, if needed, is always a good idea. And again, that's to check for the production of these plasma metanephrines, which can be elevated in these paraganglioma or adrenal tumors. And then every 2 to 3 years, the recommendation is for these patients to have basically an MRI, usually 1.5T, with or without contrast to assess the brain, cervical, thoracic, and lumbar spine, because again, the risk of developing these other tumors. One of the other things is they can get these endolymphatic sac tumors of the inner ear, can be very problematic, along with those meningioblastomas that we talked about. So sort of leading into that, there's this other syndrome, hereditary paraganglioma and pheochromocytoma. This is classically where we talk about the SDH deficient tumors. And we know this sort of more recently described, and when I say recent, maybe the last couple decades, but not like VHL and some of the other ones. But we know a percentage of patients with this disease will present with kidney tumors that, goes anywhere from 5% to less. Some of these, whether it's a defect in SDH A, B, or C, we think the presentation of renal cancer is slightly different. For SDH B and D, they're also highly associated with pheochromocytomas. Again, these are considerations in management because these are tumors outside the kidney, right? And so if you're a kidney person and you're only looking at kidneys, and sometimes I'm guilty of that too, you forget about these other factors, and they definitely matter when it comes to treating patients. Again, these patients, like many of these syndromes, are at risk of other tumors, gastrointestinal stromal tumors, pituitary adenomas. You got to think really whole body, whole patient in these patients. So these tumors, when they do happen, they tend to be aggressive. We treat them, again, not like the VHL. We typically don't wait for them to get to 3 centimeters because some can metastasize even then. Although there's some debate that if you can show, and actually this tumor is sort of nice in that there's a really nice IHC stain, so your pathologist can actually clue you into these patients very easily, is that they all lack one of the SDHB. And whether you have SDHA, C, or D, they all lack B on staining, and so it sort of can point you in the right direction and allow you to, change how you manage that patient. So this is a situation where getting a biopsy would probably be very helpful in managing these patients. The major things I talked about is that as a urologist, as a surgeon, we tend to be more aggressive in treating these patients. There's some debate that says, okay, if you know you have these SDH mutant tumors, you should be more aggressive and not really offer these patients partial nephrectomies. I don't think that's necessarily the case. Again, I think if you have a biopsy and you have a smaller mass, 4 centimeters, you have low-grade kind of features on the biopsy, then I think a partial is certainly something to talk about, again, because these patients could get other tumors, right? And so you got to really be conscious of that. Nonetheless, and again, it's certainly not, we don't have data to prove otherwise, some patients treat them more like the HLRCC, which I'll talk about in a second here, which tend to be more aggressive and therefore getting radical nephrectomies up front. Because again, these tend to be aggressive tumors once they spread. Surveillance is sort of similar from the VHL patients. These patients are recommended to have MRI with or without contrast every 18 months and an MRI of the neck, thorax, and pelvis every 3 years. Again, these patients, the paraganglioma, as it's in its name, is one of the main features that discerns these patients. And so really having a threshold, again, depending on your practice, that may not be a urologist's sort of area of expertise. They may refer over if you have abilities of like an endocrine surgeon. A lot of times when we manage these patients, endocrinologists typically are very comfortable managing or doing the surveillance for these patients and managing what needed. So you need to sort of find out where your comfort level is, both with your provider and especially if you're in the community. Getting to a center of excellence is probably, if at all possible, the best thing because there's usually a lot of specialties involved. These patients usually can get CT scans done for surgical planning, which is pretty much the same with many of these patients. There's also certain special types of PET scans for these patients, which actually, unlike the conversation we had about the use of PET scans, this is a different kind of PET scan, a PET dotatate, which actually has a very good sensitivity and specificity for surveillance for these patients and offers them sort of a non-contrast enhanced surveillance method. Again, yearly testing for metanephrines, that's very important in this group. And obviously before any intervention, you need to make sure. So if they haven't had one in 9 months, but they're going for surgery, again, this is a blood test. It's pretty easy to rule out. So this gets on to HLRCC. This is probably the second most common hereditary syndrome we talk about in kidney cancer. Hereditary leiomyomatosis and renal cell cancer has it sort of in the name. And these are characterized by cutaneous lymphomas, uterine leiomyomas for female patients, and renal cell cancer. So this is sort of the one where we talk about that loss of fumarate hydrase. Again, a lot of people put up a pretty Krebs cycle and stuff like that, but we don't have time for that. And so important, the hereditary patterns for many of these types of tumors or types of syndromes tends to be dominant, meaning that if your mom had it, your dad had it, there's a good chance you can have it. And again, this has implications for whatever phase of life your patient's in. If they're 20 and thinking about having kids, right, it's important they know these risk factors. Obviously, if they're in their 60s and they have kids who are younger, those kind of dynamics come into play when treating these patients and their families. Because again, this affects a lot of individuals within a household. It's estimated that about 10 to 20% of HLRCC patients will develop RCC. It tends to be, this is sort of the one where I think most people are in agreement that these patients are not the best candidates for partial nephrectomies. Again, it's exceptions to every rule, right? If they only have one kidney, right, you're going to have a different conversation than a patient with two kidneys, but tend to be treated more aggressively. Again, these are typically fall into that papillary type 2, and they are their own specific pathology in the latest WHO. Again, screening for these patients, this is especially important. Again, your patient may be 50, but their kid, right, is not. And so what do you do with the family, right? How do you have those conversations? Again, if you're at a center of excellence, they typically have genetics and a whole team of geneticists, and those are awesome, but not every place has that. And those kind of people, genetics in general, are sort of in short supply, even at centers of excellence. So some of it falls on the physician. It falls on the provider to have those conversations, at least in some kind of meaningful level, to give guidance for patients. Because again, it's not just them they're worrying about. Now it's their family, their kids, their brothers, their sisters, all those kind of things. So next is Birt-Hogg-Dubé. This is sort of, I guess I would rank it as the third most common one we talk about. This is an inherited one. It's characterized by the loss of this folliculin gene. Again, it's inherited in an autosomal dominant fashion, meaning that there's a very high chance of passing it on. Again, these patients, they tend to have a lot of lung pulmonary manifestations. And about 25%, again, if you just ask them, hey, do you have any history? Like, oh yeah, I had they won't say pneumothorax, or they had some lung thing that happened, and but these kind of things to sort of set off the red flags. These are the type that can have a different sort of types of histology of kidney cancer, from the oncocytomas, which are more benign, to the chromosomes, which are malignant, but they can also get traditional good old-fashioned clear cell. They tend to have a more variable age of presentation compared to some of the other ones, into the 30s all the way up to the 70s. So age, again, is not the perfect one here. I think for this patient profile, like pretty much no matter how big their tumor is, you get a biopsy. Because a lot of times oncocytomas will be managed conservatively without any treatment, whereas chromophobes, we would treat those differently. And again, depending on how the patient's coming in, they may have already had one kidney removed, and there's other risk factors that if they have other medical comorbidities, so biopsy is key. The prevalence of RCC is estimated to be anywhere from 6 to 35% of patients with Birt-Hogg-Dubé. So tuberous sclerosis, this is another sort of classic RCC syndrome, although the tumor we talk about here is not a malignant tumor typically, it's a benign tumor, angiomyolipomas, and those are treated very differently than malignant tumors, right? Angiomyolipomas are typically treated by interventional radiologists with embolization. And for smaller ones, we just watch them. The risk for them is really bleeding when they get over 4 centimeters, or patients who are on some kind of hormonal manipulation. So important to know that obviously it affects the TSC gene, which it's named after. You can have TSC 1 or 2. The incidence of TSC is actually, and I find this a little bit weird, it's 1 out of every 6 to 10,000. Most of these are inherited autosomal dominant fashion, although approximately it's estimated 2/3 of the cases develop de novo, meaning the patient developed, at that type of inception fertilization, right, they develop this germline manifestation or germline alteration, and therefore they don't have the classic family history. It tends to be that the TSC1 patients have less severe forms of the tuberous sort of manifestations talked about here than the TSC2. Skin manifestations are the hallmark of these ones. The other sort of hallmark is tumors of the brain. So many of these patients are actually identified in childhood. It's pretty rare to have one of these patients not run into some kind of health, again, given maybe access to care and things like that, but they're usually identified early on. These patients can have seizures. They tend to have some neurological defects, can be on the autism spectrum, along with many of these skin manifestations, which here I just sort of show on the left here. These are sort of shade green patches, but again, these are on the back of patients, and unless you go looking for it, you're never going to see it. And again, in a busy clinical practice, you just see a patient say you have a tumor, or you have an angiomyolipoma, but nobody actually takes off the shirt to look at your skin. So these are the keys, and can really make a difference in how we follow patients. Again, these patients can get other things, right? They can get, cardiac rhabdomyomas, pretty rare, but obviously pretty catastrophic, angiofibromas, and then, some of these other sort of retinal and dermatological manifestations. Again, these patients can get renal cell cancer, but you should be able, usually AMLs are pretty easy to pick up on CT scans. You just sort of got to have somebody look at it. Occasionally you can have the lipid poor ones, which are a little bit more of a dilemma. But if you have the patient history, right, hey, I've had some epilepsy when I was a kid, right, and they're younger, and it's not, you can get a biopsy of angiomyolipomas as well too. Again, the major consideration is angiomyolipomas in this one. Typically when these patients get RCC, we tend to treat them a little bit more like sporadic because it is sort of relatively rare. About 2 to 3% estimated this population will get RCC. Again, for these patients, they actually have some systemic treatment options, everolimus, which has been approved for a while. Again, it's pretty rare, I think, in this day and age that patients need to go on this medicine. Usually we treat these AMLs as they come, and then patients tend to do pretty well for a long term, again, depending on a couple other things. Again, for female patients, important to talk to them about estrogen and angiomyolipomas because these tumors, again, they could have a smaller angiomyolipoma, and if they get pregnant or go on estrogen or birth control and stuff like that, that can actually change the size, and so you may need to change how frequently you're surveillancing patients. And again, like I mentioned, these patients are primarily treated with embolization when needed. BAP type 1 is sort of the newest kid on the block, so to speak, but this is one we've known for a long time that this gene or loss or alteration of this gene, and the sporadic type of kidney cancer is a poor prognosis, but there is a germline variant of this as well. Again, the sort of classic one is they develop these cutaneous and retinal tumors, which can also be pretty aggressive. But obviously, uveal myeloma is sort of the one that's, the board answer, as they used to say for physicians. But then obviously, other malignancies, they can be pretty aggressive. These are pretty rare. They probably make up a very small proportion compared to these other syndromes that I talked to you about. But obviously, they have a pretty classic history, right? There's not a lot of people with uveal melanoma walking around. So if anyone has that, again, that should be a red flag. It's estimated about 5 to 10% of patients with BAP1 germline alterations will develop RCC. Again, because of what we know in the sporadic, we think that these tumors are more aggressive, but the data really isn't there to prove that yet, so still more to come. The average age is, again, closer to 50, so younger than sporadic patients, but still not too far off. Hereditary papillary renal cell carcinoma. So this is a syndrome that's a little unique in that it's only its only manifestation is in the kidney, actually. So unlike the rest of the ones where you're needing to get ophthalmologist, neurologist, all that, this one is actually really falls in line with the urologist and really the nephrologist, because these patients tend to get multiple tumors over time. And again, like we talked about, one of the biggest threats to their life is not the tumor themselves, but the damage from going after all these tumors. So it's highly penetrant, with close to 100% of patients that have this alteration will develop tumors, these papillary type tumors. They tend to be the papillary type 1 when you look under the microscope, so they tend to be a little bit more indolent, but again, because of the multiplicity and the time, it's not always a safe bet to say like these tumors will grow or will metastasize or not. This is one where that 3 centimeter rule sort of gets used, but necessarily isn't supported. The median age for this is typically low 40s. It's pretty equal in males and females. These patients also tend to have a lot of cyst in their kidneys as well. For these patients, ultrasound is not a good screening test. So again, like many things, a CT scan or MRI is needed to really get an idea of the number, location of tumors and stuff. And I don't know, I don't think I put it in. These patients also tend to have not good kidney function to begin with, right? So you're already starting again with another thing working against you in these patients. We don't know exactly why that is. I think that's something needs a lot more research, but these patients, even like 40-year-old patients who otherwise should be healthy, not hypertensive, not diabetic, but they're coming in with, already sort of with grade 2 renal failure, and they didn't know that, right? So now you're having to work in that setting and managing their tumors. So this is just a sort of overview. These can all be found in the NCCN. There's other follow-up, like I mentioned, the VHL Alliance is an excellent place too. But again, it's important that these can be used in managing and guiding patients, not just the patients themselves, but their family members too, and sort of how we, keep an eye on. Thank you.
Are there questions for Dr. Manley? Covered about how many diseases?
Yeah, that's not all of them, actually.
I'm sure not. I have a question.
Yeah.
That was completely overwhelming for me.
Sorry.
But genetically, we have adult children. Should they be tested if my husband has
So it's a great question.
a sporadic RCC?
So no. So sporadic, no. Again, this is where it gets confusing. I talked about VHL and probably in many of the slides that were up here. VHL is a central alteration to all the clear cells, basically 90% of them. That does not mean you have an inherited form of VHL, and this is where it gets complicated. And the same thing with that BAP1 alterations too. So this is a very different test. So, and I sit on the panel for the NCCN to try and develop these guidelines, and there's still a lot of debate, and mostly it's because we don't have a good answer. A lot of times we'll use sort of the general idea that if you're under age 47, right, that should be your first sort of saying, hey, okay, something's going on here, because that's not the typical age. The second thing we primarily use is family history, right? If you have somebody in your family, whether it's first degree certainly, but even second degree with renal cancer, because it's not prostate cancer, it's not breast cancer, right? So there is some value in just having somebody in your family. Those are two things that sort of raise the suspicion of, typically in my practice, those patients would be counseled for genetics. Now, the second thing is sometimes after, especially surgery or something, we get tissue back and the pathologist alerts you, right? We didn't talk about others, but sometimes they can pick up on TSC, they can pick up on other things beyond the FH and stuff. So that's another time point. I certainly have some patients, and we're not there yet, but maybe we'll get there, who just want to know, right? And sometimes that gets to an insurance issue kind of thing, but many patients, they're concerned about their loved ones, and they say, if I'm affected, and even if there's a 1% chance, but if I can find it and somebody else doesn't have to go through this or get screened, that's not an unreasonable thing too, but there's not a sort of general one.
I'm going to ask a question.
Sure.
If someone relatively young, so under that 46, gets kidney cancer, it looks like a standard clear cell, and however have genetic testing due to the age, assuming that was 5 or 6 years ago, should they have a newer,
Repeat.
better, more wonderful genetic
It's a great question, and I think 5 or 6 years, the panels haven't changed too much, so it depends on what panel you had before. There's very specific panels, there's more broad panels. It tends to be an RCC. We use more broad panels just because those are the ones that include the genes we care about. But I also have patients, and again, other people probably do too, who they're young, they're like 30s, they have multiple papillary tumors, and I send them for testing and it comes back negative. I still treat those patients. They got something going on, and this is where I get to that. We don't have all the answers yet. And it could be more than one gene, right? That's the whole problem is when you have, it takes a combination of genes to develop these syndromes, then it's a lot harder to pin those down. So for patients, I'd say more than, 10 years, 15 years, I'd reconsider getting another panel if they have those other risk factors, like you said. But on the flip side, even if they get one and it's negative and they still have those other clinical syndromes, I still treat those patients, like those are the patients I'm going to stop surveillance in 5 years. Thank you.
Good morning. I'm Roberto Pili, and from the University of Buffalo. I'm sorry that I'm not be able to be there with you in person. I want to thank Linda Anderson and the entire Judy Nicholson Foundation for the invitation. It's been really a pleasure and honor to work together throughout these years, studying with the founders, Nick Nicholson. So this morning I was asked to talk to you about nutrition and kidney cancer, our journey on nutrition and kidney cancer. And I always started with a disclosure about these pili nuts. Again, I don't have anything to do with this, but they're actually very good. They're very nutritious. So over the next 20 minutes, I want to discuss with you how nutrition and diet may actually have an impact on a patient with kidney cancer, and also the potential immunomodulatory effect of dietary protein restriction. And I want to also mention to you about an exciting project that we have at UB. It's called SNAC, Science, Nutrition, and Cancer. Starting with the definition of nutrition. Nutrition is nourishment or energy that is obtained from food consumed or the process of consuming the proper amount of nourishment and energy. An example of nutrition is eating a healthy diet. Why focus on diet and cancer? The American Cancer Society actually have a guidelines on nutrition and physical activity for cancer prevention. These are really common sense, achieve and maintain a healthy weight throughout life, adopt a physical active lifestyle, for example, consume a healthy diet with emphasis on plant foods, and we're going to talk about more over the next few slides. And if you drink alcoholic beverage, limit the consumption. If you Google it, there are several websites that actually talk about the kidney cancer diet. I want to recommend you, for example, the International Kidney Cancer Coalition. You can download a very helpful pamphlet. It's called Kidney Cancer Diet and Nutrition. The Canadian Cancer Society also has a helpful website. It's called Supportive Care for Kidney Cancer, and mentioning, for example, the challenge that most of the patients with kidney cancer have, such as living with just one kidney, and of course there are some suggestion that should be taken consideration by talking with the dietitian. If you have only one kidney, for example, try to eat less protein, so to put less burden or less stress on the remaining kidney, lowering the amount of salt in the diet, limit the phosphorus you eat. Some foods that actually have a high phosphorus content should be avoided. Limit how much fluid you take in. It's important to keep yourself hydrated, but extra fluids that can actually put a strain on your remaining kidneys, and limit the amount of alcohol that a person drink. There's been a lot of interest to see how diet actually can impact the incidence of kidney cancer. There's not really specific factors have been identified. These are most recent meta-analysis suggesting perhaps there might be some protected factors. For example, eating vegetables, consumption of vitamin C, moderate drinking actually, or consumption of cruciferous vegetables, again, can be maybe protective factor against kidney cancer. There's been also a lot of interest to look at the dietary inflammation kidney cancer, and these are two studies, one in Italy, one in the Iowa Human Health Study, suggesting this potential link. And obesity is one of the, along with the hypertension, the independent recognized risk factor for kidney cancer. These are, for example, large US cohort studies, link obesity with kidney cancer, Danish observational cohort studies. And there's been some intriguing, actually, data suggesting that perhaps there is a we call it obesity paradox. In one hand, obesity may increase the risk of kidney cancer, but patients who are overweight may actually have a longer survival. And it's a fascinating science behind that. So the objective of cancer dietitian, in particular for kidney cancer patients, is really to identify goals of healthy eating for cancer survivorship. This is a quotation from Beth Kirsch, a registered dietitian and nutritionist when I was in Indiana University. Really, the dietitian wants to, with you, identify risk for malnutrition, for example, and gain tools to gradually change eating habits. Sometimes small changes can go a long way to help you. Cancer diet, of course, depends on the goals, whether or not the patient is getting treatment, what type of side effect the patient is experiencing, and of course, controlling the appetite. And the goal of nutrition during treatment is weight maintenance, adequate hydration, we talk about that, and avoid nutrition-related treatment breaks. Malnutrition can be a challenge in any cancer patient receiving treatment, including kidney cancer. And we know that the malnutrition can be associated with increased morbidity and mortality and decreased response to therapy. So a nutritional support may definitely help to prevent or perhaps diminish the progression of malnutrition. Weight loss 1 to 2% over 1 week, subcutaneous fat and muscle loss, decreased functional capacity, all these are linked potentially to malnutrition. And malnutrition may be in some way associated also with the level of inflammation in the body. And what is inflammation? And it's really probably the best way to define it as a disorganized immune response. And this disorganized immune response actually can maybe suppress the good immune system that try to fight cancer cells by inducing what we call immunotolerance. There is a guidelines actually to try to avoid inflammation. This is important not just for cancer patients, but also for diabetes, heart disease, patient with arthritis, patient with hypertension. Food that can cause inflammation is being recognized. This processed food, excess meat consumption, especially red meat and saturated fat. So what is anti-inflammatory eating? And try to really avoid processed food and of course, eat more plant-based food. This plant-based diet is really high in vitamins, minerals, fibers, high in phytochemicals that can really actually fight inflammation. These are recommendations in general to have 1.5 cups of fruits and 2 or 3 cups of vegetables every day. So fill your plates half with vegetables and fruits every day. Plant-based eating is also an increased source of protein, for example, like beans and seed and nuts, source also minerals, fibers, and you can replace actually the meat in an entree for protein intake. And also switching to whole grain has been associated with reduced inflammation. Perhaps these whole grains contain more fibers, more vitamins, less processed, again, high in phytochemicals. So when you look at the labels, try to look for whole grain and try really to replace refined grains like white rice with, for example, brown rice. And avoid simple and processed sugar. This has been recognized detrimental, for example, for the healthy immune system, just again, linked to the inflammation in the body. And this is really the Mediterranean diet pyramid that is embraced also by the American Cancer Society. And at the bottom of the pyramids, really have a healthy lifestyle, meaning be physical active, socialize, and have a lot of fruits and vegetables in your place. And if you go up into the pyramids, try to really have less often meats and sweet and dairy products. So my take-home message is really to try, if we try to reduce inflammation, especially during immunotherapy, I recommend perhaps to avoid dairy products, red meat, increase plant-based protein and fibers, increase cruciferous vegetables, eat more fish. Maybe the only supplement I would recommend are really vitamin D and vitamin C, and definitely integrating dietary change with regular physical activity is important. How did we get involved actually with nutrition? That was several years ago when I was at Roosevelt Park. I met with Luigi Fontana, long-term friends and collaborators that really introduced me to the concept of protein restriction in the diet. And what we did in this case, we reduced the protein from 20% to 7%. In these mice were implanted actually prostate and breast cancer And it was eye-opening experience because we have the same effect like giving chemotherapy or monotherapy, but the only changes was actually change the amount of protein in the diet. More excitingly was that we were able to achieve a similar result of protein restriction by switching the source of protein. If we have just soy as a source of the protein, we're also having smaller tumors compared to casein as the main source of protein. And as you know, casein is the most abundant protein in the cow milk. We saw the same impact of the protein source in a kidney cancer model, shown here that actually if the mice were fed with corn as a main source of protein, has a much smaller tumor than if they had the casein or soy or whey. Throughout the years, our lab is really trying to identify what's the potential mechanisms, how protein restriction actually can help a healthier immune system. And we reported, for example, can help macrophages to be more aggressive against kidney cancer. And more excitingly, when we combine a PD-1 therapy with a protein restriction in this kidney cancer model, we achieve a greater response, a greater survival. So with Luigi Fontana, we really try to pioneer this concept of protein restriction in cancer. The other flip of the coin is reducing calorie intake, and there's been a great deal of effort to show that indeed calorie restriction may have an impact on cancer. And I always show this data. This experiment was done at NCI many years ago, and these are monkeys. On the left is a monkey is 27 years old. On the right is same age, but the monkeys on the right was calorie restricted. So they has eating less calories since it was young. So there was amazing experiment. And what they showed that actually these calorie restricted monkeys, not only they live longer, but also have less cancer, less diabetes, less cardiovascular disease. And this is the concept that's been developed throughout the years, that perhaps if we starve the cancer cells actually get more vulnerable to the chemotherapy, to the radiation therapy, while the normal cells, actually, if we are calorie restricted, we stress them, they get more resilient, and actually perhaps we maybe become less vulnerable to the side effect of chemotherapy. And there's been several examples now how calorie restriction is feasible, and perhaps it can indeed decrease the side effect of chemotherapy. This is an example in patient with breast ovarian cancer receiving chemotherapy. So this is really the new frontier in oncology, and to try to identify select intervention, we particularly focus on dietary protein restriction. Also, we study the intermittent fasting, how this dietary intervention can impact the microbiota, the bacteria in the gut, and by doing so can impact the cancer growth immunity and respond to cancer therapy. The University of Buffalo, we actually have a program where we isolate tumor in patients receiving undergoing nephrectomy, and we try to learn more about the metabolism, how these cancer cells work, both in vitro and the petri dish and in vivo in the mice, and try to see where a selective diet intervention may have a greater impact on one tumor type versus the other one. This is in collaboration with Dr. De Nigris in Naples. And Sabrina Orsi is a PhD student in the lab, is really trying to look at the mitochondria. Mitochondria is the engine for the energy consumption in the cancer cells. And shown here, these are preliminary data suggesting that different type of kidney cancer, we study, for example, translocation kidney cancer may have actually higher mitochondrial respiration and consumption oxygen as compared to other type of kidney cancer. Maybe they're more susceptible to calorie restriction or protein restriction. I want to show you this vignette. This was a patient with breast cancer who needed to undergo chemotherapy before the surgery in the neoadjuvant setting. She decided actually to try some calorie restriction and switch to plant-based diet. We're very excited that we put it on a specific protocol, and indeed this patient has resolution of her breast cancer with the chemotherapy while getting the calorie restriction. And only 20-30% of women achieve this result. And we want to believe that perhaps that the diet help her in her case. At the University of Buffalo, we have 2 ongoing clinical trials now where we offer intermittent fasting and plant-based diet to any type of cancer patient receiving chemotherapy, or we offer a protein restriction diet in cancer patients receiving immunotherapy, and this is particularly open, of course, to cancer, kidney cancer patients receiving the immunocheckpoint inhibitors. And I want to conclude by talking about our projects called SNAC, Science, Nutrition, and Cancer. It's really to try to provide longitudinal nutritional education interventions to cancer patients, particularly kidney cancer patients, and help them to achieve a better clinical outcome. We have a dedicated space in the Clinical Translation Research Center in Buffalo where patient comes. Again, these are patients enrolled in our clinical trials, and we did the different type of measurement, including assessment, including lean fat, body mass, and we collect stool and blood sample, and we store in our biobank. So at UB, we have established a working group to try to bring together different expertise. Really, this necessitates a team science approach across 4 different schools and try to really integrate cancer therapy with dietary intervention. And really, the goal is really to have a dietitian as a personal trainer. I believe every cancer patient, every kidney cancer patient deserves to have a dietitian throughout their journey. Because again, the intervention and the counseling may be different at the beginning of the journey or at the end of the journey. And this is really my dream, to have a place where patient can come, learn how to cook, get their treatment, get exercise, and also did some meditation and yoga. So in summary, I hope I give you, I made the case that definitely integrating nutritional support for kidney cancer patient is an unmet need. Well, our goal is really to try to integrate standard immunotherapy, for example, and that intervention for kidney cancer. We want to learn more about the metabolic signature of these kidney tumors and try to come up with a more personalized diet intervention. And overall, we want to improve patient quality of life and implement survivorship initiative for our patient with kidney cancer. I want to thank my collaborators at the University, the University of Buffalo, my long-term collaborator, Dr. Fontana, and now at University of Sydney. And again, thank you for listening. Please feel free to drop a email. My email address is rpili@buffalo.edu. And thank you again for your time today, and enjoy the rest of the meeting. Thank you. Bye-bye.
Good afternoon, and certainly the heartfelt thanks to the organizers for putting together this wonderful symposium here today. My talk is about the conversation really that no patient wants to have with their doctor. My scans are worse, now what do I do? And certainly it's a conversation that no patient really wants to have, and certainly no physician really wants to offer to their patients, but yet this is an all too common clinical scenario. If I were to give the short version of this talk, I would just say, please rewatch the excellent lectures from this morning from Dr. Hammer and Dr. Hannan and Dr. Haas and others. So the single best answer, I would say, is research, but I'll do my best to build a case for that. You're stuck with the somewhat longer version of this talk, which is a discussion of immunotherapy and how it works, and I'll try to offer some non-technical descriptions of that. And also, what is progression or resistance? And so I'll talk about that as well and use some case histories to try and illustrate these points. So these are my disclosures, none relevant to the topic today, but I do have a strong bias to believe both in immunotherapy and cancer research, which will become perhaps apparent in some of the patient histories that I describe. So first off, really, what is immunotherapy? It's really not what we see on the Opdivo or Keytruda commercials, no offense to those very fine commercials. And so what is this? And again, there's a history, some of which you've heard already today. This cartoon is borrowed from the immunotherapy primer from the Society for the Immunotherapy of Cancer. And they divide the world of immunotherapy into 4 quadrants. The upper left is really what most people think of in a discussion of immunotherapy, which relate to the so-called checkpoints, the control mechanisms of T cells. And you can see CTLA4 and PD-1, those have been the most studied of the checkpoints. And this cartoon tries to give some justice to the fact that, well, there are a lot of these sort of substances on T cells. And in addition, there's kind of a parallel universe of so-called activating receptors, or sometimes co-stimulatory receptors. In very broad terms, you could think of the collection of molecules on the left-hand side of the cell, things like OX40 and GITR and others, as gas pedals, and the things on the right side of the cell as brake pedals. But this cartoon glosses over that there are maybe 100 or 120 of each. And so if we had to drive a car with that many control inputs, it would get fairly complex fairly quickly. Thankfully, some of these molecules are, I'll say, easier to manipulate or easier to leverage compared to others. But certainly there's much more to immunotherapy than that. In the upper right, there's a description of T-cell adoptive transfer. And the idea of doing this, taking immune cells from the patient's tumor, has actually been around for quite some time, since the late 1980s, and was initially done in individuals with melanoma, but it's done in other solid cancers as well. These cells, immune cells, can be extracted from tumor deposits, grown in the laboratory to numbers in the billions, and the patient gets their cells back. And that 3-sentence description makes it sound very easy, but it's actually very difficult to do. And at least up until this point in time in kidney cancer and melanoma, there is not an FDA-approved therapy, but the work in CAR-T, so-called chimeric antigen receptor T cells, or engineered immune cells, that's helping to shine a light in some new directions, and I'll show an example later of how that may apply to kidney cancer. Sort of the unicorn for immunotherapists is therapeutic vaccines in cancer. You can argue that there's been over a century of work in this, and no one has quite figured it out yet, but there are some intriguing findings, and certainly we've learned a lot about different ways to boost immune responses. In the lower right-hand corner is to suggest that we can engineer immune molecules that are sort of like antibodies, but can deliver different substances to tumors. And different substances could be a chemotherapy substance, or it could be a dose of radiation potentially. And there are also ways to engineer molecules to trigger some of those checkpoints and to bring them together on the cell that can result in activation of the cells. My friends in the SITC organization are all modern. Something they didn't include in their slide are, you could call these Jurassic era immunotherapies, but yet there is a role still for things like interleukin-2 and interferon. And I'll touch upon that a little bit later. Cytokines, literally cell movers, things that can get immune cells to move around and also to do the work that they need to do to put the hurt on tumors. So I'll focus again on the so-called checkpoints. Again, CTLA4 and PD1 are the ones that have received, I'll say, the very most work and investigation, and worldwide there are something like 3,000 checkpoint-based clinical trials. And so the good news is that there's a lot of innovation and thought about how to deploy these checkpoints. But the more humbling news is that although there have been very clear and very important advances, but curing patients with advanced tumors is not a common occurrence. I'll return to that idea later. But despite lots of honest effort, still much more that is needed. So I'll try to offer a broader view of the immune system and how it works, and indulge in an automotive analogy. And so there are a number of very important steps to make an immune response against cancer. The initial step is the immune system recognizing that something is foreign about the body, or foreign inside the body, and that's done through a very specific mechanism of recognizing an antigen, a foreign substance, and it's really a fragment of proteins that may be mutated or foreign in cancers. And that abnormal protein or antigen has to be recognized by a T cell, an immune cell that is specifically programmed to respond and get rid of any cell that has that foreign protein. And so that is analogous to a key fitting into a lock cylinder. But just putting the key in the ignition is not good enough. There have to be other signals. And in the right-hand panel, there's a very stylish pump shoe pressed against the gas pedal, but that's to indicate that there are co-stimulatory second or third or fourth signals that are needed to sustain and amplify an immune response. In the lower left is a photograph of someone with their foot on the brake and giving the commonly used checkpoints, ipilimumab, nivolumab, pembrolizumab, is akin to taking your foot off the brake. I've inserted a subliminal message on the gas pedal regarding one of the cytokines, but that's an example of basically flooring it. And in the lower right corner is an example of a vaccine. This is insider baseball trivia. That's the steering wheel of Judd Walchuk's Subaru, who's one of the pioneers in checkpoint immunotherapy. He may be driving a BMW now, but neither here nor there. But the idea is maybe we can be very precise in ways that we can steer and direct an immune response against many cancers, including kidney cancer. So those are some of the very basic mechanisms about the immune system and how it works. But how do we define resistance or progression of a cancer? And how is it measured or compared when all of these studies are done and presented at different meetings? And so the most common set of rules for doing this are something referred to as RESIST criteria. In Portland, where I live, there are a lot of people who have resist signs in their front yard. I think they mean something else. But RESIST stands for Response Evaluation Criteria in Solid Tumors. And so there will be no quiz about these various detailed bullet points, but the broader message is that this is a set of a lot of rules for how tumors are measured, compared from one point in time to another. And the lesions that we select as targets have to be of a certain size, and the scanning technique has to be done in a certain way. And if it's a lymph node, that's measured in a different way compared to a solid tumor. And beyond that, there are some sites that are considered not measurable, although they can certainly be assessed, but you can't put a ruler on an effusion, a collection of liquid in the abdominal cavity or in the lungs, for instance. But all of these things, of course, are important to patients and how they're doing on their, in the context of their treatment. Last but not least, we don't measure all of the tumor sites. Using RECIST criteria, it's a maximum of 5 targets, no more than 2 per organ. Bone lesions are not considered measurable, and again, the rules go on, but it provides a structure, a framework for assessing how our patients are doing on treatment. These are definitions of response, and of course the response that we want to offer all of our patients is, well, the cancer completely goes away. That's a complete response, or CR. A partial response implies at least a 30% decrease in the sum of diameters of target lesions. Stable disease is something that's sort of in between. There's not enough shrinkage to constitute a partial response, but there's also not greater than a 20% growth, which would constitute progressive disease. When I did my oncology training well back in the last century, if I presented a patient on rounds and said they had stable disease and that was good, I would be given a stern talking to on the side that stable disease is not meaningful and the goal should be complete response or cure. That's sort of an old-fashioned teaching, but I think still has resonance. A lot of our initial rules and efforts in tumors came from work with leukemia and lymphoma, biologically very different cancers. We've become much more comfortable with stable disease in our patients who get immune therapy, and clearly stopping the tumor from growing is a good thing, but and patients live longer as a consequence of that, a very good thing, but that's very different from complete eradication of the tumor. So to try and illustrate some of these concepts, I'll show some cases, and the first one is a story that starts in 2003, and this is still a story that's ongoing. So this is 19 years of this patient's story with kidney cancer. At the time of her presentation, she had blood in the urine, abdominal pain. Imaging showed a large right renal mass, lung nodules, and lymph nodes in the chest. She would have fit into an intermediate risk group using some of the more modern criteria that were not commonly used in 2003, and that would be associated with a median survival probability of about 22 months. Median survival is kind of a depressing statistic. It really means how long it takes half of the people to die or succumb from their cancer. And why are cancer researchers so depressing? But that's another discussion, but yet it can be a useful barometer. But the thing to emphasize is people do better than those average statistics or probabilities. This was controversial in 2003 and remains controversial, but her initial therapy was removal of her kidney, in part to understand what cell type it was, but there are some data in that day showing that patients who started out with a nephrectomy and then received immunotherapy later, and in that day and age it was interferon or interleukin, but those patients seemed to do a little better compared to patients whose kidney remained without surgery. And so this timeline is a description of her treatments from 2003 to the present. I think someone described this earlier as a slow slog at night through a swamp. I would say this is a good example of a cancer warrior, but you can decide which fits best. You can see in the left-hand part of the slide her initial therapy with high-dose interleukin-2. The best response to that was stable disease. She received interferon when she developed new lung nodules. And that gave her, I'll say, roughly 5 years of cancer control and not on maintenance interferon. She had 1 year of therapy of that, which is, we don't give that treatment anymore. It is not easy nor pleasant to give. In 2008, she participated in a clinical trial with the 2 targeted agents, sunitinib and erlotinib. She had a brief interval of stable disease. She then got radiation to a site of progressive disease. I put radiation in the upper part with the other immune therapies in honor of Dr. Hannan here today. So we are also strong believers that radiation is in part an immunological treatment. But further progression, she had everolimus, nivolumab. You can see the other targeted therapies. And most recently in 2019, combination checkpoint immunotherapy with ipilimumab and nivolumab, or Yervoy and Opdivo to use the trade names. And so this is an example of before the Ipi-Nivo. I've indicated with the blue arrows a large liver tumor, which in kind of super slow motion is shrinking and calcifying. There have been no new masses, and she has not required additional treatment after, I'll say, her long slog thus far through multiple therapies. So this is an illustration, I would say, of persistence as a useful attribute. I'll talk about another case of a patient treated more recently. And so this individual's story starts out with an enlarging collarbone, and didn't really hurt at first, but the patient noticed that it was getting bigger. He saw his family doctor, biopsy was obtained, and it was quote unquote benign. So the patient was a little reassured by that, but still a little suspicious. And several months later, this mass continued to enlarge. He got pain in a variety of new areas, and another set of scans showed a lot of new bone lesions, lung metastases, and a left renal mass. He had another bone biopsy, and this confirmed conventional or clear cell kidney cancer. His initial systemic therapy was nivolumab and cabozantinib. And so using the RECIST criteria I quoted before, there was a substantial partial regression, about 85% decrease in the sum of the diameters, the tumor measurements that we did of his target lesions. And so things were going well, but in the midst of his treatment, after we'd completed the nivolumab and cabozantinib, his scans, you can see on the left, the lower part of his lungs, and on the right, I'll see if I can get the laser pointer to work, but this is early on in treatment, and later on, these white blobs appear. And on the radiologist's report, it said significant increase in mass-like process, differential diagnosis includes progressive metastasis. And so I'm being unfair to the radiologist because there was a much longer list of, well, it could be these other inflammatory things. But at our hospital, and I think now fairly universal, scan reports are posted kind of in real time after the scans, and patients see the reports, and I'm 1,000% behind everyone, seeing all of their data. But the patients don't often go through the differential diagnosis. They just see includes progressive metastasis, and that unfortunately is not uncommon scenario. So there's always more context, and again, having been trained in the last century, I would say any scan has to be interpreted in light of the patient's clinical history. And so part of the history that the radiologist didn't call out necessarily is that, well, this is a patient who had immune-mediated pneumonitis, inflammation of the lungs, earlier on in their treatment from the nivolumab. And you can see this process. This is at baseline, and then he has these kind of whitish blotchy areas, and then over time they seem to get better. And so this patient also had a lot of other immune-mediated side effects, which I'll describe in just a moment. But in light of the prospect of metastatic disease, a biopsy was done of the lungs, and it was an inflammatory process, no evidence of malignancy. And the patient continues to do well from the standpoint of his tumor response. But there's a big asterisk, which I should have placed next to that. He did have a good bit of other immune-mediated toxicity, including hypothyroidism, a very complex electrolyte imbalance, which was related to an immune attack on his pituitary as well as his adrenal glands. He had prostatitis on the basis of an immune reaction, which was the thing that made him the most miserable. But again, thankfully, he's doing much better over time. The last case that I'll describe is a gentleman who presented initially in 2020 with a 20-pound weight loss. He has multiple lung nodules. He gets a biopsy, and it confirms the kidney cancer. His initial therapy was pembrolizumab and axitinib for 2 cycles, followed by nephrectomy. This was done through his local oncologist. After the nephrectomy, he got some additional cycles, but the lung nodules enlarged, plus he felt pretty miserable on the treatment. He then got high-dose IL-2, actually part of a clinical trial at our Cancer Institute, which was a comparison of high-dose IL-2 with radiation plus high-dose IL-2. He was assigned, as a randomized study, so he was assigned to the IL-2 alone arm. Initially, there was a response, but it was not long-lasting. He got checkpoint immunotherapy at that point, and there was further lung progression. So he enrolled in a clinical trial, which Dr. Hammer described earlier, regarding CAR T cells, immune cells that were engineered to identify a protein known as CD70, which is present on, I'll say, 65% or so of kidney cancers. And these T cells, again, will attack this target where they can find it in the body. And this is an example of scans before and after the CAR T therapy. So this panel at the top are all baseline scans, and you can see these various nodules in different parts of the lung, and they all have shrunk, at least initially. Now, this patient's story is more complex. He had this very encouraging response. He did well. We were tracking the CAR T cells in his peripheral blood, which stayed at a high level for a time, but then sort of petered out over time. These cells are not immortal. And coincident with that was further growth of his cancer. He was treated a second time with some response, but it points out some of the complexity of this. There certainly are other immune cells that can be used in kidney cancer. That's another interest of our group, finding specific T cells in individual tumors that are potentially at least more effective than traditional TIL or some of the current CAR T technologies. So I'll just conclude, persistence is useful. New age immunotherapy can work after old school immunotherapy and vice versa. I didn't offer a case history of that, but we've seen both in our Cancer Institute. Progression on the scan report is not always progression. And most importantly, kidney cancer is not a solved problem. And it's my strong belief that research options should be a part of any treatment discussion with our patients. So I'll stop there. Thank you very much. I'd be happy to answer any questions if...
Is the presence of an autoimmune condition an automatic contraindication to immunotherapy?
That's an excellent question. We have been so bold as to treat individuals with a history of rheumatoid arthritis or inflammatory bowel disease, but it's with an eyes wide open approach to what the consequences of that may be. Their autoimmune disease may be a bad thing, but their kidney cancer also a bad thing. And so I think there are ways to thread that needle, but it requires, I'll say, even more caution in the context of the immune therapy. I think there's none.
I have a question, and this is really, you mentioned the English slide. This is just asking you to tap into someone who's been around for, as you said, the last century. So our comfortableness with stable disease treatment. First of all, I think we've also mentioned that eradication is actually for patients as well. But stable disease, we've gotten more comfortable with. I personally have gone through a struggle getting comfortable with that. Do you think that we have become more comfortable with it because eradication has eluded us? Despite millions of dollars of research, this medication, this treatment doublets, triplets, all this, but eradication is still pretty far away, and we just teach ourselves to be more comfortable with sickness.
Yeah, I think stable disease is a stepping stone, but it should not be the last part of the path. I agree, and with all deference to my friends and colleagues in the audience, but a lot of the initial checkpoint studies accepted stability or survival as endpoints and were the endpoints. But if you look at the so-called tails on the curve, the long-term survival of those patients, the majority of them with stable disease and melanoma as well as other cancers, they needed more work along the way, and they're still alive, which is great. But the curves don't illustrate, well, that patient had SBRT to 3 other lung nodules, or this individual went on to these other targeted therapies thereafter. And so we are getting much better at turning kidney cancer as well as other cancer diagnoses into much more of a chronic condition. But just like people who have long-term diabetes or hypertension get into trouble over time, even more so with cancer diagnoses. So, thank you.
Megan, and many thanks to the organizing committee, particularly Dr. O'Malley and Dr. Hajiha, and real thanks to the patients who I had a chance to spend time with some of you at lunch, and I've enjoyed that, and some of you I know in a much more profound way. We work for you, you don't work for us. My role today is to talk about something a little bit different than has been discussed today, and that's the role of surgery for advanced and metastatic kidney cancer. And I use that advisedly, and I'm going to show you how I think there are 2 different disease states to consider. I have no relevant disclosures for this talk, but I do have a real disclosure, which is also my take-home message. For the right patient, I think surgery is beneficial. Even more important than that, I think it's very important for patients and their family members to obtain a multidisciplinary opinion from a center that does a lot of kidney cancer, and that means seeing a surgeon, a medical oncologist, and other specialists as the case may be. And my real disclosure is that many of my very good friends, including some in this audience, are medical oncologists, particularly the fella in the red box over here, Dr. Asim Billen, who is a great friend and co-PI on many investigator-initiated trials in the context of kidney cancer. So some clarifying definitions here, the difference between advanced and metastatic cancer. So metastatic kidney cancer generally means that tumor is moved to distant areas, as was just alluded to by Dr. Curti. This is part of stage 4 disease. On the other side, currently in the year 2022, this does not mean kidney cancer involving lymph nodes, which are stage 3, or veins, or connected to other organs. That's not metastatic. That's advanced kidney cancer. I do worry that these definitions are becoming blurred. Many emails I get, many requests for engaging in new studies start out with advanced kidney cancer. I think terminology is important, including making sure patients understand what they're up against. This is a case from last week, so the 2 cases I'm going to present are very topical right now. So this 65-year-old retired, married police officer with a bunch of comorbidities that you can see here, good performance status, presented with hematuria to a hospital in Florida, not in Tampa. The CT scan representative image is shown here, and I've cut pasted from the radiologist their impression, 16 centimeter left kidney tumor with invasion of the renal vein and metastatic lymph nodes. That patient was referred to a medical oncologist, and this is again where I said multidisciplinary consultation is critical for the patient. This is cut paste from the EPIC chart. The oncologist lists out a bunch of things, anemia, thrombocytosis, no prior nephrectomy, etc. Calls it high-risk kidney cancer, which I don't exactly know what that term high risk means. Poor risk has more resonance since that's more the language we use. In red, I marked the fact that this was the treatment plan offered to the patient. If confirmed, start with ipilimumab, nivolumab. That was the treatment plan. Also get a CT scan of the chest and a bone scan, which I don't necessarily think a bone scan was needed. His CT of the chest showed no metastases and the bone scan was normal. So this patient certainly has a bad kidney cancer, don't get me wrong. It's not metastatic kidney cancer. This patient had stage 3 renal cancer. I took him to the operating room on Tuesday, removed a 16 centimeter renal tumor, all the lymph nodes, and extension of that tumor into the vena cava. So it was a little bit more advanced in terms of thrombus. And he went home on Friday. So this is an illustrative case in point. So just to make sure I'm getting the point correct to all of you in the audience, advanced kidney cancer can be thought of as invasion into the central structures of the kidney, invasion into the renal vein, the vena cava, and beyond as the vena cava drains into the heart, or invasion to surrounding other organs, such as invasion of the cancer directly into the diaphragm. Recognize that this kind of advanced cancer, if it's invading other organs, is classified as stage 4, but this is not metastatic disease. When dealing with such patients with advanced kidney cancer, I do believe, in my humble opinion, experience does count. There's 2 slides that were well done, both Canadian. One of them looks at IVC tumor thrombus cases. 80% of the patients in 800 cases experienced a complication. 3 out of 4 of the deaths in this cohort were within the first 2 cases of the surgeon's experience. An increased surgeon experience, not hospital volume, was associated with decreased mortality. So if you are facing such a diagnosis, or your family member is, you want someone who has experience. I won't belabor this point, but in the figure on the right, it shows that if you've done 1 versus more than 2 or more operations involving just the renal vein, not even the vena cava, the multivariable analysis shows you have about a 70% chance of doing better in terms of 90-day mortality. We do a lot of this at my own institution. I got to Emory at the end of 2005, and currently we do about 350 this year. We're projected to kidney cancer cases, 1/3 of which are locally advanced or metastatic. So this is a topic that I spend a lot of my research effort and time thinking about. Many patients come in with an idea of how surgery should be done. Should it be done robotically or minimally invasively, or should it be done open? To me, this argument or topic area is really making sure that we don't put a round peg into a square hole. It doesn't matter which one is picked if you're considering both the patient with all of the things they bring to the table, including previous surgeries, etc., and also the surgeon with lots of factors involving the surgeon. The robot isn't magic, it's only a tool. In the interest of full disclosure, I happen to like the tool a lot. This week I'll do 4 kidney cancer cases, 2 of which will be robotic and 2 of which will be open. But again, don't put the round peg into the square hole. What about medications before kidney cancer surgery? Amongst others, Dr. Haas covered this today. This happens to be a representative example of one of our kidney cancer trials that Asim Bill and I are co-PIs on, of preoperative cabozantinib for unresectable tumors. The important thing, I think, as a patient or family member is do consider clinical trials. I do think the only way we're going to make progress in understanding whether a medication should be given before surgery is in the context of clinical trials, and we have a lot more work to do. You heard from Dr. Haas about some that haven't worked out, and I think we're on the horizon of having some very good medications that could work. What about metastatic kidney cancer? So metastatic kidney cancer is a spectrum. It's not a one-size-fits-all method. Patients are different. This is a really nice cartoon that was published by Roussel et al. In the European Urology Journal last year. So the patient on the left is a patient who has a kidney tumor and a solitary or a single lung metastases. That patient is a really different patient, likely, in how they're going to do than the patient on the right who has a kidney tumor, brain metastases, multiple lung metastases, liver metastases, and in this case, a femur or bone lesion as well. Completely different size of the spectrum and likely going to do differently with the possibility that while systemic therapy may be used, there's a role for surgery as well. This is the second of the two cases I'm going to present. A 34-year-old man working as a landscaper, no other disease conditions, good performance status, still works hard. I find it hard to do yard work myself and can only imagine how hard it is to be a landscaper in the hot Georgia sun. Presents to the local ER with abdominal swelling in June of 2022, so that's 4 months ago. Regretfully, because of insurance issues, he was unable to get care and represented, this time to the Emory emergency room in late October of 2022. His scan that was seen on this MRI is very similar to the scan that was seen on his initial scan in June, so a huge mass crossing the midline over here, emanating from the right kidney. So 23 centimeter tumor, also had an IVC tumor thrombus, lung metastases. A brain MRI showed no metastases to the brain. The biopsy that was done, and I don't always biopsy things, but this was done this time because he was a young man, African American, and I did worry about variant histology or whether things could be non-clear cell. It showed clear cell renal cell carcinoma. He was anemic, elevated calcium that actually changed in terms of his calcium over a few days, elevated platelets to 403. So on the IMDC that has been mentioned earlier, he would be a poor risk patient with at least 3 points, actually, 4 on the IMDC. He did have a weight loss of 15 pounds and actually found it difficult, increasingly more difficult to eat. I'm not surprised when you look at this panel on the right, you'd see that most of his abdomen is occupied by a very large cancer. But in this case, over 75% of the volume of the total cancer in his body was in this kidney. So this is a patient who likely, because of the results of a trial I'll show in a second, would easily in many centers go on to receive upfront systemic therapy. In my own center, he's going to go to the operating room tomorrow by me, and we're going to take this out, and he will definitely receive systemic therapy. So, well, why are we doing this? Because doesn't the recently published Carmina randomized trial show there's no role for kidney removal if there's metastatic kidney cancer? This is a fairly famous slide that many urologists and medical oncologists present. It's a 2018 ASCO really highlight slide that shows that if you give sunitinib alone, it's non-inferior compared to nephrectomy, cytoreductive nephrectomy, followed by sunitinib for overall survival. A lot has been written about this, still continues to be a lot written about this. I feel like I've probably done 10 different debates in different parts of the country and the world on this. This is a highly flawed trial. All trials have some flaws associated with them. In my view, this one had multiple flaws. One of the biggest ones was that it didn't complete its accrual, but still got published. That happens sometimes. This was 450 patients operated on in over 79 centers in 2 different countries, actually multiple different countries, over 8 years. So that's each center somehow only getting less than 1 patient per center per year. So my simple-minded question, I'm a simple-minded surgeon, is what happened to all those other patients with metastatic kidney cancer at those centers? The reality is, in anecdotal conversations, they often got operations. The good ones were cherry-picked by the investigators to get operations, and the ones who ended up in this trial perhaps ultimately doomed and showed the results. I'm not going to belabor this point, but I will just say that 7% of the patients who were supposed to get nephrectomy never got a nephrectomy, and 17% of the patients who were not supposed to get nephrectomy got a nephrectomy, so perhaps the effect is clouded quite here. So therefore, we live in the era of not only trials, but in sophisticated ways of looking at real-world data. There's a problem. Currently in clinical medicine, we believe that randomized trial data is the best data. It's level 1 data. The patients are the most homogeneous. All the time points are carefully calibrated. We know exactly what happens to them. So it is true. These patients, we have much more control over understanding exactly what happens to them. And that's different than real-world data. But I live in the real world. Yes, I work in a university center, but I live in the real world with real-world patients. So what about these patients? This is a table published by Vimal Bindi at the Mayo Clinic that looks at the forest plot. And you've seen a lot of forest plots today, and perhaps all of you have gotten as patients education and statistics today looking at these forest plots. But to make it simple, on the left, any points on the left favors cytoreductive nephrectomy, favors surgery in the context of kidney cancer. On the right, favors no surgery. The one trial that's on the right is kind of on the right, not entirely, but kind of on the right, is the randomized trial that I alluded to. However, all of the other trials appear on the left over here, favoring to various degrees doing cytoreductive nephrectomy. So we decided to look at our own data in collaboration with 4 other centers that are high-volume kidney cancer centers, University of Wisconsin, Moffitt, Penn State, and MD Anderson, about 1,000. And at the top, you see our results with the Kaplan-Meier curve of patients what happened to these patients. So the median overall survival that was just previously described by our speaker, what median overall survival is, was much longer, much longer than expected from prior studies. There were no differences between if Dr. Brandon Manley selected patients at Moffitt versus Viraj Master or Jason Abel. The patients all did the same because they were well selected. So yes, there's observational bias because these patients were well selected, and that's what you want from your treating team. You want to be selected well for your treatments, both your initial treatments and your subsequent treatments. So these are the overall survivals in the table below, 117 months, 30 months, 22 months, compared with Carmina, which is boxed in the red over here. That compares favorably, for example, in the intermediate risk, 30 versus 19 months. So my take home on this particular aspect of my talk is that in a retrospective study that had nearly twice as many patients as the randomized trial, survival was much better. Why? Because of patient selection. And that's important. I'll explain towards the end about how I and others who do active work in this area tend to select patients for surgery. Many times I get the question, isn't it dangerous to do this surgery? I find that question comes up a lot and is answered by non-surgeons a lot, that yes, it's very dangerous to do surgery. So I would say that let's just look at the data. So the data, again, we put together our data from 5 different institutions and published this last year, or presented it last year at ASCO GU, and 937 patients that we had good quality data on. I'm not going to ask you to read every bit of this, just in green and red. The 30-day readmission rate was 9%, so 9 out of 100 patients came back for readmission. The mortality or death rate within 30 days of surgery, so that's probably a real surgical-related death rate, was 1.3%. In terms of major complications, the really only factor we could tease out of this about 1,000 patient series was IVC tumor thrombectomy, increased the risk of major complications. But otherwise, nothing else did, not whether they were in poor performance status, not if they had a lot of illnesses, not if they were aged, not if they had open versus minimally invasive surgery, not if they were in the IMDC poor risk group, and not if they had pre-surgical systemic therapy. So there's no real thing that we teased out to say, well, someone shouldn't have surgery because it's too dangerous in this cohort or that cohort. Sometimes it's said that if you get preoperative therapy, then it makes it harder to do the subsequent surgery. We didn't actually find that. About 20% of our patients had some kind of preoperative systemic therapy, either immunotherapy delivered as monotherapy or in combination, immunotherapy, TKI therapy, and you can see the complications here, no real differences. Importantly, what happened to patients after they had their surgery? I find it very gratifying that 15.7% of patients were able to be observed for at least 1 year without any systemic treatment. That's meaningful. That's not having to drive to the hospital several times a month, potentially, or once a month, depending on the therapy you're getting and the toxicity, as was alluded to by our previous speaker. These toxicities are real, so avoidance of systemic therapy is not a bad thing. However, it is true that most of the patients did receive systemic therapy. Many, again, I would suspect many of these are non-surgeons, say, well, you'll never get onto systemic therapy if you have surgery. Maybe. However, our data didn't show that. Our mean time to initiation of systemic therapy was 64 days. Even if the patients had had a major complication, not a minor complication, a major complication, the median time was still 68 days. Maybe because of the pandemic, or maybe because the argument on no cytoreductive nephrectomy or cytoreductive nephrectomy rages on. There's been a lot of meta-analyses published in the last year or two about this. I selected this one because friends who are medical oncologists published this paper. They used two different very large cohorts, National Cancer Database and the IMDC cohort, which is an aggregation of metastatic cancer patients from many, many different centers. And they did a lot of sophisticated statistical testing. Again, I'll refer you to the forest plot over here. The tiny red dot is patients with targeted therapy. The yellow dot is patients with immunotherapy. Both of these retrospective series and these large databases are far to the left over there, favoring cytoreductive nephrectomy. And in fact, in green, there's an even stronger association of survival benefit with the performance of cytoreductive nephrectomy in the eye immuno-oncology era, the era that we currently live in. So these are hypothesis-generating data, as retrospective data is usually association-level data. You can't prove causality. But these are, in my mind, strong hypothesis-generating data. So how do we select patients? There's really very few ways that people have come up with selection criteria. This one from MD Anderson is highly appealing as it's straightforward and makes sense to many. You can see the factors listed on the left over there. If you have more than 4 of these factors, your survival is much more limited. 3 or less, it's not. This has nothing to do with the IMDC classification or criteria, because many times things like anemia, hypercalcemia, thrombocytosis all resolve after the removal of the kidney cancer. So in terms of take-home, I think, at least in 2022, this is how I think about it, when to operate. If the patient was well until a short time ago and is now doing poorly, they've had the rapid decline, I think surgery can help to reverse the rapid decline for patients with advanced kidney cancer. For patients with metastatic disease, if they have a large, bulky kidney tumor and small volume metastases, I think surgery makes sense. When not to operate, if the patient had a long, slow case of the dwindles, it's hard to salvage those patients with surgery, and sometimes you do surgery and they kind of wither in the hospital, and I don't think we've served them well. If the patient looks weak and is highly sarcopenic, and then we can talk a lot more about patient frailty, which is a significant research area interest of mine, but that's my general take-homes on it. Thank you very much, and I'm really honored to be with you all today. Any questions?
I'm curious if the typical primary tumors found in France, where what 95% of the Carmina patients came from, are generally larger than you would say would be typical in the U.S.
No, they were not. In fact, I would say, I don't know what others in the audience think, I would not say they're generally large. In fact, I was surprised by the relatively small size of them.
And as to the metastases, the same question.
I read that paper, like many medical oncologists, neurologists, quite extensively, including supplementary data. To the best of my recollection, I don't think the volume of metastases was measured. It's a great question, so stay tuned for a submission from our group for ASCO GU 2023, where I think that measuring the sheer amount of metastatic volume will be quite important in ascertaining the prognosis of the patient. Great question. Thank you.
Thank you. Well, you've been hearing, I think, throughout all of today's presentations, a lot about trials. You've heard that word come up and up again. I'm going to continue that theme, but speak about it from a patient perspective. I hope you've been enjoying the conference as much as I have. And again, I want to thank Judy Nicholson, Kidney Cancer Foundation, for sponsoring today's conference, as they do other conferences, and inviting me to speak with you. This is only the second time I've presented on this topic, so I welcome your feedback either with my email or you catch me during a break. I'm happy to hear that. And there's also, by the way, I want to just point out, if you haven't been to the exhibitor room, the Judy Nicholson Kidney Cancer Foundation has a great piece on understanding clinical trials as well, which I think I've read several times. Agree with everything that's in there, and I think you'll find it helpful. Oops. All right. So here's a little information about me. I'm going to find out more about you in a minute. It's not my whole life story, but it gives you some bits about my life and my cancer journey, as a way of informing the set of experiences that inform what I'm about to present to you. I'm a native of Philadelphia. I snowbird between Philadelphia and Miami Beach in the winter. And I've been lucky to live in some of the world's greatest cities throughout my life, but Philadelphia is my spirit home. And commensurate with my retirement in 2019, I returned to Philadelphia. I spent my career in the business world, first on the business side, and then later on in the world of business education. I retired in June 2019. My last position was as the Dean of Students for the MBA program at the University of Chicago. I live in Philadelphia with my partner, Dirk, who is a flight attendant for American Airlines. We met 32 years ago at Northwestern University. And if it isn't obvious from all that, I have no medical training. You will not see any waterfall plots. You will not see any forest plots. I learned swimmer's plots at my last conference, so I don't have the qualifications to put any of those plots together. So my perspective today is really drawn from my 12 years as a kidney cancer patient and from the last 3 years volunteering to work with a group of doctors and other researchers designing clinical trials. I do that through my membership in the Genitourinary Committee for ECOG-ACRIN. ECOG-ACRIN is a cooperative group. There are several that exist in this country of medical institutions that come together. They sponsor research on, for adult cancers in this case, for people that are going to potentially get cancer or already have cancer. And so finally, from my start of my diagnosis, I've been a believer in the value of patient education and am active in organizations that help me with that goal. A little bit later, I'll mention what those are. While I do learn a lot from my doctors, and I always appreciate what they have to bring to my journey, I learn an equal amount from other patients. And I encourage you, if you are not reaching out to other patients, and I think you are because you're here today, that you continue to do that. All right. Let me give you my goal really for my talk this afternoon is to share my thoughts on participating in a clinical trial, to give you my advice as well as my guidance to help you evaluate a trial. And even if you have already been in a trial, there's a good probability that you might be presented with another opportunity to be in a trial. So whether you haven't been in a trial or have already been in one, I think what I have to say can be useful for you. I don't have a vested interest in a specific trial at all. I do understand behind the value of trials and the vital role I think they make in helping patients' lives longer, which is useful for all of us. In terms of preparation, I drew on the experiences I just went over with you. I spoke to many patients. I spoke to my oncologist, Dr. Haas, who spoke to you earlier, just to make sure that I wasn't saying anything that was going to make her faint. And I read some of the literature that's available on this topic. So, what is a clinical trial? And I know I've been speaking about that as well as our other speakers have, and without really adding a definition to it. So I put up there on the right the National Cancer Institute's definition of what a clinical trial is, and I'll give you a moment just to read that. Now, I know from my own experience at considering a trial, when I talk to friends, family, and my own information that I brought to it, it can often sound like initially that you're going to be treated like a lab mouse, an experiment, like the mice that Dr. Hannan, I think, put up there, with a lot of risky things being done to you. And that's simply not the case. Trials serve a very important role in treatment. And we saw a really rapidly changing landscape, treatment landscape, and I think we have trials to thank for that rapidly changing landscape. Any of the treatments that have changed practice, and there have been some, have come as a result of trials. So you might be surprised if trials are so great and they produce great results. You might be surprised to know that participation and therefore awareness remains really low, 10%, probably a little lower number I've seen. Trials suffers from a lack of awareness. They also suffer from a lack of socio-demographic diversity. That's a topic for another presentation as to maybe why that is. But two things come to mind. First of all is that people don't understand trials. They sound scary, and therefore that's the end of the discussion. And there is a history, unfortunately, that carries along with trials. And early trials that were conducted on patients unknowingly and actually caused them harm. So that also can contribute to some of the issues that trials face. So how do trials work? First of all, it takes a lot of people, not just patients, for a trial to work. And most trials usually have, occasionally trials will have a small number of patients, but many trials require hundreds of patients. Researchers, statisticians, protocol specialists, of course, and your doctors to achieve those objectives. So they cost money. So you have organizations that sponsor trials, the National Cancer Institute, the Department of Defense, you might be interested to know, they sponsor kidney cancer research trials because veterans have discovered to have a higher incidence of kidney cancer than the general population. So the Department of Defense feels like it's in their interest to understand that and think about treating their veterans. Who else? Pharmaceutical companies obviously also sponsor trials. Once you get into the world of trials, you will often hear phases mentioned. There are 4 distinct phases. Each of those phases, and I've listed those here on the right, attempt to answer a different question. I'll give you a moment to read those. My focus today is actually going to be on phase 3 trials, treatment trials. Trials can also look at behavior, and there's no treatment involved, but I'm going to look at treatment-related trials. And phase 3 trials, again, the question they're trying to answer is what we have today, the standard of care, better than something new. And that's what is trying to answer. So this slide and the next one are my attempt to answer that question, what makes a good trial? What tools can you use to evaluate if a trial is a good one? If you're given a trial for consideration, then I think you can use these points to evaluate it. First and foremost, a trial has to benefit you. It will benefit your doctor maybe, the researchers behind it, the sponsor, and it doesn't matter if it doesn't benefit you. So make sure you understand how it's going to benefit you, I have seen it said that sometimes patients can be overly optimistic with what they think. If they get the new drug, that new somehow automatically means it'll be better, and that isn't always the case. So be realistic with what you think something new could do. Often your doctor can help you with statistical information. That's a great filter to put through things and bring reality to the table. And speaking of doctors, and I'm really glad at least two of our speakers mentioned shared decision-making in this process. It's really important. I encourage you to have shared decision-making with your doctors. That means open discussions, pluses and minuses, get your questions answered. And unless it's what you want to do, no doctor should really dictate to you something without you being part of that decision. So if you aren't practicing shared decision-making, you or your caregiver, try to get to, try to get to that point with your doctors. I think it'll be a much more fruitful exercise for you. One of the things that doctors will need to help you understand is how that your doctor is going to help you stay in the trial. If you have side effects, a lot of our treatments come with side effects. And then also to actually look beyond the trial. What happens if the trial doesn't work for you or the treatment doesn't work for you? What would be next? Understand that as well. So look at the present, but also have an eye to the decision maker, to the future. And that's the shared decision making that you should be engaging with your doctors on. A doctor who's recommending a trial to you ought to be able to, actually must be able to explain in really easy to understand terms. So not a lot of jargon. What's exciting about the trial? Is it a potential cure? Or is it offering a way to slow disease growth? Is it offering a better quality of life? And make sure they're explaining that to you in simple, easy to understand terms. No waterfall plots. And the last point is really related to the previous two. Phase 3 trials include an arm of patients receiving the non-standard of care treatment. So your doctor ought to be able to explain the evidence that suggests, because this is a phase 3, so there's already some evidence around, why it may benefit you. Again, that point, it's got to benefit you in some way. And rather than sort of a lofty goal, what it may do to patients in the future, I understand how it's going to impact you. So, understand what is going to happen to you. Trials are obviously scientific exercises, and they're often talked about in really dense, science-laden documents. Some of you may have seen those. Your job is to really break through all that and understand it for yourself. Understand what's going to happen to you, what's going to be asked of you. You do have some help with that task. Your doctors ought to be able to help you. There's also a key document involved with trials, and those of you, the 6 or 7 who raised their hands who participate in trials, are probably familiar with the informed consent. That's a document to which a lot of individuals have input. It's supposed to be written at an 8th grade reading level. And I see Peggy shaking her head saying, you're right, I don't know what 8th grader they're talking about, but they're often really hard to get through. Take the time to read it, have someone else read it, take it to another doctor to read it, but make sure, because everything that's supposed to happen in that trial is really laid out there, and it may be hard to find, but make sure you understand it. Don't sign it unless you really do, as fully as possible. That's it. That's the key point. Understand what's going to happen to you in a trial. And by the way, all trials ask a lot of you. Treatment does too, of course. Trials can ask you sometimes to travel somewhere different than where you get your regular care. This will take time. It'll involve money. You may have work obligations, child care, elder care obligations that will have to be addressed. Trials can often require things beyond the standard of care, extra lab tests, extra scans, biopsies. Understand who will pay for those, and if you're in a position to handle the extra time that may be required, or any out-of-pocket costs. There's a concept in the trial world that we as advocates spend a lot of time talking about, which is financial toxicity, which really refers to the toxic impact on personal finances for cancer care. I've also been participating in discussions which talk about time toxicity as well, when the time required for you to participate in a trial is really causing you becoming toxic. It's more than you can handle. So my point here is that we all have limits on our resources, financial resources, the time resources. Make sure that a trial, even if you want to participate in it, and it sounds like a great idea, if it really requires more of you than you have to give, then don't do it, all right? Don't put yourself in that position. So the next slide really has to do with why I think you should participate in a trial, at least consider them. And I'm sure there might be some gamblers in the audience. You understand the concept of an ante or the table stakes. You know, what do you minimally need to produce in order to be at the game or at the table? I think the previous slides laid out sort of the table stakes. So for a trial to even be considered worthy of your attention, it has to meet what I put up on the other slide. But if you do see a trial that you think is worthwhile, then the next slide, this slide I should say, looks at the benefits of participating. But none of them really matter if the trial doesn't really meet the table stakes. So I'll give you a moment to look at those. So trials will often give you access to treatment that you might not have access to except through a trial. Drugs that are given to you in trial are often paid for by someone else, a pharmaceutical company, for example. And these drugs are expensive, as you know, if you've looked at your bill. The infusions of immunotherapy I get every month carry a charge of, the immunotherapy agent I get is $46,000. So these are big numbers we're talking about. And something that came as a surprise to me when I participated in the trial, and other patients have mentioned this as sort of an unexpected benefit, was the attention you receive from the study team. Key person in that is usually a study nurse. In my case, Pam was there to welcome me to every appointment. She tracked my progress through the appointments. I think she tried to reduce the time toxicity to me so that as I moved from lab to doctor's appointment to waiting for the infusion chair, waiting for the pharma to deliver the drugs, getting the drugs in the pharma chair. So she was with me and tracking me along the way. And of course, she could track it from an insider perspective. That was really valuable. Your study team will really be interested in the progress that you're making. They will be interested in knowing your side effects. You will have a lot of attention focused on you. And a lot of patients I talked to found that as a big benefit of participating. A trial can also give you another option. Often people think of a trial sometimes as the last resort. Okay, nothing else is available to me, so I should consider a trial. But I'd argue that at every inflection point in your treatment, you should think about a trial, ask about a trial. And I'll talk in a minute about where you might find more about where you find a trial. And even first treatments, you can participate in a trial in first treatments. Often people think that people participate in trial, patients participate in trials from an altruistic perspective because it's good for society. We heard about all the good that they've done. And trials do really move cancer treatment forward. And they represent a good thing, often for future patient populations. So there's certainly an altruistic element to participation. But I'd offer that no altruism can make up for participating in a trial that's bad or ask for more of you than you can actually afford to give. So keep that in mind. So how about if what I've said today gets you excited about thinking further about trials? And I went ahead and anticipated some questions that you might have. Where do you find out about trials? The obvious NCI, the National Cancer Institute, has a database. It's generally thought as cumbersome, although I was on there today or last night, and I saw they have a message saying that they're redesigning that and they're looking for input. Don't know what that means, but if you go there and find it to be dense and cumbersome, I think there's a lot of people that feel the same as you. So that's the clinicaltrials.gov. Again, I went on there recently. There were 2,000 trials across 100 diseases. So that's a huge database to look through. A better source, or as effective source, talk to doctors. And as I've said again and again, talk to other patients, because those patients are talking to their doctors and other patients, so you can find out about trials in that regard. And one of the questions that I know I got, and maybe probably some of you who participated in trials also received from your friends and family, good meaning people, is that you're going to get a placebo. And certainly placebos are offered in some trials. But in fact, and the placebo is a fake drug. In fact, it's quite rare. Unless there's not an existing treatment, then they will offer a placebo. But often placebos are often combined with existing treatment, combined with treatment in a trial. So I want to just add a few more color to that definition. And finally, another question you might have. Certainly I had that question as well. Do you get compensated for being in trial? Generally, no. And then if your underlying interest in compensation is really to help you defray the cost of participating, I think it's important for your study team to understand that, that you understand what costs you have and what costs may keep you from participating in a trial. There is an organization called, at least I'm familiar with one organization called Lazarix. They may be able to help you on the financial side, so it's good to raise that issue. Again, shared decision-making, talk to your team about what may be keeping you, when you think about keeping you from participating. Maybe there's some help somewhere. And finally, kind of a common question is, will insurance cover the treatments that I receive? Anything that you receive in a trial that's standard of care, the regular lab test you might have, a regular scan, generally that will be covered by insurance. But again, understand what will be and what will not be, and then if it's not, who is going to pay for that? I mentioned that I am a big believer in patient communities. There are social communities. There is a social element to them, but it's really patient education that's involved. SmartPatient.com is a community that I belong to, and I know some of you do as well. It is a great way to collect benefit from other people's collective experiences as well, and then contribute your experience. It works best when you're offering help and when you're taking some of the help that's offered there. There are a few organizations that you can write and also to ask to be on their mailing list. You're obviously all on the mailing list of the Judy Nicholson Kidney Cancer Foundation. Kidney Cancer Association is another organization. They do sponsor some conferences. I went to one shortly after I was diagnosed, and in fact met my oncologist there. Kidney Can, they're represented here in the exhibiting room as well. They sponsor a number of conferences, some of the virtual meetings as well. So try to get involved with those and be aware. You can't attend everything, but try to attend as much as you can, or have a caregiver attend as well. The IKCC, International Kidney Cancer Coalition, is actually an organization of organizations. They've also done some good work, so that's another organization. And I mentioned the Lazarix organization, Cancer Foundation, which might be able to offer financial assistance should you need it. So that's their contact information. And that's all I had from here. Again, my contact information. I'm happy to hear from any of you with help, assistance. Your presentation stunk, whatever it is, I can take it. Don't remember, I'm from Philadelphia, so I may say something back, but that's okay. Thanks. Any questions, by the way? Yes, of course.
If you're on the observation arm, it is an incredible altruistic gift to the field, because cases where we follow the clinical trial, the observation arm will be followed closely. As I alluded to earlier, we'll have defined time points, and it makes whatever conclusions we have altogether more believable. So right. Observation skill and from learning for you as a patient, it does make a difference to the doctors.
Right. Thanks, Doctor. Yes.
Question. What if there are no clinical trials for blood cancer one has? you?
What do you do? Well, first of all, Peggy's going to say something. Let me give my 2 cents, and yours is probably worth $1, so I'll just give 2 cents. There are, I think I'm aware that the landscape for kidney cancer tends to be really skewed towards clear cell. I have participated more recently in a trial design for non-clear cell, but it's woefully imbalanced. So, is that the point you're talking about? Okay.
Yes, I have a chromophore renal cell carcinoma, and as far as I know, there's no clinical trial in place right now. There's one that's being considered Harvard.
And I'm aware of one that I'm working with through Akron, but it's not ready to say here set up for yet. And Peggy wants to add something.
I was going to say there may be solid tumor trials that are not specifically only for kidney cancer, but there may be some appropriate trials that will include kidney cancer in with maybe a prostate cancer, and it may permit a non-clear cell, or some that are simply non-clear cell versus clear cell, even if not specifically chromophobe. And the study would probably break out those and monitor when you have chromophobe, another person has HLRCC. So it's not going to be as easy to find out.
Right.
But it's a big push going on.
And the ECOG Akron trial I'm looking at is a adjuvant trial for non-clear cell, but it's still isn't ready to roll out, so to speak. Good. All right. Well, thanks everybody. Thank you.
Well, thank you so much for having me today. I mean, I want to thank Mr. Sykes for his outstanding talk. I mean, I think, again, clinical trials are so much of what really help us to move the field forward. We've come, I think, quite a long ways, and patient participation in clinical trials is really the way that we keep, moving to the next step. I mean, I always tell my patients the treatments we have now are better than the treatments we had 5 years ago, but we all know that they're not where we need to be. I think one of the questions about finding a trial is tough. I mean, there's so many out there. If you go on the the main clinicaltrials.gov website, it can be a bit overwhelming. I think your patient advocacy groups can help you. Your doctor can help you. I mean, in particular, there are often in kidney cancer a certain group of large phase 3 trials that are going on nationally that any of the advocacy organizations and hopefully your doctor will be aware of, and that can be really, really helpful. So my name is, John Chatskill. So I'm up here from the University of Florida today. I work with Dr. O'Malley, who heard from earlier. I don't have any of his amazing cool videos like he had, but we do work together all the time. Talking about bone metastases. So first of all, why are we talking about these? I think that certainly the bone metastases, is one site that the cancer can spread, but it is an important site. Bone metastases can be particularly painful. They can be morbid. Certainly, if there's an involvement of a weight-bearing bone, they can be important to treat. And then also they can be somewhat challenging to image. So we'll go through these, and I'll try to be relatively sensitive of time. So the goals of the lecture are going to be to learn about the frequency and morbidity of bone metastases in patients with kidney cancer, to understand how they're detected by imaging and by symptoms, to learn about the main treatments for bone metastases, and also to learn about how we manage pain related to bone metastases, since that can be challenging. So unfortunately, they are relatively common in patients with kidney cancer in about 25 to 30% of cases. Normal bone is constantly undergoing remodeling. There are cells that are called osteoclasts, which absorb and break down bone, and other cells that are called osteoblasts, which help to build up bone. So your bone is constantly getting broken down and then built up again. And it's good to remember that osteoblast has a B in for building up bone. So kidney cancer cells are associated with increased osteoclast activity, so they lead to destruction of bone. New bone can form and does form in response, but the result is unbalanced and can lead to fractures. So most kidney cancer bone lesions are lytic, meaning they're associated with less new bone formation, and lesions usually look less dense on imaging. And then these metastases can be found in the pelvis, the ribs, and the spine, but can be seen in other locations as well. As many other folks have touched on, one of the challenges of kidney cancer is that it is a tumor type that can spread to many, many different places. Finding bone lesions can actually be somewhat of a challenge in kidney cancer. Our typical imaging that we do with CT scans doesn't pick up all bone lesions. It can pick them up sometimes. Again, these lesions are less dense, and that's what makes them, and the fact that they're lytic can make them a little bit challenging. One of the key things to keep in mind is that when you have your routine staging scans that you might have with your doctor, which is usually going to be a CT scan, occasionally it'll be an MRI of the abdomen, but may not necessarily find all bone lesions if you have them, or may not say there's bones are normal, but you may actually have a bone lesion, and it's not because something was wrong with the scan or the radiologist read it wrong, but that these lesions can often just be kind of hard to see. And that's why it's really important for patients to let their doctor know if they have a bone that's painful, and we can do more directed imaging of that area to try to identify those. We'll just talk a little bit about the tests that we can perform. So CT scans, I imagine most of the patients here are familiar with. Those are probably what routine cross-sectional imaging that uses radiation to detect lesions. We also have nuclear medicine bone scans. So I don't know if anyone here has had those, but essentially a patient will get a tracer and then they'll come back a few hours later. They can be helpful. They're most helpful at finding sclerotic lesions or bone lesions which are more dense, but they can help with lytic lesions, and they can help to find lesions in patients with kidney cancer. We have MRI, which is extremely helpful at detecting metastases. We'll find them the great majority of the time. The problem is that the test is quite time-consuming, so it's difficult to routinely image the whole body. So it's usually not something where if you're on surveillance, you're going to get a full body MRI at each visit. It's or every few months. It's something would be a bit tricky to do, but it's something that once we have a suspicion that there's a bone lesion, say a patient has new pain in an area, that would be often a targeted test that we would use. So bone lesions can be treated in a few different ways, and they work together. And I think it's great that that my talk came at this point of the day, since you've heard about most of these methods already. So surgery, radiation, cancer-directed systemic therapy, and then also medicines called bisphosphonates, which I don't think we've talked about so far today, but can be very helpful in treating patients with lesions involving the bone. And how do we determine which treatment we use for a given patient? Well, there's a lot of things that we need to consider. So first is the number of bone lesions. There may be some patients who a single bone lesion may be the only site of cancer that patient has that we know about. So you could think about a patient that had a kidney cancer that was removed a year or two ago, and then has a site that's painful in their say an arm or a leg, and we do an MRI of that area. We see that there is a bone lesion there. We might biopsy it and say that that's a kidney cancer, and we do all our other imaging. We do a CT of the chest, the abdomen, and pelvis, and we say we think this is the only site that this person has. Well, that may be a target for treating that lesion surgically and trying to put that person in a long remission from their disease. If there's someone that has a large number of bone metastases, that may be someone we treat with systemic therapy instead. Whether lesions are symptomatic. So certainly, if I have a patient with a lesion in their bone that's causing them significant symptoms,
then certainly we're going to look at pain medications to try to control their pain. But there are also options for local therapy that we'll talk about, including, for example, radiation, surgery, etc. Whether the lesion might predispose to injury. So certainly lesions in weight-supporting bones, particularly the spine, are things that we want to really try our best to get on top of and treat before they cause the person morbidity. And then also certainly patient and physician preference. There can be a variety of preferences from a patient on what they might prefer. So some patients, if there's, again, we'll use this word oligometastatic, if the patient has one lesion, that patient may be very interested in proceeding with surgery to try to remove it definitively, whereas for some other people, they may very much want not to proceed with surgery and may choose other options like radiation or systemic therapy. So surgery can be helpful, particularly if there's intractable pain, an impending fracture, or spinal instability. So if there's a lesion that you really are worried about causing structural instability and you need to restore the stability of the bone, not just to kill the tumor, but really try to fix the stability of that area, then surgery can be particularly helpful. And then, as we talked about, if the surgery is given with curative intent, that's another reason to certainly consider it. I think for me personally, as the medical oncologist, considering where to first look at treatment for a metastatic site, I think surgery, for me, I put a little bit of a higher bar on it because it is oftentimes a more involved procedure than something like a radiation treatment, but the benefits can be more definitive because, for obvious reasons. You're removing that lesion, and also you're going to potentially restore structure if it's a spinal lesion. So surgery is certainly very effective. 91% of patients report relief of pain. 89% report good to excellent functional outcomes. So certainly very effective intervention. Radiation can be effective in the treatment of bone lesions related to kidney cancer. We had some speakers earlier today talking about how it was previously not felt that radiation worked on kidney cancer. We know that that's now know that that's not true. And in fact, radiation can be very effective in treating bone lesions, often in just oftentimes in just a single fraction, a single dose, and can be very effective and can help relieve pain quite quickly. Systemic therapy, such as we've heard about earlier today, such as VEGF TKIs, so oral systemic therapy, or immunotherapy can often be continued during radiation. Obviously, talk with your medical team, but it's something we often are able to do. And it certainly can serve as another valuable treatment option. So we also have options such as radiofrequency ablation or cryoablation, and both of these are effective in about 60 to 70% of cases, and certainly in controlling pain. So another valuable modality, which you've heard about from our interventional radiology speaker earlier today. Okay, so now we're going to switch over. So we've talked about sort of targeted, local therapy. So we've talked about surgery, radiation, cryoablation. We're going to talk now about therapies that work orally or via IV, so systemic therapies. So as you all know from our talks earlier today and prior knowledge, the two main modalities that we most frequently provide are VEGF-targeted therapies and immunotherapies, and both of those certainly can help with bone metastases. So we know that one particular VEGF inhibitor called sunitinib or Sutent has been shown to delay the formation of bone metastases when compared to another medication that we've used called sorafenib. That's the molecule there. And certainly there's another VEGF TKI, which is perhaps particularly well known for treating bone metastases, or has come to sort of particularly serve in this role, called cabozantinib. The brand name for that is Cabometyx. So this is another VEGF-targeted therapy, and it's actually known to decrease osteoclast activity. If you remember, osteoclasts are the cells that sort of break down bone. So it decreases the activity of those cells, changes the bone remodeling, and then also alters osteoblast activity. And it's not just mechanistically, but we also know that there was a study that compared cabozantinib with a medication called everolimus and showed that patients with bone metastases had their disease controlled for a much longer period on cabozantinib, 7.4 months versus about 2.7 months with everolimus. I do want to sort of, so certainly cabozantinib, there is evidence that it is active in patients with bone metastasis. I want to be very careful in saying that we probably, in terms of directly comparing the agents, the VEGF inhibitors that we use today, it's a little bit hard to say that one is necessarily better than another. They're often not compared directly. But again, what we can say is there's evidence that cabozantinib seems to be effective in these patients. So I wanted to mention another study that compared a combination of the regimen of cabozantinib, which is, again, this VEGF inhibitor oral therapy, plus nivolumab, which is an immunotherapy, and found that it actually was superior to sunitinib in patients with bone metastasis. And again, I will add just again another caveat that we don't necessarily know, and you'll hear a lot about this, that one sort of combination therapy is necessarily better than another. It's although we can say that they're effective, comparing them is difficult with the data that we have. So next we'll talk about bisphosphonate therapy. So bisphosphonates are medications that work to inhibit the activity of osteoclasts. So the two that we've most frequently used and that you may be familiar with are zoledronic acid or Zometa and denosumab or Xgeva. And these are given via infusions, often about once a month. And they are shown to reduce the risk of fractures in patients with bone metastases. So these can be a valuable adjunct to your anti-cancer therapy if you do happen to have a bone metastases. So I do want to mention some of the side effects that can be associated with these agents. So just like with any systemic therapy, there's a benefit, which is the reduction in fracture risk, but there also is a little bit of a cost, which is these side effects. I think in general for most patients, the benefits with bone metastases, the benefits of these medications outweigh the risks, but it really depends based on a particular patient's, comorbidities, their desire to have potentially additional infusions. So if you're getting an immunotherapy, you may have to come in potentially an additional week to get this bisphosphonate therapy. So there's some costs. Other things I do want to mention, with Zometa in particular, there is a risk of renal injury, so we have to be aware of that, particularly over time. So if I have a patient with impaired renal function, it may make me lean towards that other medication, denosumab or Xgeva. There is a risk of something called an atypical fracture. So while we know that bisphosphonates decrease the risk of fractures on aggregate, there actually is an increased risk of fractures of what's called an atypical fracture of the femur. Just something to be aware of. Lastly, and probably most, I think this is the thing I try to counsel my patients most about, is there is this thing called osteonecrosis of the jaw, which can happen, which is quite a severe toxicity where the jawbone peeks through the gum and the gum in the mouth, and can require surgery to treat effectively. So it's something that's rare. It happens less than 2% of cases, and I do think we're a little bit better at avoiding this toxicity today. So in the past, it was quite common to give these medications, these bisphosphonates, for sort of years on end, and it was actually noticed that these patients who were getting this medication for a prolonged period had an increased risk of this very rare complication called jaw osteonecrosis. And so one of the ways that I try to avoid this is to put sort of a tight, as soon as I start this treatment in a patient, I sort of will make a note, and we'll talk with the patient and say, we're planning to give this medication for a set period of either 12 months or 24 months, and then we're going to stop at that point. And I think if you do that, I think that can decrease the risk, but it's still present. The other thing that I do is I do ask my patients, if they have a dentist, to talk to their dentist, make sure that their teeth are in good health, their jaw is in good health before we start the treatment. So the last kind of key point that I want to, or key area that I want to address in terms of the treatment of bone metastases is the pain that these metastases can cause. So bone metastases can certainly be quite painful. So things that can be typical of bone pain is that can be worse with movement or at night, and it can be tender to palpation as well. So those are things that are characteristic of bone pain and may make me be a little bit more worried about it if I see a patient, if a patient comes to my clinic and describes mentions these characteristics of pain to me. Certainly anti-cancer treatment is a key component of treatment of the bone pain. So like we talked about, radiation or surgery can be particularly effective. Bisphosphonates also have been shown to decrease the risk of, or the need for analgesics in patients with bone metastases. So they can be helpful as well. But often we need medications, of course, to treat the pain directly. So in terms of treating bone pain, so first we think of over-the-counter medications like NSAIDs, including Advil, as well as medications like acetaminophen or Tylenol. So it seems like medications in the NSAID family like ibuprofen are a little bit more effective than acetaminophen. Certainly with patients with impaired renal function, we do have to be careful about the amount of NSAIDs that we use. Certainly patients with kidney cancer, many of whom may have undergone potentially nephrectomy, we have to be particularly careful about that, but I still do think that they have a role. Opioids can be helpful for moderate to severe cancer-related pain, so they're a very important aspect of your treatment. I think we have some talks later today talking about pain management, so those can be very effective. Steroids can help with bone pain by reducing inflammation and swelling. We do want to be careful with giving those for a prolonged period because they are associated with their own toxicity. For example, they can cause even weakness of the bones over time, in addition to elevated glucose levels and a number of other potential toxicities. So we do want to be careful about using them for a prolonged time, or at least be mindful of those side effects. There are other medications that I won't talk about in significant detail called gabapentin and pregabalin, which have really kind of shown inconsistent benefit in treating bone pain in various clinical trials, but it's potentially worth considering, can be worth considering. So, kind of to revisit the main messages of the talk is to, I think certainly let your physician know if you do have new areas of bone pain. If your screening, surveillance or baseline CT scan didn't show bone lesions, it doesn't necessarily, unfortunately, mean that they're not present, since CT scans are not perfect at finding these lesions. If we very, very highly suspect that you might have a bone lesion, an MRI can be a particularly good test. It's quite what we call sensitive. It's good at finding them, and if it finds them, if there's a hint that there's a bone lesion on the MRI scan or a strong indication that there's a bone lesion on the MRI scan, it probably means that it is a metastasis. So we certainly want to use that in a targeted fashion. There are many modalities that can treat bone metastases, so surgery, radiation, systemic anti-cancer therapy, as you've heard about earlier today, and then also bisphosphonate therapy. Surgery can provide certainly good functional outcomes and excellent relief of pain, and can be particularly useful if you're someone that, if you are a patient that has an isolated bone metastasis, that's your only site of disease, then surgery may be a particularly good option for that site. Radiation can provide very, very good control of painful bone lesions, and may be an option if you're that patient in that case we just talked about, where you don't want to proceed with surgery for whatever reason, or your doctor doesn't think you're a good candidate for surgery. Oftentimes we can continue systemic therapy while patients are receiving radiation. I don't know if people mentioned this, if this was mentioned earlier today, we do have to be careful about continuing our VEGF inhibitors in patients that are receiving surgery, because those medications, they inhibit blood vessel growth, and so they slow down wound healing. So patients may need to be off of those medications before and after surgery for some period of time. With radiation, for some patients it might be acceptable, and immunotherapy is often acceptable to continue either during surgery or radiation. We know that, again, bisphosphonates can help reduce the risk of fractures in patients with bone metastases. They can also help with pain control, so they can be a really good adjunct. Again, we want to be, both us and our patients, to be aware of potential toxicities, most notably the small but present risk of jaw osteonecrosis amongst other things. So we certainly do want our patients to get evaluation by a dentist, or at least make sure they have good dental health before they start their therapy. And then pain control in bone metastases, it involves multiple methods, both with everything we talked about before, but also with NSAIDs if your doctor thinks it's safe based on your kidney function, opioids, and then occasionally other agents as well. So that's what I had today. I certainly want to thank the foundation for having me, and certainly want to thank our other speakers and all of our patients for being here as well. And I'd be certainly more than happy to take any questions that people have. And I'll just leave my references here. Thank you so much. Yes, sir?
Going back to your osteoporosis.
Yes, sir.
Two related questions. One is, with the defined course of therapy that you were talking about, can you expand on that a little bit? Because I understand we said the research showed that sort of long-term use of that reduces the chance of that. But if it's doing some good, how do you decide 1 year is enough, 2 years is enough? And what are the implications of stopping it? Who's providing some benefit?
So that's a good question. I think that the main take home from that I wanted to make is not to sort of just continue it indefinitely. It's not something like with your VEGF inhibitor where it's working, you're going to continue it. With that, you do want to have, I think, some sort of stopping point in terms of when a particular patient would stop it. For myself, I usually will use a 1 to 2 year course. In terms of what's best for that person, I think, again, you're going to weigh, how the patient's tolerating it. You're going to weigh, probably the extent of the bone metastases that patient has. If they have a large volume, you may want to continue it for probably something towards the longer end of that. In terms of the downsides of stopping it, I certainly understand the concern that maybe you're not having as much of an effect at that point. But I think it is just something that at least for me personally, I think it's something that I want to balance against that increased risk of jaw osteonecrosis.
Yeah, dental stays on the same as we think treatment can change by treatment. So
Absolutely. Absolutely. Thank you so much.
Quick comment, because this is really important. Sometimes you have one complication that may be not cancer related that completely wrecks your life. Think about it. What happens if your jaw breaks? You can never ever again chew normally. It doesn't matter how well your cancer is controlled, you're miserable for the rest of your life. So you gotta be careful with some of these things. So I can totally buy the point of backing off, because what's the other side we have to look at? If you don't break a bone, then you're doing well. But breaking bones is not something that happens daily, right? So how do you know when is the right time to stop? Toxicities, as everybody here is very well aware of, sometimes dictate what happens to you in terms of your daily life. Osteonecrosis of the jaw is a horrible complication, right? And I understand the respect he has for it.
Right. How long does this stay? How you stop it? How long?
In terms of the half-life of the drug, there can be some decrease in bone density when you do stop the medication. I think it's unfortunate. It's something that there's just there just is a cost to continuing it indefinitely, and I think it's we kind of get the benefit we can from it. There's a certain point at which it's just not really the risks start to kind of outweigh the benefit to continuing it.
Good afternoon.
Awesome to see all of you. I think this is an opportunity to reclaim a little bit of time because I'm actually hoping that we'll be able to do our breakout sessions. And a lot of my presentation is going to be an overview of some of the things that have already been shared. So some of the more intimate pieces we may be able to also cover when we do the caregiver segment. So with that being said, I'll go to I think a big part of pain and symptom management as it relates to kidney cancer is one, understanding and knowing how the kidneys work. You've heard, again, a big overview of that, so I won't belabor that point. However, what I will say is this: what do we know about the kidneys? We know that they manage our elimination system or part of our waste. Some of the other things that you haven't heard today that may be familiar, the kidneys produce two specific hormones that we're going to talk about just briefly because, again, it ties into our pre and post operative planning. The hormone renin, which helps with blood pressure regulation, the hormone erythropoietin. That is what stimulates and helps us develop new red blood cells. It's important because when we look at what we know about symptoms, and again, kidney cancer is one of these tricky cancer diagnoses that tend to come later unless found by chance in the earlier phases. It's one of the cancers that have a high success rate for treatment as well as remission and long life, longevity with treatment. But what are we looking at? As one of our presenters said, a lot of times the issue may not be so much that you're passing from or someone passes because of the cancer in and of itself. It may be the sequelae or the consequences or the contraindications with other therapies, the response, inflammation, some of the post-operative or post-treatment effects on other systems. And so when we're looking at it just in general, remember some of the symptoms that we see with the diagnosis would be low back pain. There may be a mass that's either palpable on either side of the body, again, looking at previous pictures and understanding the positioning of the kidneys in the body. Anemia. Anemia, you may see blood in the urine, but remember, that usually is not a large enough quantity or amount of blood to cause anemia. The anemia is usually related to the decrease in erythropoietin, the hormone that actually stimulates you to produce new red blood cells. So again, going into planning a surgery or any kind of treatment, these are some of the things that we're looking at prior to. Fatigue. If you're extremely fatigued prior to surgery, these are some things that you'll have to anticipate as it relates to symptoms post-operatively. So these are just a few things to keep in mind. Weight loss. Weight loss is not always indicative immediately of a kidney cancer. Again, you see the weight loss, appetite loss, things of that nature, but until you know the cause of it, oftentimes you're kind of chasing your tail there a bit until we get the diagnoses. And again, early kidney cancer findings generally are by chance. There's usually a scan for some other reason that then that mass is found. And so again, you've heard of some of the treatment modalities and things, and I'll cover that briefly. But again, understanding how all of these things play together. So symptom management, again, both pre and post. Blood in the urine, again, depending on the amount, transfusions may be done. Again, it's not usually because of the significance of blood loss in and of itself. It's that lower production of blood cells. So we talk about anemia. Again, the low back pain, anticipating what you're needing pre and post surgery. If your tolerance of pain was very minimal prior to surgery, then post-operatively, a lot of your pain would likely be related to the incision and the surgical site itself. You got to remember, you've heard some of our presenters talk about nerve channels and the muscles that that are cut to get to the kidneys. Kidneys are in a particular place where you've got a lot of other organs neighboring the kidneys. And so when you're looking at whether or not you're a surgical candidate, whether cryo or ablations are going to be done, I was very happy to hear some of the advancements in technology as it relates to radiation. I think that's phenomenal that these new scans or radiation machines are going to be able to really focus more on the tumor itself, because I think as that technology continues to develop, then there'll be less involvement or damage to the healthy tissues surrounding your kidney, the tumor itself. So that's awesome to hear. So mass, the size, again, You heard that from a presenter before, size does matter. And so the more invasive or involved, if there's any vessels or major vessels involved with your mass, that's going to be a more invasive surgery. So you can anticipate a longer recovery phase, but as we know, movement and diet, there's some things that we can do beforehand that are going to optimize that outcome. Weight loss, fever, these are some of the things that we see tied to early symptoms. I won't go much into this. This is where we've heard about quite a bit: ablation, radiation, targeted therapies. Anytime we're talking about any kind of a systemic treatment, meaning that's something you either took orally or intravenously through a vein, your body may respond to it in different ways. And so this is where nausea and things of that nature may come into effect. Of course, that's going to be medication management in most cases, but there may be some variations with how people are doing there. I'm excited about the palliative presenter that's coming after me, so my guess is we kind of marry just a bit with our topics here. So just before, you heard about some of the long-term medication management or drug treatment plans as it relates to bone metastases. That usually is indicative of a later stage cancer, but also more of a chronic pain management plan. Whereas what specific to this presentation, I'm speaking more towards pain that is related to, again, pre and post-operative planning, but as well, we know you're in it for the long haul, so that's going to change over the course of your disease, but definitely immediately post-op. We know there's going to be some discomfort, so I always encourage people to look at non-pharmaceutical management. Sometimes just repositioning, using assistive tools to get up and down, allowing someone to be your support so that you're not using or straining muscles so soon after surgery. We talked about, and I heard another presenter also mention, steroids and NSAIDs, the anti-inflammatory regimens. Again, we have to be careful and cautious with that because we know they can be nephrotoxic or can cause extra strain on the kidneys. So we're cautious there. Complementary and alternative medicines, again, complementary means it goes along with your treatment plan, again, both pre and post surgical planning, but alternatives as well. There may be some folks that are really, I've had patients who, again, as a palliative provider, who were really leery or afraid of pain medication. And one of the things I explain to them is your brain knows the difference. You have receptors that indicate and know when there's a true brain stimulus, a pain stimulus, excuse me. And so when you take pain medication, that's what's happening there. Your brain is identifying, and those chemicals, because that's what medicine is, those chemicals are connecting to those receptors and managing your pain. Someone taking narcotics and opioids without those stimulus within the brain, these are patients that we're talking about that are not patients, excuse me, people who are misusing the medication, and that's a different road or can lead to addiction and things of that nature. But when you have valid pain or well-controlled pain with your regimen, that's the goal. Other things that we look at, we know that omega-3s are really good post-operatively as well as preoperatively. They are really good for helping with anti-inflammatory, and if you heard inflammation quite a few times as it related to cryo and ablation and even surgery, so much so that it could look like on imaging pseudo advancement of the disease. Well, it's not. Our body doesn't know the difference between a surgical incision or a regular injury. It sends those same chemotactic or chemical messengers to say, hey, I'm hurt over here, come help me. And so the body's natural defenses then have to also be considered when we're implementing or going into certain treatments. And because we are mind, body, and spirit, I like to remind you of other things such as acupuncture, Reiki, positive imagery, massage. These are all things too that can be helpful in pre and post-operative management. And because my partner in crime, I hear, is coming next and going to talk about palliative care, I want to remind you too, with that holistic approach, you're looking at having others involved in that care plan. This is where you're talking not only your nurse and your nurse's aide that are at bedside, communication and involvement with your physician team on what your goals are, and that open dialogue about how well you're accomplishing what you envision as well as what their goal or plan is for you. That's how you'll know if you're both on target with where your expectations are as well as their expectation for your response to treatment. Including chaplains. We are existential beings, which means mind, body, and spirit. We don't just exist here in the flesh. we do have to manage not only our emotional being, but as well, where do we see ourselves throughout that course of treatment and care. The Judy Nicholson Foundation, not only are we here to continue to educate, they did mention I'm the vice president of our board, but more importantly to me, it's important, and I love our mission for advocacy and education. So check out our website, not only because you will find a wealth of information as far as nutritional recommendations. Protein is an important building block for every cell in our body. It's part of our recovery process, but we know in excess it can be harmful to the kidneys. Part of what we didn't get to hear today, but it will be part of the presentations that will be available online, is we didn't get the nutrition and kidney cancer presentation by Dr. Pili, but I will encourage you, stay tuned, follow this presentation once it does air, once we get it on the website, because there are going to be other pieces on there that you did not get today or discussions that you'd like to revisit. So don't forget about that, check it back out again, and it's my pleasure to be before you now. Thank you so much for your time and for being here today. Thank you.
All right, so it looks like it's up to me to bring us home today. I just want to give a thank you to the foundation for inviting me to be here with all of you today. It's truly humbling to be sharing the stage with so many wonderful speakers. Really, really thankful and pleased to be here. I was tasked with, trying to answer the question, palliative care, when is it needed? And I think I could honestly put up one slide that says now, and I would be able to provide a pretty good argument really to any question as to why, that's true. And hopefully today I'm going to be able to dispel some common misconceptions about the field of palliative care, who we are, what we do, how we can contribute to the care of so many patients. So I titled this 3 W's, which will make sense in just one moment. I don't have anything to disclose, related to the content I'm going to present to you all today. So what are the topics we are going to consider? We're going to talk about what exactly is palliative care. I think there are a lot of, again, misconceptions as to what the field is and what we do. What services will a palliative care team bring to my care? And when should I think about meeting with a palliative care doctor? Or, to me, the better way to ask these questions, the 3 W's, who are you, what do you do, when do I need you, right? These are kind of the basic questions that we're perhaps asking ourselves when we're thinking, should I be seeking care from a palliative care physician, a palliative care team? So first and foremost, who are you? Palliative care is quite unique in that we are the field of many different names. I'm going to just put up a few examples here. You may hear palliative care referred to as palliative medicine, palliative care, supportive medicine, supportive oncology. Hospice and palliative medicine, that is the actual name of our medical specialty, the board certification in that specialty. And this can be very confusing to patients and families, and frankly to clinicians, medical professionals alike. And so this milieu of all these different terms can get confusing. Regardless of what you want to call us, we're going to be providing very similar services and providing to your care, regardless of the institution we find ourselves at. Some practical definitions from some of our societies. So I'll read this, but palliative care is specialized medical care for people living with a serious illness. It's focused on providing relief from the symptoms and stress of the illness. The goal is to improve quality of life for both the patient and the family. Palliative care focuses on improving a patient's quality of life by managing pain and other distressing symptoms in a serious illness. Palliative care should be provided along with other medical treatments, and I tend to agree. My take on this is it's really patient and family-centered care, optimizing quality of life by addressing all of these different domains that were just alluded to a moment ago for folks with serious illnesses like cancer. Where I work at a cancer institute. We're taking care strictly of patients and families who are dealing with cancer. However, palliative care physicians work in many, many different diseases, helping folks with many different issues. The thing that's a bit more unique about palliative care in particular is that care is provided by the interdisciplinary team. This really is at the heart of what we do. And this is just, I've left off so many people, here, but physicians, nurse practitioners, physician assistants, nurses, you see all these people, some of the integrative medicine folks with yoga, massage therapy, acupuncture, et cetera. All of this to address mind, body, and spirit, again, which was just alluded to. I thought that was fantastic. So what services can you expect a palliative care team to bring to your care? What do you do? So I created this graphic, and I'm going to just kind of click through a couple of these. And forgive me for the last one, but this is not entirely all-encompassing, but just a graphic that I made up to try to demonstrate, at least in my practice and folks that I take care of, the different things that we might be addressing, not necessarily in a single visit, but longitudinally. And the thing that I think I'll highlight about this in particular is that it's important to recognize that we're dealing with really expertise in medical management, medication management. For instance, I might have a patient who comes to see me who's complaining of severe pain. We've talked a little bit about pain in the last hour. And that patient says, doc, this medication's not helping me, it doesn't work. And I say, well, okay, let's tease that out a little bit. You take the medication, 45, 60 minutes later, tell me, how do you feel? I say, well, I feel better, but it doesn't last long enough. 2-3 hours later, I'm really hurting again. It's not lasting me long enough. So these are the kind of questions that we really tease out in a visit to understand how can we adjust medications, how can we adjust what we're doing for that person. Another example might be I have side effects from this medication. It's very easy for us to fall into the trap of thinking that all side effects are negative. The term side effect, the phrase side effect, I think carries a negative connotation with it. However, we have opportunities to take advantage of side effects. Maybe a medication causes you sedation. Okay, let's take it at bedtime. Why do we need to take it in the morning? Maybe we can take it in the evening time, get the benefit from that medicine. If it makes us a little sleepy, helps us get some rest, that's important. So there are a lot of ways to kind of optimize your care. So some other things that we'll focus on, pain and symptom management is a big part of what I do, a big part of what most palliative care physicians do. We help patients and families understand their illness, also help the healthcare team understand how illness is affecting patients and family. We're able to address the goals of that patient and family, the benefits and burdens of treatments, shared decision-making. We've talked a lot about shared decision-making. We'll talk about that a little bit more in a few slides. We can talk about advanced directives and code status, right? Honoring your wishes. What are the things that you would or would not want done if you were unable to tell us? And there's a great opportunity for palliative care teams to be involved in coordination of care. Very, very high-level communication between medical oncologists, radiation oncologists, all the different people involved in the care of that patient. We can help with the transition to hospice if and when cancer-directed treatments are no longer an option or are no longer being helpful. And I want to just take a few moments to talk about palliative care and hospice, because I think a lot of people, when they hear the term palliative care, their mind immediately goes to hospice. And I put up in that graph earlier, hospice is but a part of what we do as clinicians. And so palliative care does not equal hospice. And again, people hear the term palliative care, they think it means hospice. In most situations, this simply is not the case. A referral to a palliative care physician, to a palliative care team, does not mean that that person is dying. Importantly, myself as a palliative care physician, we really are the experts. We have the additional training to best take care of folks who are receiving hospice care, which I just want to make a point that hospice is some of the most aggressive medical care that one could consider. What other type of care comes to you in your home with a team of people who are talking constantly about you, how to best make you feel the best that you can, right? So these really are intensive medical therapies. And one more slide, just a little bit more about hospice. It's a model for quality, compassionate care for people who are facing sometimes, life-limiting illnesses. And again, aggressive medical management, typically at home, but sometimes in a hospice facility. And a shift of focus away from maybe what's become burdensome disease-specific treatments, focusing more on treatments that are explicitly directed at improving quality of life. And again, that care is provided by an interdisciplinary team. Provide emotional and spiritual support tailored to the patient and family's needs. And importantly, that care is available to all persons covered under Medicare, Medicaid, private insurance. There's charity care for those who do not have any of those. But this is a practical concern that a lot of patients and families ask about. They worry about the cost, but that is 100% covered under the hospice benefit. So the third W, when do I need you? This has been studied. This is a really interesting question. Again, I think you'll hear me say the earlier the better. One of the limiting factors there is that there's not enough palliative care physicians in the United States today to really provide that subspecialty level care. Last I checked, there was close to about 9,000 of us in the United States. And that's simply not enough. So one of our missions has been focused on sharing that training, sharing that knowledge with lots of different folks, primary care physicians, medical oncologists, radiation oncologists, other clinicians, to provide some of this care and then refer to a palliative care doctor, at some point when maybe symptom burden becomes more. I put up this clip from the Tamil study, which a lot of the folks in the audience may be aware of. At this point, this is 12 years old, which is pretty remarkable considering, to me, it feels just like yesterday that this came out. But what this looked at, this was not in folks with kidney cancer. This was in patients with lung cancer. But the thing that got everybody's attention is there were 151 patients with advanced non-small cell lung cancer, and they were randomized into two groups. One group received standard of care in terms of their cancer-directed treatments, and the other group received that same standard of care, cancer-directed treatments, and also had immediate referral to palliative care. And what they were looking at in this study was actually patient-reported outcomes in terms of quality of life, which they did find a meaningful improvement in quality of life and less symptoms of depression in patients. However, one of the secondary analyses was pretty interesting in that it actually showed that the cohort who were referred to palliative care early actually lived longer, which was very surprising to a lot of people. And I think this kind of got the attention of a lot of folks to think, is this model applicable to other solid tumor types, which really hasn't been demonstrated yet at this point, but definitely got increased interest for referring folks to see palliative care teams. This is just a cartoon to demonstrate kind of what we could call as the old model, so to speak, where you see there's disease-directed treatments which account for 100% of the treatments that patient might be receiving. And that might represent missed opportunities for more aggressive symptom management. And then at some point down the road, so to speak, there's a referral to palliative care. Unfortunately, maybe when that person is really having a high symptom burden, really struggling, perhaps maybe very much near the end of their life, and then that results in a very quick referral to hospice care. The kind of new school model, if you will, is more concurrent early referral to palliative care. So you see all the way to the left, 100% of the care that person is receiving might be disease-directed treatments, cancer-directed treatments, maybe a palliative care physician's involved, but to a small degree, maybe seeing the patient fairly infrequently, maybe the patient has a very low symptom burden. And with time, the role of the palliative care physician may become more substantial, more significant in terms of co-management with the medical oncologist and the other clinicians involved in that person's care. And then you see here at the point where, say, additional disease-directed treatments are no longer being helpful or are felt to, to be causing more harm than good. That can result in a bit of a more early referral, say, to hospice, really with an aggressive focus on quality of life. And then the additional benefit of that hospice referral that I did not mention is 13 months of bereavement support for family, which I think is often overlooked, but can be immensely helpful to families. I want to share just some personal viewpoints. When I meet a patient for the first time, I'm really lucky. One of the reasons I love doing what I do is I get to spend a lot of time with patients and families. A new patient visit, I'm going to be in the room with the patient for an hour, sometimes, an hour 15, and follow-up visits 30 to 45 minutes, and we really do take all that time. But when I first meet patients and families, I explain, I've already done my homework, I've already looked at your scans, I've looked at, the medical oncologist notes, I've done all the doctor things, so to speak. Now we just get to sit down and take an opportunity to talk about how can I best help you? How can I make you feel the best that you can possibly feel? All with the goal of maintaining function, allowing you to best tolerate all of the cancer-directed treatments that you're receiving. That really is one of our major goals. So just I guess a couple of quotes that I'm, I don't know if famous or infamous is the word, right? But things that I often say to patients is, one of our goals is to stay out of crisis mode. I know that this can feel like an emergency right now, but I promise we have a moment to take a breath and figure out how do we develop a plan? What is going to be the plan we develop together to address your concerns today? I mentioned improving, maintaining function so that that person can best tolerate those cancer-directed treatments. And I put together this cartoon just using pain as a prototypical example, a very common example of what we might be helping somebody manage in the office. And the way I put it to folks is when you have pain, you're probably not sleeping well. If you're not sleeping well, you're fatigued during the daytime. If you're fatigued during the daytime, your mood suffers, you have decreased appetite, you're losing weight and muscle mass, you develop weakness, you become more immobile, which leads to more pain. And you see this vicious cycle, and really one of my primary tasks, whether it be with a medication or otherwise, is to break one of these arrows. How can we kind of insert ourselves into the situation to break that cycle to allow that person to be more functional, tolerate treatments that much better? When it comes to early referrals, some personal viewpoints, we're all built differently. I'm famous for saying that. If we take all of us here in this room today and we trialed a medication for X, Y, or Z, 30% of us might have a good result, 30% of us might have bad side effects that are prohibitive. A third of us might have really no benefit. We might be somewhere in the middle. So everybody's built differently. Everything is a trial, right? Sometimes we need to try something, see you back in the office in 3-4 weeks in short order, and touch base, see how we're doing. And it's about trajectory. I often tell people that there are going to be setbacks. Unfortunately, there are always going to be setbacks on this journey. How can we, while we're feeling well, take 2, 3, 4 steps forward so that inevitably when there's that setback and we take a step backwards, we're still a net 3 steps forward? And a lot of people say that makes perfect sense. I tell people famously, you're driving the bus. I'm sitting in the back seat. I might say, get off on this exit. And they might say, okay. Or they might say, no, that's okay. I want to keep going down this road a little longer. We can always jump off on the next exit. We're going to get to where we're going together. Really, this is at the heart of shared decision making. You've been living in your body for X number of years. You know it far better than I could ever hope to, which leads to, what do you think we should do? And I swear, I think people, when they hear me ask this question, they just sit up in their chair and think, oh my gosh, how often have I been asked this? at a doctor's visit, right? But I really feel that that's a powerful question. And some people say, Doc, I'm really not sure. What do you think? That's why I'm coming to you. And I say, that's a fair statement. This is what I think. But I enjoy practicing medicine because the person we're taking care of already knows the right thing to do. They're trying to tell us. All we have to do is listen. And I'm a firm believer in that. So I often ask patients, what do you think we should do? And that really is the question that's at the heart of shared decision making. So again, trying to answer this perhaps impossible to answer question, when do you need me? If you're not sure, ask. Ask your medical oncologist, ask your doctors, do you think it would benefit me to see palliative care? See where that conversation goes. I think that's a fair question to ask. Some medical oncologists feel more comfortable than others with pain and symptom management. Others, prefer to refer earlier to a specialist. So I think ask those questions. If you have uncontrolled symptoms and you want additional suggestions, perhaps seeking a visit with a palliative care physician for an opinion on that could be helpful. If you're worried about next steps, right? We've talked a lot about hope today. Hope for the best, plan for the rest. I tell patients I'm always hopeful and I'm always worried. And hope and worry can coexist. And I think ideally they do, right? We're gonna hope together for a good outcome. We're gonna hope for this. And if that doesn't happen, can we talk about what is that next step gonna be? How are we gonna move forward together? If you're considering discontinuing cancer-directed treatments, or if there are no additional cancer-directed treatment options. And by the way, that's very intentional that I keep saying that, cancer-directed treatments, because you'll never hear me say we're stopping treatment. Frankly, it doesn't happen. We don't stop treatment. It's simply that those treatments may change in terms of their focus. Less focus on directly treating cancer, more focus on treating symptoms aggressively, improving quality of life, living as long as you can, as well as you can. And frankly, I've yet to hear the words, I wish I was sent to you later. Every time I hear the statement, I hear, I wish I was sent to you earlier. I don't want to read too much into that, but I guess the point is, if this is something that you're considering or you think may be beneficial to your care, get that opinion. Palliative medicine teams are here for you to, again, be part of your care, allow you to tolerate these treatments and do the best you can with regard to your cancer treatment. And if that becomes prohibitive, allowing that person to have the best quality of life possible. So that's really all I have for you today. Again, I'll say thank you so much for having me. Really appreciate your attention, and I'm happy to take any questions. Thank you.
Dr. Murphy, the slide that all the symptoms, from big to small, I think I count them all, and probably have 99% of that, at any given time. And when I look at the various options, from yoga to opioids, one option that I would seen in the list is the use of cannabinoids. What is your position? What are your thoughts about that?
I get asked about medical cannabis very, very frequently. Cannabis is interesting in that we know very little about it. We're not able to study cannabis in a meaningful way because it's still considered a Schedule I drug as far as the DEA is concerned. That's, of course, recognizing that there's no medicinal use for it. That being said, there are synthetic cannabis medicines that are on the market. There are two that are targeted at, interestingly enough, pediatric seizure syndromes called Dravet syndrome and Lennox-Gastaut syndrome. In many states, of course, I'm not sure about Georgia, where we are today, but in Florida, where I practice, medical cannabis is recognized. You can get a card and procure it. The two molecules that we think are most implicated in pain and symptom management are THC and CBD. THC, we think, being a bit more helpful for nausea, for appetite stimulation. CBD perhaps being more helpful for pain, especially nerve type pains. I tell my patients, I treat cannabis like I treat as it should be treated, in my view, as a medication. And I treat it just like I would any other medicine. Meaning, if it's being helpful, that's great. Let's use it. And just, make sure everybody's aware of it, that you're utilizing that, because that's, there can be drug-drug interactions between cannabis and prescribed medicines. But if it's not being helpful, well, we should discontinue it. It wouldn't make sense for me to give somebody a blood pressure medicine or something like that if it wasn't helping their blood pressure. So that's my overall take. I have a lot of patients who use it, and I just say, make sure that everybody's aware that you're using this, and if it's helpful, great. If it's not, discontinue it. Did that answer your question?
Yes.
Great. Yeah.
I have a question. So at one point in time in your presentation, talk about standard of care in palliative medicine. And I'm in the school that thought it was the end of life. So now that I've learned that it's not, I guess my question is, why isn't it a standard of care?
I think it's challenging because, number one, from a numbers perspective, we're limited in terms of the number of clinicians that have this training. And that frankly feel comfortable dealing with a lot of these medications. We deal with a lot of controlled substances. I think that's a bit limiting in terms of its widespread availability. I also think that disseminating that message that palliative care does not equal hospice. I mean, there are many clinicians, frankly, who think, well, I'm not going to refer this patient to palliative care because, they're not ready for that. We're not at that point. We're not at that stage yet. Which, I love nothing more than somebody coming to see me, and they might not necessarily need a whole lot from me, right? They're being referred over to me early in their course, or maybe they were diagnosed recently, and we might make some tweaks to their medicines or provide some counseling, but that person might follow up with me as needed. So I think it's a numbers concern. And also just, again, disseminating that message of who we are and how we can best help patients and families. Great, well, thank you again. Appreciate it.
Okay, today I would truly like to thank you for uplifting me. I've met so many beautiful people here, caretakers, patients, and heard incredible stories about your journeys. The doctors that give their time and their soul, as you know, Dr. Mashan here flew in last night, was here this morning, flew back to see his patients. The caring and the giving, it really gave me strength. I hope today that we gave you hope and optimism and inspiration. That was our goal. I hope that we did that. It is all about information, caring, and sharing. Please go to our website. As Jayla said, Dr. Pili has great information on nutrition that we were unable to lock his information to upload it today, but it will be on our website in the next couple of days. Join our support group. Join a support group of any kind for both patients and caregivers. Like we've heard, we are physical and mental and spiritual. We need all help. That being said, I know it's been a very long day, but we will still have our breakout sessions for patients and caregivers. If you can do that and have the strength and stamina and aren't catching a plane or going someplace, it will be in the rooms to the right of here. And if you need a parking pass, we have them. Also, if you filled out your survey, please put them in on the front table. The only way to learn is through you. I know we weren't great time managers today, and I'm sorry about that, but we wanted to get it all in. So thank you for joining us today, and I truly appreciate you. And Judy Nicholson Kidney Cancer Foundation really cares about you also. It's all about you. Thank you so much.